Today's date is May 12th, 2014, and the time is approximately 10:14 a.m., and we are on the record. Would the court reporter please swear in the witness?
Raise your right hand, please. You swear or affirm the testimony you give will be the truth, whole truth, and nothing but the truth, so help you God?
I do.
Thank you.
Dr. Nasser, would you state and spell your full name, please, sir?
My name?
Yes, sir.
My name is Gabriel. Middle initial is F. Last name is Nasser, Nassar.
All right. And how are you employed currently?
Currently, I'm employed with Life Cycle
Yes, sir.
and Morehouse School of Medicine.
All right. And what is your role at Life Cycle?
I see patients for Life Cycle
Yes, sir.
and do surgery for the patient.
All right. And how long have you seen patients for Life Cycle?
I moved into Life Cycle in April of 2011, and on January 2012, I became an employee there.
Okay. So from April 2011 until January 2012, you were sharing space
Yes.
with Life Cycle? All right. And then in January 2012, you became employed by Life Cycle
Right.
as an OBGYN?
Yeah.
Yes, sir. And where are you credentialed currently?
You want me to start from the beginning?
No, currently. Where are you credentialed currently?
Yeah, I'm a board-certified obstetrician-gynecologist
Yes, sir.
since 1970. I was recertified voluntarily in 1981. I'm a fully trained OBGYN, and I did a pelvic surgery fellowship, all with Emory University.
Yes, sir.
I am an assistant professor in obstetrics and gynecology at Morehouse School of Medicine, and I've been since 2007 officially.
Yes, sir. And you were credentialed at Southfield Medical Center in 2012? Isn't that true?
Yes, right now I've been re-credentialed with AMC again. Every 2 years they do that.
And by AMC, you mean Atlanta Medical Center?
Right.
Yes, sir. When were you first credentialed at South Fulton Medical Center?
1970.
All right. And you were continuously re-credentialed until they closed the labor and delivery unit there?
Yes, until they became AMC.
All right. It's my understanding they moved the labor and delivery unit from South Fulton Medical Center up to another tenant hospital, Atlanta Medical Center.
Object to the form.
Is that your understanding?
Object to the
Yes,
form.
I understand your question, but I don't think that happened.
Okay. Tell me what your understanding is.
What I understand is they plainly closed the OB service, period.
Yes, sir.
They didn't move anything. The only move there were the practitioners that wanted to go downtown. They had privileges too.
By practitioners, you mean the people?
Yeah, the doctors.
Okay. And nurses and
Object to the
medical
form.
assistants? Yes?
Object to the
Yeah,
form.
not all the personnel that was at South Fulton Hospital actually transferred to AMC downtown.
Okay. Some transferred, some did not. Is that your
Some
understanding?
rats went somewhere else.
Some transferred, some did not. Is that your understanding?
That's, yeah, I mean, it was their choice whether they wanted to or not.
And what's your understanding about why the OB service or the labor and delivery service closed at Southfield Medical Center?
Well, I sincerely don't know the 100% reasons behind this. I was not in the administration at that time. I was just occasional practitioner there. I did a lot of surgery there, but my obstetrical practice was about 10 deliveries a month. It wasn't very heavy then. And as I say, I was not involved in any of the discussions of the board or anything as to know the reality of why was the hospital closing that. It was told to us that they were losing money on the department. And that was just about a year before they closed the service. Then I was on vacation when one of my daughters called me and told me that the hospital has called and said that the date for the OB department to close was, I think it was something like August 15 or something. I'm not sure of that date.
Do you know what year?
No, but it was the year it closed, probably 2013, 2012.
And I appreciate you telling me what you were told. What's your understanding about why it
Object to the form.
closed?
Join.
I don't really know, to be honest with you. If I was to tell you any information, it will not be reliable. Because
You don't have to guess, you just have to say what you know.
No, I'm not. I wasn't the chief of the department. I was not in management of the department whatsoever. I was very critical, but not involved.
All right. What reasons did other people share with you other than the department was losing money about the reason for the closing?
Well, you know, in medicine nowadays, it's very hard to get good nurses,
Yes, sir.
especially in obstetrics.
All right.
And there was a continuous complaint of the quality of nursing that was seen. And because not as much as the quality of knowledge of the nurses, but as much as these visiting type of nurses, you know, flying nurses, they come and stay 2-3 days, a week. Sometimes they stay temporary help,
Yes, sir.
not permanent help. When the hospital announced that they were going to close the department, we lost the best nurses automatically. They just went to Northside and different other hospitals.
Yes, sir.
And some of them even changed departments just to the ones that thought was convenient to stay in the area because they live close or whatever.
Yes, sir.
And that's as much as I can say was how we felt
Yes, sir.
as caregivers.
I'm sorry, that last part.
Caregivers.
Yes, sir. So it was your understanding that there was an issue with the quality of the nurses there in labor and delivery at Southfield Medical Center.
Object to the
Object to the
form,
form.
mistakes
Object to
of
the form.
testimony.
You may answer.
There was a lot of talk about
Yes, sir.
whether the problem was seen by administration in that way or not. I don't know.
Okay. But you saw the problem.
Check the form.
Same objection.
I felt like,
Yes, sir.
yes.
All right. And one of the problems that you saw was I think you called them the visiting or flying nurses. You had nurses that were coming and going. Is that right?
Yes, that's one thing. When you don't have continuity,
Yes, sir.
you lose part of the quality there.
So lack of continuity would have been another issue that you felt like.
Yeah, that's the same thing. You know, when
Yes,
I
sir.
said that, I included the performances.
All right. And you mentioned, while you weren't the chief of the department at the time, you felt like it was your place to voice your complaints regarding issues there at labor and delivery. And tell me what you recall about some of the complaints that you had about the labor and delivery service there at Southfield Medical Center.
I'm sorry. Well, South Fulton Hospital was one of the best 100 hospitals in the country.
Yes, sir.
So what I recall of the hospital is a top-notch hospital.
Yes, sir.
And I would like to continue to think in that way about that hospital after spending my life in that hospital.
Yes, sir.
With the problems that occur in the area,
Labor and delivery area.
no, I'm talking about the geographical area where
Yes,
the
sir.
hospital was located, and where the many changes occurring socially as well as economically.
Yes, sir.
And naturally, the population changed, and patients changed, reimbursement changed, everything changed
Yes, sir.
in medicine in 40 years. So then the changes were noticeable to anybody,
Yes, sir.
whether it was in the medical field or not. And so doctors began to leave the area. Administrations were tying up. We were losing most of the doctors that left. It wasn't because there was not work or they were not good. They were excellent physicians. But they left because the administration wouldn't do things they wanted to.
Like what?
Like you wanted some equipment, you have to buy it. You know, they say, we can't get that equipment, it's expensive, and only one or two of you are going to be using it, so forth. It all depends on who was the administrator, and it changed a lot. And then the hospital went bankrupt, and that was coup de grace
Right.
for the whole thing. And then Tenet purchased the hospital after 2 or 3 years that the hospital was floating in the air with no owners.
Yes, sir.
And when Tenet purchased the hospital, Tenet actually did a lot of good in the beginning. I'm sorry. I'm having a lot of backache for 2 days.
Can you take a break?
No, that's fine. We're going to take a break. I have to go home. Tenet sent an administrator, which was a physician, pediatrician by himself, and specialized in medical management. Excellent man, which later on was stolen by Grady, and later on was stolen by Jackson Memorial in Miami. And so the guy was super. He really put back together the hospital, attracted physicians, and the whole thing began to spur.
Right.
When he left, another administrator came in, which was not so good and at all in comparison with the first guy, and also a lot of funny things happened there with administration.
Like what?
Like, for example, I was then in the executive committee, and
Dr.
We're
Nasser,
gonna-
I'm going to caution you on behalf of the hospital, if it involves peer review, you can't discuss it.
One, if you have an objection, you need to make it.
I've
You
just
don't
noted-
represent Dr. Nasser. Go
I
ahead,
do
Dr.
represent
Nasser,
the
you may answer.
hospital, and the hospital peer review is sacrosanct, so
You can't talk about peer review. That's privileged information. So
Yeah, I can't
anything
do
to
that.
do with privileged information, you cannot
okay.
talk about.
Well, then, I can't talk.
Well, no, were you talking about peer review, an assembled peer review committee of a doctor? Is that what you're about to
This
talk
is
about?
covered by the law because it was an enclosed meeting, and it was a privileged information.
We'll close meeting about what?
I'm going to object to the form of the question. It calls for
Join.
peer review protected
If
information.
I tell you about what, I'm telling you everything.
Right.
Well, then, just because it's a closed meeting doesn't mean it's peer review protected, unless you were peer reviewing one of your peers, another physician.
I'm going to object to the characterization of the state of Georgia law on peer review, but even as to whether a peer review meeting occurred is protected information under Georgia law.
You may
And it'll be
answer.
up to the court to decide whether it's peer review.
Join.
That's what I understand, what the lady says there.
If the meeting had to do with peer review, you can't answer it. That's privileged
Yeah, he was
information,
peer
so-
review.
Okay, then we need to move on.
He was peer review to the max.
Okay.
All right. And what happened as a result of that meeting?
Object to the form of the question, calls for privileged and confidential information under Georgia peer review statutes and law.
You may answer.
No,
The
you-
hospital
you-
continued to operate the same way, and then this administrator was switched for another administrator, and then the administrator that followed was the last administrator before the guy that closed OB.
Yes, sir. And what's your understanding about why he closed OB?
I'm going to object to the extent you've already asked that a
I
couple of
need to,
times.
I need to stand up.
You need to-
Sure.
If we need to take a break, we can. You're going to, don't.
All I can tell you is that the
Wait,
decision.
Dr. Nasser, if you need to take, I don't know how this is working on video, but if you
That's fine.
can't answer the question, we should take a break till your back feels better.
You can do him standing up, can't you?
I'm-
Standing is fine, doctor.
Okay. The memo came to us that the hospital was planning to close the department, and they gave a different date to us, different to the one that was used for closure. As I say, I was on vacation because I didn't expect anything to be closed while I was on vacation, and when they called me to notify me that the hospital was going to be closed on the 15th of August or something like that, I'm not 100% sure of that.
Yes, sir.
But it was a few months ahead,
When did you get that memo?
early in the year.
What year?
I would say, what year did the hospital close the department? Do you any here? No?
You're the only one that gets to answer questions today.
Huh?
I said you're the only one that gets to answer questions today.
Oh, well, I don't have the information.
So it had been early in the year that it closed?
Early in the year that it was closed, yes, sir.
And who was that memo from?
The,
Administrator?
uh-huh.
And that was, you mentioned there were 3 administrators. You mentioned the first one who was good. That's okay, you're fine. The first one who was really good that was left, do you remember his name or her name?
This guy from,
Went to Jacksonville, I believe.
yeah, was a guy from Nigeria, but I don't remember exactly his name. Andy was his first name.
Andy?
The second one was Chris.
Only answer the question you're asked,
That's
Dr.
all right.
Nasser. Just answer the question he asks you.
Oh, I'm sorry.
Yeah, no, I want to know, and the second one was Chris. What was his last name? Don't know. Okay. And you remember the third one that closed OB?
James, I think it was.
Do you remember his last name?
Not really. I wasn't good for him.
All right. And you got a memo, would that memo have been from the hospital administrator who, as best as you recall, first name was James, is that right?
Yeah, we asked why, and the reasons that were given to, at least to me,
Yes, sir.
were the ones that I expressed earlier about they were losing money.
Okay. Do you still have a copy of that memo?
Now,
All right. I think you mentioned, in your view, some of the reasons that the South Fulton Medical Center Labor and Delivery Unit closed had to do with a change in the geographical area, true?
Object to the form
Where
of
the
the question.
hospital was.
Join.
I didn't say that was the main reason, no.
Okay. So,
I said that I was describing the changes that occur from the 80s and 90s progressively that affected in general, not only the hospital, but I'm sure all the businesses in the area were affected too.
yes, sir. So the main reasons, you mentioned the issues with the nurses. You also mentioned an issue with equipment where Southwood Medical Center wouldn't supply you with needed equipment. Tell me about that.
Check the
Going to
form.
object to the form, misstates the testimony. You
You
can
may
ask the
answer.
questions, James, but you can't testify for him.
You may answer.
I do microsurgery.
Yes, sir.
And in order to do microsurgery, you require specific equipment to do that. You just don't get a knife in the kitchen and do things like that. So I have to spend over $20,000 in equipment. I still have the equipment. That's an example.
Yes, sir.
And that's
Other examples?
other examples.
Yes, sir.
We have to buy a CAT scan before the hospital got a CAT scan. Several doctors put the money together and bought a CAT scan, and then the hospital bought a CAT scan too. EEGs, all kinds of stuff. But that was even before Tenet was in the picture.
Yes, sir.
Tenet has been very good even throughout the administrators that I recall giving us the equipment we needed.
Okay. Since Tenet acquired the hospital, you have all the equipment you need? Is that your testimony?
Yes.
Okay. So the equipment that you recall having to buy yourself because Southwood Medical Center wouldn't purchase it includes microsurgery equipment?
Oh, many of the surgeons have their own instruments
Yes, sir.
because of that. But apparently that was from the days that the hospital opened down the road. The hospital was a very small hospital that grew up fantastically fast in the area and went from 90 beds to 480 beds.
Yes, sir.
480 bed acute bed hospital.
Right.
And so the explosion, I guess, forced the purchases and all that, and they were very picky as to what they bought.
Yes, sir.
If something was to be used by 15 of us, they would buy it. But if it was just by 3 or 4, they said no.
All right. Well, maybe you can help me out. We were talking about why the unit closed. You mentioned some issues with the nurses, the flying nurses, the lack of continuity of care. And then we started talking about equipment. And then you mentioned the equipment issues, the microsurgery, CAT scan, and the EEGs occurred prior to Tenet. And of course, Tenet owned the hospital when labor and delivery closed,
Check the
right?
form.
Object to the form.
You may answer.
Well,
We
wait,
have
wait,
the
wait,
labor-
wait, stop. What's the question?
Go ahead.
No.
Do you understand?
You have to ask him a question. Dr. Nasser, you answer a question when it's posed to you.
Do you understand the question?
The way I understood the question is, did we have the labor and delivery area well-equipped?
Yes, sir.
Tops.
Okay. So after the microsurgery, the CAT scan, the EEG, that was before
That's
Tenet.
way before.
Okay. What about issues with equipment after? Well, what issues regarding equipment contributed to the closure of labor and delivery?
Object to the form of the question.
Not to my knowledge. Not to my knowledge, any equipment had anything to do
With the closure.
with the closing.
All right. Another thing you mentioned, doctors leaving, reimbursement and a change in the the patients.
When the demographics in the area change,
Yes, sir.
naturally, things change. Basically, right now, AMC South, as it's known today, is a hospital. It's a Medicaid, Medicare hospital.
Okay. And what does that mean, that AMC South is a Medicare, Medicaid hospital?
That makes the largest number of patients admitted to the hospital. I know you want me to tell you compare with what?
No, I didn't, largest number of Medicare, Medicaid patients?
Against the days before when there was Delta, Eastern, Southern, bottle factories, preserved bottle factories, all kinds, Nabisco, everybody was private insurance.
Yes, sir.
And that makes a lot of difference.
Okay. Tell me about that. How does that make a lot of difference?
Private insurance always had paid or reimbursed hospitals and physicians and nurses and everything else much better than government operations.
Right.
And so, they keep on actually shaving this cost more and more and more and more, so the hospital have to accommodate.
Yes, sir.
And naturally, we don't have to accommodate. We are accommodated to begin with. We never say no, but that has created a migration of the young. It's not attractive for a young guy that finished residency to come to practice to our area, because they say, you guys don't have what I need to pay my expenses.
Right.
And it's right.
Because they're paid less, because Southfield Medical Center, when the unit was shut down, was a Medicare, Medicaid hospital.
Objective form.
Objective form. Can,
I don't know if it was just Tenet, but I think it affected Southern Regional, Fayette County, everything.
Right. Including Southfield Medical Center.
But of course.
Okay.
I'm sure.
Jackie,
Go ahead.
answer the question when you have a question on the table.
No, I answered it, didn't I?
Yes, sir.
Right.
You were about to say something.
I was going to say something which I shouldn't anyway.
Is it in further response to my question?
No,
Okay.
it was actually a question to you, but
That's fine.
I don't need to do that.
I'll answer anything I can.
No, not important or related to.
Sorry?
I said it wasn't important.
Okay. Let's see. Dr. Nasser, you agreed the placenta is a structure that develops in the uterus during pregnancy.
Of course, I agree.
All right. And that the placenta is there to nourish the growing baby, true?
It is the lung and the heart of the pregnancy.
Yes, sir. Provides oxygenated blood and nourishment to the growing fetus, true?
Correct.
And placenta actually comes from the Greek word for pancake, true? If you know. Is that right?
Yes.
And that the placenta adheres to the wall of the uterus.
the
Right.
inside wall of the uterus.
Yes, true.
True.
And if the placenta peels away from that inner wall of the uterus before delivery, either partially or completely, it's known as a placental abruption. True?
Yes. It's got other names, but yes, that's the most common name.
Yes, sir. What else? What other names do you use for placental abruption?
In England, spoken of accidental hemorrhage,
Yes, sir.
for example. And I guess that comes from the days that it wasn't understood as clear as it is today.
Yes, sir. All right. You agree that a placental abruption can deprive the baby of oxygen and nutrients? True?
Correct.
And cause profuse vaginal bleeding in the mother? True?
Not all abruptios will cause external bleeding,
Yes, sir.
but yes, in general, I agree with the statement.
Right, you can have a placental abruption and a patient can exhibit no bleeding, but a placental abruption can cause profuse vaginal bleeding in the mother. True?
It could.
Placental abruption often happens suddenly. True?
I'm sorry?
I'm sorry. Placental abruption often happens suddenly. True?
Right. From then that's called accidental bleeding. Also.
You agree that left untreated, placental abruption puts both the mother and the baby at risk. True?
Partially true, not completely true.
All right.
Let's say you have a patient that is a multiparous. That means this woman has had several other children before,
Right.
and her labor during abruptio usually move fast, and she's dilated to a point that it will allow you to deliver that baby vaginally within 30 minutes or an hour.
Yes, sir.
You can end up the situation in a non-surgical manner and with good results as to the product.
And by the product, you mean
The baby.
The baby. Yes, sir. All right.
In other cases, we categorize the abruptio placenta according to how's the labor, what's the dilatation, is the cervix favorable or not, etc., to reach a decision. Parity, age of the person, etc.
You're talking about reaching a decision about intervention. True?
Intervention, correct.
And I'm talking about how, without intervention or left untreated, how placental abruption can put both the mother and the baby at risk. Do you agree with that?
It would put her at risk either way you look at it,
Yes, sir.
but the risk can go from 10% to 100%.
All right.
So that makes a great difference when you're taking a risk at level of 30% or taking a risk at 90%.
And what risk are you talking about?
I'm talking theoretically.
Yes, sir.
I'm not talking specifically of any case itself. If I have a patient that is 8 centimeters dilated, he's a gravid of 4, all right? And he's at term, and she's clicking those contractions really nicely.
And by nicely,
I
what do you
know
mean?
that I mean, every 3 to 4 minutes and lasting 40, 50 seconds, I know that I can deliver that patient a lot faster vaginally than I can deliver by cesarean section.
Right.
Okay? So my risk will reduce. Now, this risk also allows me to detach the rest of the placenta that is not detached and stop further bleeding. 1, 2, the products that are caused by the retroplacental hemorrhage, also known as the clot, these products up there can absorb and then make the patient hypocoagulable, which will increase the bleeding. So all those factors interfere with the different risks that you are taking.
Well, those are factors that help you determine how to intervene, whether to deliver the baby vaginally or employ a C-section, right?
That's correct.
Okay. But whatever intervention method you choose as the physician, placental abruption puts both the mother and the baby at risk, true?
Correct.
And that's because that blood that's there, is supposed to be passing from the mother through the placenta into the child, is not going through the placenta into the child, but actually, into the uterus and oftentimes out the vagina, right? Not going where it's supposed to be.
In general, you are correct, because that's the transit. But it depends on how much of the abruptio is affecting this villus legs. And if it is a small abruption, it's not going to affect the baby so much as if it is the largest the abruptio,
Right.
the more affection that can be.
Right.
But blood continues and oxygen continues to pass on through the non-affected area of the placenta.
Correct. You wouldn't expect to see profuse vaginal bleeding with a minimal placental abruption. True?
Yes. It's not a commensurate effect. Bleeding and pain are not commensurable to the severity of the cause, okay? Sometimes bleeding is an exaggerated amount through a very small situation, small laceration, small detachment, or very little to a very large defect in there. So there is not a measurable amount of bleeding that will tell us the severity. Naturally, one is accustomed to think the more the worse.
There's not necessarily a direct correlation, but you still look for a constellation of signs and symptoms when you're diagnosing a placental abruption. True?
That is correct. There should be no vaginal bleeding in a normal pregnancy. Correct?
Correct. Now, if you agree that as an OBGYN physician, you must suspect placental abruption when a patient is 36 weeks, 3 days gestation and presents with profuse vaginal bleeding and severe abdominal pain, 10 out of 10. True?
Those are symptoms, yeah.
All right. Additional risk factors for placental abruption also include chronic hypertension. True? Yes.
Yes.
They also include patient who's an insulin-dependent diabetic. True?
Yes.
They also include polyhydramnios.
Yes.
True? They also include large myoma. True?
True.
Especially when the leiomyoma is near the implant site. True?
True.
In addition to the signs and symptoms, profuse vaginal bleeding and severe abdominal pain, back pain, uterine tenderness, and rapid uterine contractions are also signs and symptoms of placental abruption. True?
Tetany is tetany.
Yes,
That's
sir.
when the uterus contracts and won't relax.
Yes,
It's
sir.
classical for abruptio.
Yes, sir.
Okay? But if, I don't know if I should get into this, you're not asking me this. In general, you are correct, yes.
Well, if it helps you explain your answer, I mean, I'd like that explanation. I'm entitled to that
All right.
explanation.
how do you assess the quality of the contraction of a uterus? That will be the theme. The uterus normally should contract between 2 and 3 minutes apart, lasting approximately 50 to 60 seconds duration,
Yes.
after which this contraction will disappear and the uterus becomes soft and until the next contraction occurs. And that rhythm is what creates labor.
Yes, sir.
And then when we have X parameter of number of contractions and how frequent they come in, then we expect them to produce changes in the cervix,
Yes, sir.
which by X standards, we will say this patient is in labor.
Yes, sir.
Now, when a uterus contracts and does not relax, remember one thing, that the muscle of the uterus is created specifically to become a hemostatic effect when the uterus fibers contract. The blood vessels in the muscle are spread in a vertical manner that when the uterus contracts, then it cuts the circulation, all right? By cutting the circulation, then there is no flow in it. And that naturally will produce the changes of no flow, anoxia, etc. Now,
No flow to the fetus.
that's the damage of the abruptio more than anything else, is because it's cutting the oxygen and the blood flow to the placenta or to the exchange area. Anyways, that should answer your question.
Yes, sir. Now, you said you're talking about contractions 2 to 3 minutes apart. You agree that contractions of 3 minutes or less, coupled with profuse vaginal bleeding and severe abdominal pain, 10 out of 10, are signs and symptoms of placental abruption, true?
You cannot exclude placental abruptio, but it's not the only cause that can produce vaginal bleeding on a person in labor.
Well, but you have to suspect placental abruption in that case,
Definitely.
true?
It's the number one on the list.
And, right, in addition to being the number one on the list, I mean, I'd like for you to give me all your differential diagnoses for a patient who's 36 weeks, 3 days gestation, and presents with profuse vaginal bleeding, severe abdominal pain, 10 out of 10. What are the differentials? I know you said placental abruption would be number one. What else is there?
Rupture marginal sinus will be the other one. There will be no placenta previa in that, even though it can occur with contractions and labor. But
Right.
placenta previa is usually painless bleeding.
Right. And so that would, if it's pain 10
A
out of
ruptured
10, you would rule that
uterus.
out, right?
Huh?
If pain 10 out of 10, you would rule that out, right? And
10 out of 10, really, to be honest with you, it depends on the assessor. Who's assessing the pain?
Yes, sir.
Pain is assessed. We came up with a modern way of
Right.
assessing pain with a chart,
yes, sir.
okay? And so pain is something that comes out of the person that is complaining of the pain.
Yes, sir.
So it is a way how you interpret. And also it has to do with the threshold that a person has for pain. There's people that can take a lot of pain before they actually complain of pain. So it's a very subjective evaluation of pain. Now, I noticed that 10 over 10 is the classical way that the chart will read the max pain. That's not my impression. The patient denied to me of having severe pain.
You're talking about Miss Bohannon.
Yes.
All right.
because I classically, the first thing I do is ask the patient directly. And I also examined the patient when I got to the hospital, and the uterus was relaxing in between contractions.
Yes, sir.
So I knew there was an abruptio. I
You knew
didn't
there was
expect
an
it to be a
abruptio.
massive abruptio.
Yes, sir.
I'm sorry, I couldn't understand the answer.
So you knew there was an abruptio, true?
Pretty much. And also, when I examined her, she was not the dilatation that the nurse had quoted me on the telephone.
All right.
So that put together, I said, this is not going to deliver on her first real pregnancy.
Right.
She was not going to deliver vaginally.
All right. So you knew you had to do a C-section.
I pretty much suspected that I needed to do a C-section when I talked to the nurse on the telephone.
Right. That was at, what, 1:15 in the morning?
Mm-hmm.
Yes.
I
Yes.
told her, get the operating
Well,
room
first we
ready.
have to get, yeah, the, it's very difficult for the court reporter. I know we all do, but
Oh, I'm sorry.
that's all right. You're fine.
My
You're
fault. Lack of experience, to be honest with you.
fine. Which is a good thing. I believe, I'm sorry, Steve, do you mind reading back that?
Listen to the question and answer the question that's asked. We're kind of getting off track, and it gets a little confusing if you're answering something that wasn't asked sometimes.
I'm doing that a lot.
You said that
You're
was,
fine.
what, 1:15 in the morning?
Yeah, that was 1:15 in the morning?
1:15 in the morning, she
Yes.
called me to report the admission of the patient. And I said something about that. I told her, get the OR ready, I'm en route.
All right. You knew then it was a placental
Most
abruption,
likely.
true? Yes.
Because I knew Ms. Bohannon well.
Okay. Would you know if she walked in here today? Would you?
Most likely, yes.
All right. You agree that vaginal bleeding is a sign or a symptom? True.
Both.
I guess if you see it, it's a sign. If somebody tells you about it, it's a symptom. True?
Symptom is something that you feel,
Okay.
okay, and emanates from you.
Yes, sir?
And a sign is what I find, or I can see, or a person sitting next to me will see it too.
Yes, sir. All right.
You might be aware of, and then it becomes a symptom. You say, I'm bleeding,
Right.
all right? So you look at it, and it's got a sign and symptom there.
Right. So vaginal bleeding can be both a sign and a symptom. True?
Correct.
The vaginal bleeding is not a medical diagnosis. True?
No.
As a physician, if you see or suspect vaginal bleeding, that would be a sign or symptom that would indicate you needed to diagnose the cause of the vaginal bleeding. True?
Right, this is, and sometimes we don't even know where the blood is coming from, and that's what we diagnosed as vaginal bleeding of unknown etiology, which is not very common nowadays with all the testing that we have available.
Right.
Can occur.
You agree that when, as a physician, you suspect placental abruption, you must not delay delivery. True?
Right. Excuse me.
Sure.
Are you going to ask me all this? Because you only been 2 pages. I don't think I can take this
I
that
think
long.
my outline is, it's a little bit longer, but sometimes we cover stuff as we go along that I won't be covering a second time. 22 pages, that's not too bad. This is a hospital record. A couple of things in here, a couple of records, some of your records, a little of your credentialing file. That's it. We're
Sure.
gonna cover some of that stuff. You need to take a break?
Yeah, do you want to walk around?
No,
for a minute?
let's keep going. Huh? It is really, it's certain position, and when I get kind of exciting, muscles contract and make me see the devil.
Well, I'm not doing anything to excite you.
Yeah, I know. That's exactly what I asked. How long is it going to be before we get to the exciting part?
Before the what, I'm sorry? The exciting part? What do you consider the exciting part?
You said this is not exciting yet.
No, okay. You're a board-certified OBGYN, true?
Yes,
That's an obstetrician and gynecologist, I believe, true?
that's correct.
You're not an anesthesiologist, true?
Not at all.
You're not board-certified in anesthesiology,
No,
true?
sir.
You don't have privileges in anesthesiology, true?
I do certain parts only, locals.
Oh,
I
right.
can do paracervical blocks, I can do pudendal blocks, but today, no. We
Right.
don't have the privileges that to do anesthesia in general.
Well, and the same, and let's see. And,
The answer is no to anesthesia.
okay. And when you cared for Miss Bohannon, you didn't have privileges in anesthesia, true?
That's correct.
I mean, you couldn't give a spinal epidural, true?
They wouldn't let me.
Okay. Even if you'd wanted to, you would not have been permitted to do that for Miss Bohannon, true?
No,
Okay. Same thing for a general anesthesia. You would not have been permitted to put Miss Bohannon to sleep, even if you'd wanted to, true?
I will not be expected to do that kind of work,
Right. That you would defer to the anesthesiologist to do.
especially when you have one.
Yes, sir. And you don't advise anesthesiologists on anesthesia, true?
No,
In fact, it's
they
just the
don't
opposite.
advise me in obstetrics either.
Right. They advise you on anesthesia, true?
They should.
Yes. And if you have a placental abruption and you need to get a baby out, and it's an emergency situation, you expect that patient to be ready for you to proceed as quickly as possible, true?
That's correct.
Object to the form.
And you would expect the anesthesiologist to choose the correct method of anesthesia to get that patient ready as quickly as possible, true?
Object to the form.
I expect him to do his part, I do my part.
Yes, sir. And you agree that you put patients to sleep or you get them ready for surgery much faster using a general anesthetic than an epidural, true?
Yeah.
Object to the form.
Okay.
He just testified he wasn't qualified to give opinions about anesthesiology.
You may answer if you know, and if you don't know,
And
that's
if there
fine.
was an answer, it was covered up.
He said not necessarily.
I'm not an expert
Okay,
on that
okay, thank you.
subject.
Okay.
When
But-
I was in the Army, I was, but not now.
All right.
A long time ago.
Yeah.
And when you, so when you have an emergency C-section to do and you're there at the hospital, as soon as that patient's ready for you to perform that C-section, you perform it, true?
That's right.
And that's what you did here with Miss Bohannon, true?
Pretty much.
You're also not a neonatologist, true? You're not a neonatologist, true?
No,
You don't work in a NICU, true?
no,
Never worked in a NICU, true?
never,
Not board certified in neonatology, true?
no,
Don't care for patients, don't care for babies after you deliver them, true?
no, sir.
At that point, it's up to NICU and the neonatologist and their team, true?
That is correct.
Do you ever intubate babies after they're born?
You say ever? Yes, I have.
Okay. Is that common?
No,
Okay.
it's
And
not.
You would do that when? If there was no,
When there's no one or baby needs to
Okay.
be intubated, yes, I'm capable of doing it, and I've done it.
yes, sir?
But if today, it's not a needed skill to have.
Okay. And in 2011, if you delivered a baby and that baby needed to be intubated, that would be up to the neonatologist and the NICU team, true?
That is correct.
And you don't administer epinephrine to neonates, newborn babies, true?
Nothing after baby's out, I don't do anything to a baby.
All right.
Not even change a diaper.
All right. That's up to the The
the
neonatologist.
NICU people.
And the NICU people, right. Yes,
That is correct,
thank
yeah.
you. So we covered a whole half of the page.
Great.
Sir?
Great.
Talk with you briefly about your background. In 2011, you were privileged at South Fulton Medical Center. Anywhere else?
Grady Memorial Hospital?
Yes, sir. Anywhere else?
No,
And where are you privileged today?
same places.
South Fulton Medical Center and Grady. Do you do any work at South Fulton Medical Center now with the labor and
That's
delivery?
AMC South, that is correct.
Okay. So labor and delivery is reopened there now?
No.
Okay. Tell me what,
They're gonna have to open it sooner or later, I think,
okay,
because they lost a lot of patients.
okay.
I
So-
mean,
Wait
Go
for a
ahead.
question.
I started, I have to finish this. In the women care, it is very known that the family goes to a place where the wife or the female person in the household says goes.
Got it.
And a woman has her likes and dislikes, how things look alike. It don't matter if the care is good, it's how it looks. That's
Right.
number one thing. And the hospitals spend millions of dollars making things look homey and nice.
Wow.
That. So by cutting or closing labor and delivery, and you talk to a patient I'm going to take you to AMC South for just a minor operation, a diagnostic laparoscopy or whatever. She says, can we go somewhere else? You know, they bring up closing, they bring up all kinds of stuff, which I said, well, look, I still take my family there if necessary, and try to give them a little more. No, it's not that. It's that the hospital is no longer a woman's hospital.
Okay. Because women can't have children there.
That's right.
Got it. And being a OBGYN, having privileges there, what do you do there? You can't deliver babies there, true?
No, there's no baby business whatsoever
Right.
there. The only thing we can do is gynecology, surgery, mostly,
Okay.
which that is still excellent for that.
All right, so you still do gynecological surgery there at South Fulton Medical Center?
Every Monday,
Okay.
except today, naturally.
And you also work at Grady? Is that
Yes,
right?
sir.
Did you deliver babies at Grady now?
I supervise deliveries.
Okay. What do you mean by that?
In teaching hospitals,
Right.
a resident cannot do anything without an attending being there.
Yes, sir.
Not only being there, but when you deem necessary, you have to do it.
Right.
Or at least scrub in to be ready in case that the resident needs you.
Right.
And that is the law. Let's
Right,
put it that way.
right.
Not the law as you know it, but the law in medicine and academics.
Right.
So in that way, I do it. If it's an operative delivery, I'm definitely in it. By that I mean whether you do it on extraction or whether you do in any procedure in which you have to intervene, from C-section down to removing a placenta. Now, that's in OB.
All right, so that's what you do there at
Yeah,
Grady?
I have my privilege to do that, yeah.
Yes, sir. And you're still working at Life Cycle?
Still work the life cycle a couple of days, yes, sir.
All right. You working anywhere other than life cycle?
Grady.
Okay. And life cycle, the address there is what?
2739 Felton Drive.
Felton?
That's 30344,
Okay. That's in Atlanta, true?
East Point.
East Point. And that's in Fulton County?
Fulton County, yes, sir.
All right.
Why do I know that address so well?
I don't know. Why?
That was the first office that we had when I first came down to practice in Atlanta. And once they built the building, we all moved into the building, and the hospital sold those buildings and they knocked them out. And Life Cycle bought that building and built what they are now today there, 2739.
Right.
And I didn't know until I came in April of 11, and I saw the number. I said, wow, this is the first place where I practice. It's going to be the last place where I'm going to be practicing to.
So you're practicing at the same address, 2739 Felton Drive?
44 years.
Okay. And that was in
ago.
Sir?
That's the first place that I came in.
And that would have been in 1970?
1970, September 15.
Okay. And just very briefly, your background, your education and training leading up to September 15th, 1970?
I was born in Colombia, South America. My parents, Lebanese, first generation born in Colombia. I went to all my primary and secondary education was with the Jesuits. Graduated from BS in 1955. Went to medical school with the Jesuits too. 56 through 61, did my internship 61 through 62. Graduated cum laude in 1962. Came to the United States in 1963 to Emory University, where I stayed until September of 1968, when I was inducted involuntarily to the United States Army Medical Corps for 2 years. And on the 15th, I came back here to Atlanta.
Okay, 1970. So let me, up until 62, you're training with the Jesuits. You mentioned that was in Colombia? Yes,
That's
sir.
correct.
Where in Colombia?
In Bogota, Colombia.
Bogota. All right. And you graduated from medical school there in 1962?
1962.
All right. And then you went to, from 62 to 65, where were you?
62 to 65.
Yes, sir.
I came here in November of 1963.
Okay.
Between, well, I did 2 years of residency in OBGYN
At
in
Emory?
Colombia
Oh, okay.
also.
Okay. And then you came to the United States in 1965.
3.
I'm sorry. Came in 1963, so you were at Emory in 1963?
From there to 1968.
Okay. 5 years, from 63 to 68 at Emory, true?
I did my residency, I did a pelvic surgery fellowship, and
Right.
then I was an instructor waiting to be assigned a place in the Army.
All right. Then you went into the Army from 68 to 70, came back in September 70 to 2739 Felton Drive, and you opened your practice then?
That's
and there?
correct.
Okay. And was that a private practice, or were you part of the group?
Private practice.
Okay, and you were...
Yeah, well, there was another partner. Later on, we were 3, and so forth. Then we split.
Okay. And you were in private practice until you joined the Life Cycle group, and...
That was nothing until April 1st, 11.
Okay. Were you part of the Life Cycle group when you cared for Alakina Bohanna?
That is correct.
All right. And what's your date of birth?
3/17/1938.
And where do you live currently?
In Sandy Spring, Georgia.
Have you ever had your privileges suspended, revoked, curtailed in any way?
No, sir.
Okay. You know Dr. Acevero?
Acevero.
Yes, sir.
I know of him. We haven't worked together much at all. Maybe a couple of times I assisted him in surgery. He wanted to do some procedures.
Okay. You assisted Dr. Acevero a couple of times in procedures? Yes?
Yes.
Okay. Do you know why Dr. Acevero left Life Cycle? What's your understanding?
I have no idea, to be honest with you,
Okay.
what was the reason he left.
All right.
What I am the type of person that if I don't know reasons, I don't speak of,
All right.
because this is how rumors start, and I don't want to be part of rumors.
Okay. Did anyone tell you their understanding about why Dr. Acevero left Life Cycle?
That's the same thing that I just said.
Okay.
I really don't know, to be honest with you. All I know is that he left, and I didn't even know what was he going to be doing after he leaves. I've seen it a couple of times since he left. Briefly, hi, and how you doing? I'm doing well. He told me something about it was public by then of a problem he got in a pain clinic or something.
Yes, sir.
I didn't discuss with him anything about it.
Okay. Nothing regarding the pain clinic
No,
issues?
it wasn't none of my business anyway.
Had any conversations with anyone regarding this case, Ms. Bohannon, other than your lawyer?
That is correct, sir.
Who? No one
No,
else?
no,
Okay.
no
All right.
discussion or conversation,
All right.
except to myself and with Miss Jennifer.
Okay.
Melissa.
Melissa, I'm sorry.
That's all
Jennifer. Well, that's good. You changed your name now.
What about any documents reviewed regarding Ms. Bohannon?
No. As a
Sir.
matter of fact,
Not at all.
Well,
the documents were given to me 2 weeks ago.
he's looked at the medical records.
Okay. Do you have those here, what you've reviewed?
Yeah.
May I see those? Are those copies we can mark, or?
Yeah.
That's it.
This is everything he looked at.
I'll just, these have been handed to me by your lawyer, and they've got some, maybe some helpful tabs in here, which are fine. I guess one is affidavit of Christian Briary. We'll mark that as Exhibit 1. Is that right? You reviewed that?
Yeah, I read what he says.
Okay. We'll talk about that. Looks like Exhibit 2 or some South Fulton Medical Center records. It looks like some strips that start at 1 and go to
There's 2 different strips.
1 to 21. And then some more South Fulton Medical Center records. It looks like
That's the first admission, yeah.
starts at 195 on to page 216. Is that right?
That's correct, sir.
All right, and that's not the full South Fulton Medical Center record. That's just a portion of the strips and a
This is the
portion.
triage. It's a full triage note,
Okay.
this part. The other ones are, the first part is the triage tracing, and the second is the admission on the 26th tracing.
Okay. And then it looks like the third, these are your office notes regarding Ms. Bohannon, is that right?
That's correct.
You have some spots in there to, let's just see what we got here.
Hang on just a second. Let me do this. you tab these?
Huh?
Did you tab these?
You did.
Yep, I gotta take them off.
Okay,
That's all.
that's all right.
I don't know, you, probably that day you gave me the wrong record when I said I didn't have copies, and then I found the copies
Got it.
and at
We've been
home.
going about an hour. Can we take a bathroom break?
Yeah, absolutely.
Yeah, let me just finish with these documents.
Just
Were you just
marking.
identifying them?
Yeah.
Oh, yeah.
Exhibit 3 looks like the, well, I don't know,
Right.
we can go to the
No,
bathroom.
that's fine. If you
fine.
want to, if it's just marking them, James, it's just if we're going to get into discussions of them.
Off
We'll
the
take a
record
short
at
break,
11:45 a.m. We are back on the record at 11:44 a.m.
I think, I'm pretty sure that when Ms. Woodland asked about a break, we were talking about Exhibit 3, but I'm not. You were. Okay. Exhibit 3, which is, look like your office records regarding Ms. Bohannon. Is that right? And Exhibit 4 is a public consent order. Is that right? Yes. I have to
That is
check.
correct,
Okay.
yeah.
And I think it's actually 2 orders. The first one's dated March '06, and the second one, is dated October '83. Is that right?
Correct.
Any other documents that you have reviewed?
This is it.
Okay. And we took a short break. Anything over the course of the break cause you to change any of your answers that you've given so far?
No?
Right.
Why should it?
I wouldn't imagine it would. It's happened now.
Well, I'm sure it does.
Now, you may have spoken with your lawyer over the course of the break. I don't want to know what, if anything, you talked about. Did you speak with anyone other than your lawyer over the course of the break?
I have not spoken to anyone. I was in her office and we sat there and she was concerned about my back.
Okay. All right. No other conversations with anyone else?
No, sir.
All right. You mentioned your privileges have never been suspended, revoked, or diminished in any way. True?
That's correct, sir.
Have you personally authored any textbooks?
Have I been offered?
No, sir. Have you personally authored any textbooks?
Written. Have you written any?
Have I written textbooks? No, I have written chapters on.
Is this your CV? Got it. That, we'll mark that as 5, if that'll help you. We mark your CV as Exhibit 5 to your deposition.
All right.
Ever authored or written any textbooks?
Textbooks, no.
Okay. What about any treatises, research manuals, things like that?
I've done a lot of writing,
Okay.
some published, some unpublished.
All right. All your writing is listed there in your CV, is that right?
It should be.
Have you written any portions of any textbooks?
Yes, I've done chapters for.
Okay. And are those listed here?
There is contraception.
All
I
right.
wrote dual sterilization chapter. I wrote the chapter of mini laparotomy, and I wrote, I think it was laparoscopy or something like that.
All right.
I don't recall exactly. It's been
Of those portions of textbooks, any of the portions that you've written deal with placental abruption?
No.
Okay. Have you written anything regarding placental abruption?
No, sir.
Have you taught any students? Yeah, I think you mentioned you were doing some teaching.
Mentioned, of course, lecturing on school and on staff meetings and things like that, yes.
Okay. And over the course of your teaching, I mean, there's a portion of your course that deals with placental abruption, true?
There's not a day we don't talk about different things, but not in a formal lecture type of thing, you know?
Yes, sir. Is there a textbook that you use in your teaching at
Williams.
Morehouse? Okay. And what's the title? It's the
Williams Obstetrics.
All right. Use Williams Obstetrics when you teach at Morehouse. True.
One of the textbooks or references.
All right. Any other textbooks or references that you use that deal with placental abruption?
No placental abruptio. I'm not. Are you talking specifically about abruptio?
Now I am. Oh, when I mentioned it in a question.
The first few questions here was all this thing in reference to abruptio, where I tell the residents and et cetera, et cetera.
Well, we can go through it again. I think I first asked you whether you'd authored any textbooks, and you said no. Is that right?
That's correct, because
So-
I could understand that for that question, that if I received free textbooks from someone, that's
Yes,
what
sir.
offering means to me.
No, I'm sorry. I'm not authored. A-U-T-H-O-R-E-D.
Oh.
Okay.
No.
Okay. And then I asked you about whether you'd authored or written any chapters
Yeah,
in
that's
textbooks.
different.
And you told me about those, and then I asked you whether any of those
Was
chapters.
about abruptio, say no.
Yes, sir. Okay. I think that
Okay.
gets us up to.
I think
then-
he was confused about your questions about teaching the residents. And when you ask about the text, he wanted to know, are you asking him
Got it,
specifically when he
got it.
taught about abruption or talked about it?
Right. And then you shared with me, you used Williams on obstetrics.
That's a basic
Right.
Bible.
Right. And that's the Bible of obstetrics, and you use that when you teach at medical school at Morehouse.
Right.
True. Any other textbooks that you use when you teach at Morehouse?
There's many reference books, you know. Depends on what you're talking about and what you want them to read about, or if there's any specific subject you want them to dig into it, and they have to research,
All right.
and that's up to them what they choose.
Right. Any others as you sit here today that you're aware of that deal with placental abruption?
Actually, no. I had kind of not discussed this thing at all since this thing happened.
Okay. And maybe I didn't do a good job with my question. In your teaching at Morehouse at the medical school, are there any other textbooks that you
I have
use
not
other
lectured
than-
the residents nor the interns formally on placental abruptio
Okay.
since this case.
Okay. What about before this case?
Wherever the opportunity comes, I take it.
Okay.
The thing is that if I do a formal lecture of this thing, it's like if I was reviewing this because of the case, and that I don't want it to look like that.
I
Because
didn't
that wasn't
understand
the
you.
purpose. I wasn't learning on the books after I took care of Mrs. Bohannon.
Yes, sir.
That's could
You
be
weren't
the
learning.
conclusion of what I was saying. I don't want it to show that I didn't know what abruptio was, and then I have to take a textbook and prepare myself and use a lecture to the residents as an excuse for my learning how to take care of an abruptio. You confused?
That's
Let's
not
drop
the-
the question.
Yeah, that's not the question. Just listen to the question.
It's an explanation.
Yeah, an explanation's fine. Yeah, I'm not, I wasn't suggesting that you needed to use any of these textbooks to care for a patient that's suffering from a placental abruption.
I didn't think you were
All
either.
right. Okay. So are we on the same page?
We got you insisted about have I lectured the residents formally on this?
Right.
And I say no.
Okay. How'd you come to learn about this case, about Miss Bohannon's case?
When I got your notice at 7 o'clock in the morning in my residency, and a sheriff got us out of bed and gave me the greetings.
You were served with a lawsuit, is that right?
That's correct.
Okay. And did you read the lawsuit?
But of course I did.
Okay. And then, who did you contact about the lawsuit?
That morning, at 9 o'clock, Miss Selwyn, I told her what I got, and she says, okay, notify the insurance company, and that's how it started.
Okay. And who was the person that you called? What was the name?
Miss Selwyn, Ann Selwyn.
Oh, Ann Seguin. Okay. All right. And she notified the insurance company, and that was that.
I presume she did what you needed to.
All right. And the next person that you spoke with about that was a lawyer. Okay. And you haven't spoke with anyone else other than your lawyer about it and me. You understand your deposition is a public document? True.
Yes.
And that barring this being sealed, your colleagues at Morehouse, your students, and other people that you practice medicine with would be able to read it or see it and know what your views are on placental abruption. True?
That is correct, sir.
Okay. All right. I mentioned, let's see, one of the exhibits we marked was a portion of the South Fulton medical record. And
James, does that have any numbers on the bottom?
yeah,
Right? It
we'll go
does?
through it.
Okay.
Um,
Does it say SFMC and then a series of numbers?
yes.
Okay, thank you.
The Exhibit 2 is composed of two different pieces of the South Fulton medical record.
Gotcha.
It looks like South Fulton Medical Center FMS 0001 through 0021. Is that
No.
right?
Yeah, that's what it says there.
Okay.
But these are two different documents.
Right.
Is that okay?
Well,
Yeah, he's just talking about the numbers right now, to make
Oh,
sure
the
they know what
numbers.
the numbers.
Okay, yeah, that's what it says.
the first one is a fetal heart strip. True.
Right.
And that's for the Bohannon baby.
This is exactly for Mrs. Bohannon when she was in triage month before she came in labor. So.
All right.
May I make a request, please? It just might be easier. Can we perhaps get a copy? Is it copyable? I can't really tell the volume from
Well,
here.
you've got, I mean, I don't have an issue with you making a bunch of copies, but, I mean, do you have the medical records with
I
you?
do, but
Okay,
I just
I
want
can tell you what.
make sure we're all on the same page as to what the
That's fine.
exhibit is, so.
I have no
Okay.
problem. I can make a couple of copies.
Yeah, I'd like a copy too, please.
Yeah, go ahead and have him identify it, James, and if we can take a short break and just get a copy, so we're all looking at the same thing,
fine.
it might be helpful.
That's fine.
Thank
You just gonna do this one, or you're gonna do them all?
I don't, I tell you what, can we go off the record for just a minute and
Sure, it's
take a
fine.
look at them and just see
Yeah.
what they are, and then
Off
we
the
can make
record.
that decision?
Off the record, 11:57 a.m. All right, we're back on the record at 12:06 p.m.
All right. We were going through some of these records, and one of, I believe you mentioned earlier that you'd reviewed this portion of the South Fulton Medical Center record, but you've actually reviewed the entire record. And these are just portions that you had with you that you also reviewed?
Everything, yes, sir.
Yes, sir. And this is the fetal monitoring strip, pages 1 to 21, it looks like.
That's correct.
And then there's also South Fulton Medical Center 0195 to 216, which I think you said was the triage? Is that
That's
right?
the triage admission, yeah.
That's a triage for which admission?
for the first patient,
The
the
date.
first admission, which was not really, it was an outpatient type of thing.
Right.
But the triage records for Ms. Bohannon on the night of the 22nd of June of 2011.
All right. And why did you review those particular records?
Because the record should be the reflection of what happened to the patient, right? So I have to see what had happened. I did not see the patient myself,
Right.
and so everything was done by the triage personnel and the communication that I had with the nurse
Right.
on the complaints and findings.
Right. Now this is, and you didn't see Miss Bohannon when she was in the hospital on the 22nd of June 2011 at all, true?
No.
I believe you gave one telephone order to send her home, is that right? Discharge?
Well, I gave an order to send her home, yes, that was the last one. I also asked them to monitor her and to do an amnio check and several other questions that might not be reflected in fetal heart tones, etc.
Yes, sir.
And there was no data that indicated that I needed to be by her bedside
Yes, sir.
with the complaints that she had
Right.
and the answer to the test.
Right.
So I didn't see her.
Right. And this was a couple of days before she came back by ambulance, true?
This was on the 22nd, and she came by ambulance on the 25th, 6th,
Here. You
25th.
can, you can look at,
Is this
Feel
all
free
this
to
is good, or?
reflect the records. Yep, that's just a copy that
Right.
we have of the records. If you want to refer to them.
27th of June.
These Bates? Yeah. Okay. I'm sorry,
June 27th.
27 June. Three.
Okay. All right, we're going to go through and Exhibit 3, those are your office records.
Right.
Let's start with a couple of questions about those. Alekina Bohannon first presented to Life Cycle on April 15th, 2011. Is that true?
April 8th, 2011.
All right. And she was 25 weeks, 4 days gestation?
She was 24 weeks by sonogram done at South Fulton Medical Center on, I think it was a few days before I saw her. Done on 4/1/11.
All right.
And the emergency room referred to us.
All right. And at the time, Ms. Bohannon's past medical history indicated she was of advanced maternal age and an insulin-dependent diabetic. True?
At the time, yes, on this evaluation, I found that she was a diabetic, insulin dependent,
Yes, sir.
and but that she was on metformin, not insulin.
All right.
I also found out her obesity and her hypertension,
All right. She had chronic
and
hypertension.
AMA.
Chronic hypertension.
That is correct, and advanced maternal age.
All right. And you had an ultrasound done, all right?
I did I told her that day it was a long visit, and I counseled her that she needed to see an endocrinologist to control her diabetes, that she needed to see maternal fetal medicine specialist, that we needed to change medications for high blood pressure, and that I did not know if she will require to go back into insulin for care of her diabetes. She did go to see Dr. Sedin for that, and he put her on insulin. And she went to maternal fetal medicine, which did the evaluation and reported about, they extensively counseled her too, including the complications that were to probable complications and possible complications of these quadruped diseases affecting her. We miss late prenatal.
Yeah, I've got late prenatal. Both her advanced maternal age, diabetic, and chronic hypertension all were additional risk factors that would make her more susceptible to a placental abruption. True?
More susceptible, we don't have the stats to indicate exactly what's more than enough, but yes, it is a risk factor.
All right, I'll do a better job. Ms. Bohannon's advanced maternal age is a risk factor for placental abruption. True?
It is.
Yes. Ms. Bohannon's diabetes is also a risk factor for placental abruption. True?
Yes.
Ms. Bohannon's chronic hypertension is also a risk factor for placental abruption. True?
The number one.
Yes, sir. That was my understanding as well. Thank you.
There's another risk factor that is not mentioned, which is that she had had 2 previous abortions.
Okay.
That is voluntary interruption of pregnancy.
All right.
Not for abruptio, though, but for premature delivery.
Got it. And then you had an ultrasound performed. True?
Yes, she had, as I mentioned, she had an evaluation on the 22nd of June. Wait a minute, I get back. This is April. She had an evaluation by the APA, Atlanta Perinatology.
Right.
And
That was on 1 April 2011, right?
right, and they
Hold on.
Not Atlanta Perinatology on April
Yeah.
1st.
What was the date of the
April 1st is Southport.
April 15th? Do you have the?
The first date that she went to Atlanta Perinatal.
Yeah,
Take your time, if you would, if you can find that ultrasound.
this is not here.
Just to clarify, are we
By
talking about
dates.
the April 1st ultrasound or
We're
subsequent?
going to talk about both of them,
Okay.
but he's looking through the record
Okay.
now, which is fine.
These ultrasounds are not in order.
Yeah, there's multiple.
525, Alan Newman. 41, April 1st. This is the ultrasound at South Fulton,
All right.
all right?
And,
23-4.
There was a large pelvic mass seen at that ultrasound.
They saw a necrotic, yeah, on this one, what they say, probably a necrotic fibroid.
Right. And that was just above the fundal placenta, true?
The description of the fibroid on this ultrasound at the emergency room is
Sure.
necrotic appearing mass associated with the right annexa and fundus of the uterus. Associated is to understand that it's neighboring to the right annexa, not necessarily being part of the right annexa. The 10 centimeter is at 23 weeks. Okay, I want you to keep that in mind when I get in the operating room and open this patient.
Right.
These tumors weren't 10 centimeters. Anyways,
If they weren't 10 centimeters, what size?
well, just remember this fact.
All right.
The laomyoma grow during pregnancy
Right.
because of the amount of estrogen that is circulating in the maternal blood.
All right.
So at 23 and 36, the size is at least double on every tumor.
All right.
All right?
All right.
So that means a huge uterus based on the multiple tumors that she had,
Right.
which she considered very nicely because of her habitus. But there's mention of these tumors with APA serial sonograms throughout. And in one of them, as a matter of fact, if I recall correctly, there is a mention of the crowding to the baby because of the tumors. Now, I was accused by your...
Wait, Dr. Nasser, do you know the
Go.
question you're answering right now?
My question?
Do you remember the question that you're answering right now?
My bad.
So
Yes,
You can explain.
Well,
he was asking me about the tumors.
Right.
I think he asked you where the tumor was in
the
relation
fundus?
in relation to the placenta.
Okay. In a relation, I don't know where the placenta was. There's no description as to insertion of the placenta in the ultrasound.
Right. You were talking about with the number of tumors that she had and her habitus, and you were explaining your thoughts about the tumor. Or tumors? Will you continue to do that? I think that's what you were doing.
No,
You need a,
since I put my foot in my mouth.
Oh, you didn't.
All right.
We're
well,
going
there's
to get
nothing.
there anyway.
It's not anything to hide anyway. Yes, there were multiple large tumors
Right.
in her uterus,
Right.
which made the surgery much more difficult
Right.
without an assistant especially.
Right.
But anyways, the tumors did not allow me to remove the uterus to even sew it up. I have to do everything within the peritoneal cavity with a real sizable uterus. But we got away doing it all. Anyways, what else can I say about that?
Well, that's what we were talking about, that tumor and where it was. And you agree that on the 1 April 2011 ultrasound, the fundal right adnexal region of the uterus just above the fundal placenta
Object,
is where the pelvic mass was.
object to the form. Misstates
That,
the testimony.
I didn't see that says fundal placenta. It says here, 10.5 necrotic appearing mass associated with the right annexa and fundus of the uterus.
Right, okay.
There's no placenta mentioned here. These are ultrasounds that are not the most complete
Right.
ultrasounds in the emergency room. The ones for an APA are level 2 ultrasounds, all of
Right.
them. And they very much attached to what we expect to know.
let me take this for a minute.
Let me pull. I got a better way to.
got everything from Sardine in one package.
Oops.
Is the ultrasounds the one I, oh, you got them?
186 there.
Hmm?
It's 186.
Are you looking at the Fulton records now?
Yeah, I mean, either way is fine with me.
No, that's okay. Yeah, I've got 186 here. All right. Dr. Nasser. Let's just look at this one so we're all on the same page. One,
Patient.
South Fulton 186.
Okay.
Yeah, that's the emergency room.
Right. Do you have a question about it?
Yep. This is April 1, 2011.
Yes.
You see, this is Miss Bohannon, right? April 1st, 2011. And this is an ultrasound, true?
That's what I can read. I didn't see Miss Bohannon. I didn't know Miss Bohannon by then.
No, I understand. Less than 14 weeks. Would you see where it reads findings? Can you read aloud where it says findings? There's a 10.5 centimeter necrotic appearing mass associated with the right adnexa and fundus of the uterus. True?
Yeah, that's what it says.
It is uncertain if this is due to an ovarian mass or more likely a degenerating fibroid. True?
True.
And you'd seen that before today. True?
Yeah, that's
You were
the
aware of
same
this.
conclusions that they have.
And then the next ultrasound was on April 15th. Is that right?
Just kind of try to help us move along here. Okay.
April,
15th.
18th? Oh, April 15th. I don't know
yeah,
if we
this
have
is
that.
May.
Oh, wait.
There's a copy in here too.
Okay, he said there's a copy in here.
April 1. My first ultrasound here is on May 11.
We'll look at the
My record, on office record.
You're right. May 11th, ultrasound.
It is right, the one that you have here.
Oh. I doubted myself.
You see that?
Here. This one? It's the 18th. It's not the 11th.
That's the second. You don't have the May 11.
Well, if it's in your records here, then find it before we talk about it, or if you have it, you
I
can
can
look
show
at
you.
it.
He has it here.
Do you have you show an April 15 visit in your record, true? You see that?
I have here the one April 11.
Okay.
Correction, April 1st. And then I have May 11, or that's 6/11. 6/1/6/9, 5/11, 6/1 and 6/9. And I have here copies of 4/26. This is probably the first one. Oh no, that's a urine culture, I'm sorry. 6/22, I have that.
All right.
I have 6/1.
Do you have a specific one that you're waiting for him to find, James?
Yeah, I'm
What-
just, let's give him a moment to get familiar with this record. And when you do, if you would turn to the May 11, 2011 obstetric ultrasound report.
This is 6/1.
Here.
Right. This is 5/11.
Okay.
All right?
This ultrasound was performed on May 11, 2011, true?
That is correct.
For Miss Bohannon?
That's
True.
correct.
And that was Atlanta Perinatal Associates?
That's
True.
correct.
And there was, under presentation, amniotic fluid markedly increased, polyhydramnios, AFI 30.2 centimeters, true.
That is correct. That's what it says there.
And that's an abnormal finding, true.
That is an abnormal finding, yeah.
And polyhydramnios is also a risk factor for placental abruption, true.
And for premature labor, too.
Yes, thank you. And there's also a note that you made on 27 June 2011. Do you see that in your record? I'll show you what it looks like. Looks like this.
What date?
June 27th, 2011.
Son okay with diabetes, well controlled, as well as high blood pressure.
Hold on. Dr. Nasser,
Yes,
he's
ma'am.
showing you a particular page. He's showing you a particular page that he's going to ask you about.
Yes,
So-
that's the same.
Right here.
Yes, sir. Yep, you completed the initial pregnancy profile.
Uh-huh.
And in the initial pregnancy profile, you did a physical assessment?
Yes, ma'am. Yes, sir.
Yes, sir.
May
And
I
you
just
did,
ask for clarification? Is there a page number? It's just hard since we.
Yes,
can't-
I have.
They're not on,
There's
these
not
are
a
his
page number.
notes.
This is life
Obstetrical
cycle
history and
correspondence.
physical,
Gotcha.
there's no
And what was the
page
date on
number
it?
there. The physical examination.
June 27th.
Gotcha.
Dr.
And-
Wait, let me see this. Okay, so James, just to clarify,
Mhm.
there's one that's completed in the life cycle
Mhm.
chart.
There's
And
also
then it-
one, that's right.
So the one he's looking at does not say,
No,
June
not dated
27th.
until the patient is admitted to the hospital.
But
Right.
are you looking at his?
we're looking at the
Office
life cycle
records.
chart.
Right,
Okay.
here's what
So
we're
it's
gonna.
Exhibit 3,
Yes.
Yes.
Okay.
all right.
And it's also South Fulton Medical Center record, I'm gonna,
Yeah, page.
118,
Right,
but that's what's completed at the hospital.
right,
You're not asking me, but I'm gonna let you know something.
okay,
It says here, visit date.
Yes, sir.
And it says 4/15/11.
right,
Right, that's the day I saw her and wrote this.
right, okay,
I have this date for my own reference.
all right,
The date here is written when the patient is admitted to
Right.
deliver her baby.
right,
Because copy of this has to go into labor and delivery.
Right.
At least that was the rule.
right. And for the record, I just want to make, when you say this and this, not everybody knows, and we won't remember when we go and read this. You're referring to the prenatal flow record for Miss Bohannon. On the first page, you've got the dates of the patient visits, true?
Right here.
Yes, sir?
It says here, the age of the patient, the year, and the visit date.
Right, and the visit date is April 15th, 2011,
Right. That's
true?
the day that I saw her for obstetrical care.
Yes, sir. And if you flip back,
All this was done on the same day.
right, 3 or 4 pages, you've got the initial pregnancy profile. You completed that document on April 15th, 2011.
You're talking
as
about the
well.
pelvic evaluation.
Yes, sir,
Yes.
including the pelvic evaluation, right?
Yes.
And your pelvic evaluation, when you took Miss Bohannon's measurements, revealed that she had a borderline pelvis. She was borderline, true?
Borderline for what?
Well, you checked this box, borderline, right?
Yeah.
And you mean borderline about her ability to have a vaginal delivery?
Or of a 7 pounds or more baby.
Okay.
Not a 4 pound, nor a 3 pound, not a 5 pound.
Right.
Okay? The problem that you have to understand is this is a clinical evaluation of the pelvis
Yes, sir?
halfway in a pregnancy.
Right,
So in order for you to evaluate the content against the container,
right,
you have to have a content fully grown to make an evaluation.
right,
In the meantime, the evaluation you make is only an indication that, hey, guy, if this grows a good baby size,
Right.
we're gonna have to do something different than vaginal delivery.
Like a C-section.
Like a C-section, right?
So you, go ahead, I'm sorry.
This is, remember, we are evaluating the first pregnancy of a person that has never delivered.
Right.
So this is got a pelvis that is not or has not been proven.
Right,
Proven is when you deliver.
right.
This patient has not delivered baby. This is not a proven pelvis. I felt what I wrote down there, and I am not retracting of my feelings.
Right.
And so this is telling me, watch out when you get to 38, 37, 9 week,
Right.
and you evaluate that pelvis again, then you compare with this, and you said, this baby is too big, it's not coming through. We
Right.
should plan to do, let's say, an elective C-section,
Right.
or I think this is gonna come through. Don't we do a trial of labor before we decide it? Chances are you going to do it or not. I mean,
Right.
but in the case of Miss Bohannon, that's the reason. Interpretation was that I should have sectioned the patient based on this, according to your witness. I hate to disagree with the colleague, and this is not the final evaluation of
Right.
that pelvis. And this is just an indication of a call on it.
Right. So that's your note as of April 15th, 2011, and that's to alert you and any other colleague, if you were, God forbid, out of
Check
town
on
or
this,
away,
yeah.
right, that you may need to do a C-section for Miss Bohannon.
Mm-hmm.
True? Yes?
Yeah, that there is something that needs to be evaluated. Remember one thing, between the time of a person is 23 weeks and 40 weeks, there is a good number of changes in the pelvis, okay? There is dilatation of the pelvis. The ligament become very elastic, and they give up approximately 1 inch of extra space in every big joint of the hip, okay? All the hip joints, the sacro-sciatic joints, the pubis, pubis separates to about 2.3, 2.5 centimeters. Same happen with all the joints. This is one of the reasons that women become clumsy walking, is because the joints don't respond as good as when you're not pregnant, and they fall easily and become erratic on trying to go upstairs or down from the sidewalk and straight, whatever.
All right.
Getting on the bus. But that's just to try to explain the reasoning that goes on this.
All right. You're fine. Your Plaintiff's Exhibit 3, the obstetric ultrasound report dated May 11, 2011, reveals the diagnosis of polyhydramnios. True?
Mhm.
Yes.
That is correct.
Known risk factor for abruptio placenta. True?
It is, yes, one factor, definitely. Also, this ultrasound has also some more information that is very relevant.
All right. Like what?
Like what? Well, this is not for me to tell you like what, but this is the first ultrasound indicating that there is polyhydramnios. All right. There is nothing you can do to manage polyhydramnios, especially at 29 weeks, unless you want to end up with a premature, extreme premature baby
Right.
with only 20% of chances to have, if survive, having a decent brain.
Right.
All right. So we don't do anything here except for bed rest and observation and follow-up ultrasound. On the follow-up ultrasound of this lady 2 weeks later indicates that he has gone down.
Right.
Voila.
Right.
Great. The best news was seeing that ultrasound saying, well, this problem is controllable.
Right.
The following ultrasounds, the liquid retained into the amniotic sac was within normal limits all the time.
Right.
So in conclusion here, the polyhydramnios was a transient
Right.
one that, thank God, did not enter into the final game to complicate more situations,
All right.
according to the serial ultrasound.
Later ultrasounds, right?
Mm-hmm.
Yes.
Yes, say it out loud, yes.
That is correct. I'm sorry, I forget that I'm talking to
Well,
everybody.
the whole purpose of that is that there's going to be a transcript, and so it's hard to tell if you nod what you meant.
Okay,
Okay?
thank you, ma'am.
You're
I'm
welcome.
sorry.
No need to be sorry.
I'm not as smart as my mother used to tell me.
What is
But your mother was a,
I say I'm not as smart as my mother used to tell me.
You're plenty smart. All right, we're going to talk. I want to talk with you now for just a moment about the Miss Bohannon's first admission on 23 June 2011
Uh-huh.
at Tenant South Fulton to the Labor and Delivery Unit,
Yes, sir.
and it's documented that Miss Bohannon had Category 2 fetal heart rate tracings at that time. True.
objective
Yes.
form.
And what are Category 2 fetal heart rate tracings?
The category 2 is a tracing that is considered to be a normal tracing with a good variability and absence of brady or tachycardia on permanent basis. And if the patient is contracting, you will be able to record the contractions. And that's a non-ominous tracing.
Okay. And it was also indicated at that visit that there were fetal heart rate decelerations. True?
Objective form.
I know that you got that out of the signature interpretation or the sign interpretation on the computer of this tracing.
Right.
I'll be more than delighted to try to explain that. Number one, at the time that you read these things, your tracing is not available.
All right.
All right? One. Two, on this lady, and this is not actually the patient, but is the machine. The recordings on this tracing were erratic.
Right. And
But
for the
you
record,
can-
you're looking at South Fulton Medical Center FMS fetal monitoring strip, page 0002.
That's
True?
correct.
All right.
And you see that there are fetal heart rate recordings here between 190 and 150 and under 150 in certain, but there is nothing steady. It's up and down. This is interference. This is nothing. But it was interpreted by me looking at this of a possible TAC.
All right.
Okay, that is the portion of the TAC, correct?
All right.
And then here it continues with fetal heart rate on 160, 165, but then
Can you tell
once
us what-
we start
what-
getting,
What page?
Wait,
this is up in
That's okay.
page 4.
Page 4.
And now, where we get a decent tracing finally on this patient
Which
is on page 7.
Thank you, sir.
In page 7, you see a perfect normal tracing with good variability.
All right. And by normal, you're looking at 150, right?
Yes.
Fetal heart
And
rate.
where did I get the variable deceleration? In the only place that you can see it in the entire tracing is here.
All right.
page.
You have a descending curve with a nadir at 100 beats per
7.
minute.
Can you
Right.
just tell us the panel
In
number
the
at the top?
apex of your contraction.
Hold on.
And then it recovers perfectly right after the contraction is over for a normal tracing again.
Okay.
Followed on page 8
Dr. Nasser, can I
Nasser.
just ask one question, sir, since I can't look over your shoulder? Where you're identifying that variable D cell, can you tell me the panel number up above it?
Panel
Yes,
number
sir.
is,
Well, hold on, you can,
Uh,
we're not
12.
gonna, hold on, Dr. Nasser.
Okay.
We're gonna, we've, I think our hostess has been very accommodating. She's given you copies of these documents. You can follow along by page number. We're doing, if you have questions for Dr. Nasser, you can ask him after I complete this examination.
James, that's fine, but all he
Go
needs to
ahead,
tell
Dr.
me is the
Nasser.
panel
I'm sorry
number.
for the interruption.
that's all right.
All right, so you were,
What panel number is it?
page 7.
Thank you. Okay.
So here we finally get a little tracing.
Yes, sir.
Now, this is very common on external
Right.
monitoring, where sometimes it's very difficult, especially on an obese person,
Right.
to get an external monitoring that is steady. So
Right.
any movement will change that total from recording good, decent
Right.
tracings.
But, I mean, if you have even a morbidly obese patient, and you don't contend Ms. Bohannon was morbidly obese, true?
Ms. Bohannon was obese by all means. She was 39 or 38 BMI,
Okay, well, you
220
ever
plus.
No, I don't, well, okay. Her weight was not an excuse not to monitor, true? I mean, you still have to monitor.
Her obesity on the abdomen, the habitus that she had, was making us difficult to palpate the size of the uterus, number one,
Yeah.
to be able to have a good applied external fetal monitoring,
All right.
but not impossible.
Okay. What if it's impossible to get a good fetal heart tracing because of a patient's weight? What do you do? Or,
Well-
has that ever happened?
If the patient is in active labor, it's completely different
Right.
situation because you just put an internal electrode,
Right,
and that solves the problem. Now you direct on.
right,
If the person is at 29 weeks, like
Right.
in this case,
Right.
there's nothing you can do except keep on trying and hoping that you're going to get a tracing somewhere along the line,
right.
which in this case was not a very prolonged tracing,
Mm-hmm.
but it was decent enough to reassure us on the next 3 pages.
So page 10, this is reassuring on page.
This is
page
reassuring.
10.
Page 9 is reassuring,
All right.
and page 8 begins, 7 and 8 begin to be reassuring.
All right. There's another, do you have,
Oh, sorry. That just
you have 216 here?
Tell me what it is, I can find it. These aren't.
Sorry?
Can you tell me what it is, because I've got.
Southfield Medical Center, yeah, 216.
I mean, I'm just
Oh,
trying to figure out what
um,
sections.
216.
Yeah, it's an interpretation of the fetal heart monitoring strip.
That's the one that I was bringing to your attention to.
Here.
Okay.
That I did not have
I've got it
the
here.
tracing one.
Right.
There you go. Can I have some?
It says fetal tachycardia. I explained to you why.
Yes, sir?
And also says variable deceleration. I also explained that portion.
All right. This is your, and for the record, we're at SFMC 216, and that's your note. True?
This
What you
is
just
done
read.
on July 6th at 1:50 in the afternoon.
Right, I just want to make sure, this is a document that didn't accompany the certified medical record the first time we requested it.
I noticed that on your record.
So this is a note that you made, true on SFMC 216, right?
I have to accept this because the only person that has access to this specific thing is me.
Yes, sir. And those are your initials, GN, right?
Yeah.
And would you read that note? It's just very difficult to read. It reads fetal
it says fetal tachycardia
And,
and variable deceleration.
yes, sir. And that was your note at the time.
That was the note at the time for the little bit of analysis that I had.
Okay. And your testimony is that after that analysis,
I
per
would
the
have
strips,
said,
then you got reassuring. That's okay. Go ahead.
that's okay.
I was just gonna let you finish. I was trying to make sure y'all
That's
weren't
fine.
talking at the same time.
No, probably I would have had transient tachycardia or monitoring interference either. You see, the trace wasn't as long as I can see now with the full print.
Okay. All right, I want to talk now about the, at around midnight on 26 June 2011. This is the Miss Bohannon's second admit.
That starts at here.
But I think this is going to, what we're talking about now is going to be in this notebook.
Oh, okay. I'm sorry.
It's okay.
So we'll, this is, I'll get you a copy. This is South Fulton Medical Center record from Miss Bohannon, which begins at SFMC0001 and goes to page SFMC0260. If you would, have a look at,
Oh, I was just gonna say,
these aren't going to
aren't,
be in order?
right.
Okay, that's fine.
But if you tell me what, they're just tabbed so that,
Sure. There's a
On
flow
yours.
sheet. South Fulton Medical Center, page 30.
yep,
See that?
Should be with the history and physical.
129, I'm sorry. It's a difference.
I'll let you, sir.
Looks like this.
Yeah, you had it.
I did.
Yeah. It's on the history and physical. Okay, that is the same one that you showed me.
But he's asking you about a specific,
Here, the flow sheet should be with these papers, unless it's moved.
which is,
There's a flow sheet.
I-
Is that the one you?
no,
The-
he's looking at
this-
Oh.
something different.
Flow sheet.
She's talking about nurses' notes. Okay,
What page did you tell me?
129.
I think I've got it here. Okay,
all right.
All right.
here we go.
Page 0129, hospital record.
Yes, sir. And according to the labor and delivery flow sheet dated June 27th, 2011, at 1:15 that morning, Ms. Bohannon was suffering from abdominal pain and vaginal bleeding. True?
That's what it says here.
And you were called, right?
That's what it says here, yes, sir.
You were called by, is it Vanessa Newton, RN?
That is right.
And according to this note, you were called and given a report of Ms. Bohannon bleeding and complaint of abdominal pain, orders received to perform vaginal exam while you waited on the phone. Is that right?
That's correct.
And then there's a note, but immediately beneath that, VE 7 centimeters / 100 / 0, station VTX MD states en route, right?
That is correct, sir.
Okay, what does that mean?
That means, according
Vaginal
to
exam.
the person that wrote this,
Right?
and the time in which it was written, that the person has been admitted to the hospital with the complaint of pain and bleeding vaginally,
Yes, sir?
and that her examination, which she has not done one until I asked for, was a V stands for vaginal examination.
Right.
7 centimeters dilated,
Right.
100% effaced. The presenting part was at 0 station, and she called this a vertex. And MD states en route.
Right.
That's what it says there.
All right.
Signed Vanessa 45.
So what does that mean to you, that the vaginal examination that she relayed to you, 7 centimeters /100/0? What did that indicate to you as,
That indicates to me that she has opened her cervix to a 7 centimeter.
right?
That indicates to me that her cervix has almost disappeared with an effacement of 100%.
Right.
And that the presenting part, which is the lowest part of the body that is presenting in that pelvis, is at 0 station.
Right.
It
And
means a lot of stuff.
okay, is that
I
baby
mean,
ready to come out?
We can talk about 5 or 6 hours just on that pelvic examination, on all the meanings that can
Okay.
happen,
Right.
which we're not going to.
Right.
Okay, that is again her expression of what she felt.
Right. Do you disagree with what's written here?
I didn't scream or holler, but I did write my own
Okay.
somewhere when I came in an hour.
Tell me how you disagree with this VE vaginal examination, 7 centimeters /100/0.
Okay, I disagree that the patient wasn't 7 to begin with. When I got the opportunity to examine her 1 hour later,
Right.
the patient was only 5.
Right. In your 40 years experience, have you ever known someone to be dilated 7 centimeters and then an hour later be dilated only 5 centimeters?
And the shrinking, the magic
Yes.
shrinking. It only happens when a student examines the patient and then a resident comes in and examines the patient. There's magic shrinking.
Okay.
Because the two people
Right.
have different measurements.
Right. So it's fair to say that the vaginal examination listed at SFMC 0129, we're at 7 centimeters, and your dilated is, in your view, incorrect. True?
Object to the form.
Well, I didn't say anything about correct or incorrect. I said my findings were, A, the patient was 5.
Right.
B, that the patient, let me see my notes so I don't quote myself wrong, but pretty much that the patient had the membranes intact.
Right.
3, that I could not feel the presenting part.
Okay.
And that has a lot of meaning for what I did then.
All right. Tell me about that.
Your witness says that I could have ruptured the membranes
Right.
to find out if the fluid was bloody or not.
Right.
I agree with him 100%.
Right.
That's one of the things that we push.
Right.
Why didn't I? Because I couldn't feel presenting part. And if this presenting part would have been a bridge or a transverse or something, not being able to feel what was in the pelvis, I would have created a new complication to this lady, which could have been a prolapsed cord. And now we not only have abruptio, but we have a cord
Right.
that has been compressed.
Right.
So I said, what's the difference? I'm going to be getting this baby out. There's no need to rupture this.
Right.
And take the chance of that.
Right.
Now, you notice that here brings the patient to 0 station according to the nurse exam.
Right.
That means the patient is engaged, right?
Right.
So that's fine. But when I come in, the patient is not engaged and the cervix is not 7. That's a disagreement, and I couldn't hide that. I wrote it exactly how I felt.
Right.
And it didn't make any difference at that point, except for one thing that occurred during our phone conversation that is not there,
Right. And what was that?
was that I told her, I'm en route and I want the OR to be ready for the time I go there.
Okay.
That's not written anywhere,
Right.
but I did not write my notes there. So I don't know what happened. Then I found that the patient was transferred from...
Dr. Nasser, let there be a
Hold on.
question on the table that you
okay, I'm
answer.
sorry.
There is. That,
What's the question on the table?
finish explaining. So,
I'm done.
all
Do you
right,
want to hear
so,
the question again to make sure you don't have an explanation? Because I don't want to cut you off if you have an explanation to the question that was asked.
all right, I want to, Southfield Medical Center 0129 at 115, where it reads, hold on, let me just, let's see this. Which number is that? 19. Okay.
129. Let's see, progress notes here. 0035. Is that
I'm
what
sorry,
you're talking about?
0129?
That's where we just were. Here, let me
Yeah,
find
I-
it for you.
I think it's nurse's notes too.
That's what I was looking for. Sorry. Just had it open.
Okay, thank you.
So, Southfield Medical Center, the labor and delivery flow sheet, which is page 0129, dated June 27, 2011. At 1:15 that morning, when you got that call, you told that nurse, not only were you en route, but to have the OR ready. True?
That is correct, sir.
And you told her that because you knew then you had a placental abruption. True?
That's suspected highly.
Yes, sir. And you knew that baby needed to come out, true?
That is correct.
And you knew that baby needed to come out as quickly as possible, true?
That is correct, yeah.
All right. And, but that's not written here in this note, true?
Object to the form.
Not that we can see it.
Okay. Well, I mean, I don't see it either. And then you also, so you left for the hospital, you got to the hospital around an hour later, an hour and a minute, 2:16, is that?
Something like that.
All right. And when you arrived at the hospital, you examined the patient yourself, true?
That is correct, sir.
And you were able to determine that the vaginal examination that had been indicated to you by Vanessa Newton, RN, was incorrect, true?
Object to the form.
You may answer.
I would say it did not agree with my evaluation.
Yes, sir. In fact, the vaginal examination that the nurse shared with you was that the patient was dilated 7 centimeters, and on examination, you learned that the patient was only dilated 5 centimeters. True?
That is correct, sir.
As far as the effacement, the nurse indicated to you that that was 100%, and on examination, it was not 100%. True?
I don't remember exactly what I call it, but let me see. My admission note is that.
Here, because I'm assuming we're coming back.
Yeah.
Progress note here.
Okay.
I read what I wrote. Pelvic 5 centimeters,
Let's see what you read.
Read what page you're on.
Page
0035.
All right. Yes, sir.
I say pelvic 5 centimeters, bulging bag of waters, no presenting part felt, bleeding moderate. I gave my impression and to OR for C-section. Patient desires PPS. Patient was very lucid, I remember, because that's when she asked me, since you're gonna do this, should tie my tubes. I said, you sure? She said, "Yeah."
All right. And immediately, this is your note, this Southfield Medical Center 0035 that you're referring to, right?
That's correct.
It's dated 6/27/2011 at 2:19 that morning?
Yeah, that's pretty much the time I sat to write the note.
Okay. And at 2:19, that was, you arrived around 2:16 and met with the patient and then examined the patient and wrote this note around 2:19. Is
I'll
that-
be lying to you if I tell you what time I arrived.
Okay.
I know I wrote this because I had a clock in front of me.
Okay.
Now, was that clock in with the other clocks on the floor?
Right.
Who knows?
Got it. Okay. That's fair enough. Now, you, it reads here, a portion of your note reads, severe vaginal bleeding, true? I think that's right.
Yeah. It
Severe
says
vaginal.
that explains that on admission, patient was brought in an ambulance because of severe vaginal bleeding. No pain.
Right.
I made that point very clear.
Right.
Because the first thing was that I heard the pain.
Right.
Then you even mentioned a 10-10 pain today.
Right.
And I remember that I asked him, how bad is the pain? She said, I don't have any pain.
That's what Ms. Bohannon told you.
And here I made a note to that. He says that the part of the tracing that I saw at the time that I walked in the room,
Right.
the sternal maternal fetal monitoring TAC of 134 blood pressure. Oh no, those are all. I'm sorry.
all right.
That's not one. I'd say here, denies severe pain, having contraction every 3 minutes,
Right.
abdomen is obese, uterus is palpable with no tetanic or tetany, fetal heart tones tracing, TAC, and variable deceleration. Now, TAC and variables was what I saw when I was in that room.
Right.
Now, I'm not saying that this didn't change, because it's very evident that a few minutes later, it began to change and became a trace, a grade 3 trace.
Dr. Nasser,
But at the time, that's what it
the
was.
question was about bleeding.
Bleeding. Yeah, I answered that.
All right. And by TAC, you mean tachycardic?
That's
right?
correct. That's when you're referring to maternal TAC. Yeah.
Yes, sir. I understand. I got it. I think there was another note. We'll get back to my.
Hey, James, we've been going about an hour, so whenever you get to a stopping point, let me know so we can take a break.
That's fun. We can take a break.
Are you sure?
Yeah.
Good? Okay.
Okay, we're on the record at 1:05.
Sure.
All right, we're back on the record at 2:02 p.m.
If you would, turn to South Fulton Medical Center 0027, physician's orders.
Look at the tabs. There should be a physician's order tab.
Orders. 0027.
Yes, sir. And those are your physician's orders, true?
That is correct.
Dated June 27th, 2011 at 01:15 or 1:15 in the morning, true?
That's correct.
And it reads admit to L&D, true? Yes.
Yes, sir. That's
That-
what it says.
And that's, you're talking about Ms. Bohannon, admit her to labor and delivery at 1:15, true?
Yes, sir.
And immediately beneath that, perform SVE, that's vaginal exam? Is that,
That's correct.
all right. And then CBC, blood work?
Type and screen, yeah. That's what it says.
Yes, sir. And these are your notes, right? You wrote these?
No, I didn't write this. This is the
Okay.
nurse's writing. This is standard orders for admissions.
Okay. So these are the, yeah,
I
that's,
sign it there.
is that your signature over to the right?
That's correct.
Okay. But this is a telephone order. This is what you actually telephoned in to this nurse.
That's
True?
correct.
And over on the left, did you write this portion? Was that say work 6/27/11?
Object to the form.
No, this is not my writing.
Okay. Can you read what that says?
It says 6/27/11/0115. Somebody are in.
Okay.
Fax? No, probably.
All right.
Probably says fax, but I'm not
Yes, sir.
sure.
And that you didn't prescribe any antepartum antibiotics, true?
No, sir, we don't usually do that.
All right. And now the patient was febrile, right?
I don't have a proof that the patient was febrile.
Okay.
There is no vital signs indicated that. There is, I didn't see a temperature chart.
Feel free to look through the records. You need to do that.
At one time there is 37.8 or something like that.
Let's see. If you look at 0129,
0129.
yes, sir. In that left-hand column, under vital signs, temperature, see, I assume that stands for Celsius. Oh,
Is it in here?
This is post-op.
Oh, okay. Did you see it?
it's the same.
Oh,
LD
you're in
flow
the-
sheet.
Turn the page.
Yeah, that's what we marked.
Okay, yeah.
Got it?
$38.1.
Okay. And is that, do you consider that afebrile or?
Not, it's not afebrile, but it's not fever.
Okay. No need for antibiotic in that
No,
situation?
Now, I didn't see that prior giving the call for the surgery. Now, immediately we do the pre-op on the C-section, then the prophylactic antibiotics are given.
Right.
So she was covered if that's what the problem was.
And you would expect a nurse, when a nurse calls you about a patient, to relay to you all the significant findings regarding that patient?
That is
Object
correct.
to the
That
form.
was never mentioned to me. I did notice, though, that, and I wrote on my admission that the patient was tachycardic,
Right.
indicating that her heart rate was up for A, B, or C reason.
Right.
At
Now,
the
you're talking about
time.
the mother or the
The mother.
fetal? Yes.
The mother heart rate. And so that naturally will go on to the baby's fetal heart rate increasing too.
Right.
But what was the reason for his tachycardia? Was it excitement?
Dr. Nasser?
Don't
answer
do
the-
it.
Answer the question.
Yes, ma'am. Thank you.
I think he was explaining some of what the nurse shared and some of what the nurse didn't share. One of the things you realized the nurse did not share was the patient's heart rate, true?
That's correct.
And the patient was tachycardic, true?
Yes.
And tachycardic for an adult is anything over 100, right?
That's right.
And this patient's heart rate that the nurse did not share with you was 146. Isn't that true?
Object to the form.
Yeah, and 146 is quite high, actually.
He's high.
Well, I mean, in fact, if you're at a heart rate of 146 for a sustained period of time, it would lead to death. True.
Check the form.
Not that. It's not like a paroxysmal tachycardia, okay?
Okay.
Which you shoot up 190 and 195,
Right.
200, and you begin to feel dizzy.
Right.
But 150 is,
Sustainable in your view.
Oh, yeah.
But it's something you want to be made aware of.
well, naturally, number one. And number two, it helps you also to think in other things.
Okay. Like if her heart's having to beat that fast, there's a reason for it, right?
Yes. Excitement, hyperventilation,
Right.
and she had all this. The patient was in a situation that was not her common everyday situation.
Right.
So all that influenced the maternal pulse.
Right.
And now the temperature.
Right.
I was not aware of that either. It wasn't mentioned to me. But a 38 temperature could be a little bit of dehydration. The patient did get a bolus on admission, but that temperature was on admission too. So it's now she did
Dr.
not
Nasser,
show.
the question was about tachycardia. Okay?
Right.
Okay.
That's how it started.
That's
Yeah.
how,
But they
right.
both related, the tach and the temperature and the emotions and all that.
Right. Yeah, actually, the question was more, at this point, it was about the vital signs that you learned when you got to the hospital that the nurse did not share with you, right?
That was
Object to the
correct.
form.
That you would, ideally, you'd like for a nurse to share with you significant findings, and you agree these are significant findings, true?
Object to the form.
That is 100% true.
All right. And you were telling us about the patient's tachycardia or the heart rate of 146, about the temperature, 38.1 Celsius. What other vital signs that you consider significant appear here in the record that the nurse did not share with you when she called you at 1:15 regarding this patient?
That is just about that. There's only one more vital sign that wasn't discussed, which was the respiration.
Right.
And naturally the blood pressure. But the blood pressure was fine. The respiration was on a little high rate. But again, she was hyperventilating, she was excited, and that has a lot to do with that, most likely.
All right. Let's see. Would turn to South Fulton Medical Center record for Miss Bohannon, page 35. Do you see that?
Progress notes, progress
We discussed a majority of this record, but toward the bottom, you've indicated, let's see. Yeah. Fetal heart rate, tracing tachycardic plus variable D cells, true?
That's right.
And that's what you wrote, right?
That's what I saw,
Yes, sir.
okay? There's a piece of the tracing that I didn't see until I have finished the delivery.
All right, and which portion was that?
That's the final portion of the tracing that starts probably a few minutes
Are you looking at tracings for the 27th or the 23rd?
Talking about the 27th.
All right.
This is the 27th, isn't it? No, this is the 23rd.
Got it.
Here's the 27th.
I'll tell you, the tracings for the 27th. They begin at Southfield Medical Center, page 150, I believe.
15?
150, I believe.
No, we're looking at different versions.
Oh, well, I got the tracing here.
But we need to make sure we're on the same page. We need to make sure we're talking about the same page.
Is there a stapler?
Probably not. Here,
Yeah.
I'm gonna take these so that
Page
y'all are.
150.
There we go. I'm going to go ahead and mark this as
He's using
exhibit.
that version.
Exhibit 6 to your deposition. And these appear to be the stored fetal strip for Alekina Bohannon for Southfield Medical Center dated June 27, 2011. Beginning at about 1:12 that morning of the 27th and ending at I believe it's 4:27 that morning.
Object.
Do you have numbers on those, James?
What's that?
Page numbers on those?
Yeah, I think I went, yeah, Bates numbers,
Whatever they are, SFMC what?
FFMC 0150 to 0161.
Thanks.
Thank you.
You ever seen that document before?
I haven't seen these 2 pages.
Okay. The first 2 pages, 150 and
First 2 pages I've never seen, and my tracing begin here.
Okay, and by
It's-
here, for
it's
the
really
record, you're
impossible.
being 152?
I guess. Page 3.
When y'all say here and there, if y'all will please give us the page numbers, it's just hard for us to know what here and there is.
0152.
Okay.
And the question is, sir?
Well, I guess first my question, the first 2 pages of Exhibit 6 to your deposition, which are pages 1 and 2 of the tracing, which for this case have been labeled SFMC 0150 and 0151. You've never seen those 2 pages before?
Not that I recall, sir.
Okay. So what you've seen before and what you'd seen when you cared for Miss Bohannon begins at page 3 of the fetal strip, which is SFMC 0152, right?
That's correct. To my recollection, this is, look at that.
Yes, sir.
That's where mine starts.
All right. And you mentioned there was a portion of the strip that you didn't see until after you'd already delivered the baby.
That's correct.
Which portion is that?
The very end of it.
Okay, and that begins
Like
at,
here, begins like at I was, according to the nurse, I was there at 2:00 something. 2:16 or what?
yes, sir, 216.
And this is what I saw at that time, according to,
All right.
So
And
refer to the,
for the record, you're looking at SFMC 0157, is that right?
right. There's no notes here saying, oh yeah, here is comment, Nassar on the bedside.
Right,
Patient go to C-section 627, 219.
right.
So this is the last part of the tracing that I saw. Now, this I didn't see until I came out of the operating room.
Everything after that.
After that, yeah.
Uh-huh.
Which, this is a 3, there's no question.
Okay, and when you said this is a 3, you're talking about the tracing on SFMC 0159, true? And by 3, you mean,
Now, unfortunately, on these
answer the
tracings,
question.
okay,
unfortunately, on these tracings, there's, the Toco dynamometer was never adjusted correctly.
okay, tell me about that.
Tell me about that. Why did I say that? All right. The pressure of the contraction and intensity of the contraction is measured by a tachometer,
Right,
which measures the pressure of water that is occurring while the uterus is in contraction.
right,
It is naturally much more accurate when your assessment is done intrauterine with a special equipment.
right,
This is external. It would have been almost not an easy thing to do here due to the habitus of the patient, not only that, but the tumors. And then there would have been a lot of interference doing that. Now, I can see on the tracing how they try several times to adjust the tachometer. And you see that almost every other page until apparently they just gave up on trying to adjust that.
and that was, it appears to you that they gave up trying to adjust that on about page,
Well, I don't think they gave it up, completely. But they adjust, I can count at least 4 adjustments here on the tachometer.
right, and first of all, who's responsible for adjusting the tachometer?
NURSE.
The nurse. And it's important to have that adjusted properly because these fetal heart strips give you information that, as a physician caring for a patient about to have a baby, that's information you need to care for that patient. True?
Accuracy,
Yes, sir. Accuracy is important. True?
most important,
Okay. Imperative.
imperative.
All right. And you didn't have that here because the nurses didn't properly adjust the tachometer.
I don't know. I don't know that. All I know is that this is not adjusted.
Okay. The tachometer is not properly adjusted.
It's not properly working, and even the machine tells you electronically, I'm out of whack.
Right. And show me where the machine's saying, I'm out of whack.
I read that here. Inoperative, not transmission. Inoperative, taco. Inoperative, taco.
What page are you on?
Taco, inoperative.
Dr. Nasser, what page are you
He's
on?
Oh,
He's on 151.
page 151 on.
From Southwold Medical Center, page 0151 on, the tachometer is letting the nurse know it's not operating properly. True?
True.
Object to the form.
And,
And she adjusted.
okay. And it's imperative for you to have accurate information in a situation like this with Ms. Bohannon to properly care for the patient. True?
It's very imperative, true.
All right.
And the reasons are clear. We're dealing with a disease that is based on tetany, which is an exaggerated contraction of the uterus, which we're not measuring,
Right.
you know. But if you put your hand and you take the time to spend a minute or so there, feeling the tone of the uterus, you find that the uterus is relaxed. Then, what am I going to prove that because you believe me? Or am I going to prove that because I'm not a liar? Or you're going to go on something that cannot give you any information?
Right.
You can't. They're not saying that this is true, but how are we going to assess it?
Right. And you would expect a nurse to let you know that the strip's not working properly.
Check
Right.
the form.
If you look at the nurse's note,
Yes, sir.
I'm sorry to have to talk about the nurses, but they were there.
Right.
You will see that the contractions described by the nurses throughout the labor is under 5 in 10 minutes.
Right.
That's normal.
Right. That's right. I saw that.
So if that is normal, then where was the tetany
Right. Now,
and the 10-10 pain that you brought up this morning?
right.
And there's no match for a couple of few things.
All right.
If you bring them up, I might give you answers, but I'm not bringing them up.
There are no match for what things?
Here we go. Well, no match for the times.
Okay.
This applies to almost any hospital except the hospitals that has centralized time control, which it has never existed at South Fulton facility.
Okay.
But if you just walk in one floor and you look at 3 or 4 clocks in any hospital, they have a different time.
All right.
And most of the operating room clocks, they don't even work. They stopped.
Right.
Dr. Nasser,
At
what,
South
what,
Fulton.
what question are you answering right now?
I'm answering the
What- what-
question at
Well, he
not
can
matching
explain.
things,
He can explain.
not matching the
I will let
times.
him explain if there's a question, but either we can read back the question or you can tell him what your question is.
He was explaining the centralized time control.
That's not a question.
I'm asking you what the question was that's on the table.
Okay. Explain to me what you
No.
meant by centralized time control.
Now
That's
there
the
is-
question.
Centralized time control is an electronically controlled clock system around the hospital.
Right.
Okay? In which you don't have to send one person to put the clock back 1 hour. It might take several weeks to happen that, or to go forward 1 hour. But they go from a central office, they push a button, and everybody starts at 12:07 today. And every clock reads 12:07. Modern hospitals are equipped with that, okay? But older hospitals, there's no way they can do that.
South Fulton Medical Center was not equipped with that. True?
Maybe 99% of the hospitals in the United States are not equipped
Okay.
with that.
All right. So you mentioned there were some other issues that when you reviewed these records in preparation for your deposition here today with the nursing notes. Is that right?
Check to
Well,
the form.
Join.
Let me answer.
The one thing that I was talking was about time.
Yes, sir.
I explained about the clock. Do you want to know anything more time things?
Well, anything else regarding the nurses that you?
I don't know that because I wasn't there.
Okay. But you mentioned when you reviewed the records, there were some issues with what you saw had happened regarding the nurses.
Check
Yeah,
to
with
the form.
Object to the form, it's very broad question
Okay.
and difficult to answer.
You may answer
Answer what?
the question. You want him to read it back?
Yes, please.
Okay.
You mentioned that you reviewed the records, there were some issues with what you saw regarding the nurses. And all objections.
Same.
Well, I answered to that question that I wasn't there. I can't really do that.
Okay.
But what else is the question? Is there any other compound on the question?
Yeah, but I think it's a few questions back. I don't,
South Fulton Medical Center was not equipped with that, and that was referring to the time sinking, I guess you'd call it.
okay.
I did refer to that this morning, remember?
Yes, sir. All right, if you would, turn to South Fulton Medical Center, page 0017, which is obstetric discharge summary. You see that?
Yes,
Maybe a tab.
I can show you mine.
yeah, that's fine.
Which page are you on?
Sh-
I got it. It's right here. Dr. Nasser, I got it
Oh,
for you.
okay, thank you.
Seventeen.
Is this your discharge summary?
That is correct, sir.
Up in the upper right-hand corner where it reads comments, would you read that aloud, please?
41-year-old female, O positive, EDC 726, diabetic, insulin dependent, advanced maternal age, chronic hypertension, late prenatal, profuse vaginal bleeding with abruptio placenta, polyhydramnios. Emergency primary C-section, male Apgar 230, small for gestational age, 20 grams, large fibroid uterus, placenta with at least a 50% abruptio, estimated blood loss between bleeding and clots, 900 mLs, BTL done at bilateral tubal ligation done at patient request during emergency C-section.
Yes, sir. And so you wrote profuse vaginal bleeding because Ms. Bohannon had profuse vaginal bleeding, true?
There we go. These are terms, okay?
Yes, sir.
Shall we use mild, moderate, severe? Shall we use profuse instead of severe, or abundant? I mean, these are lax terms that we don't have measurements. We can say mild is under 100 ml. Moderate is between 3 and 500 ml. Severe is beyond. This is something that you pick up on your eye.
Right.
That this girl is bleeding heavy.
Right.
Okay? And so sometimes I use heavy, sometimes I use profuse. The nurse use profuse vaginal bleeding. That's where the term comes from.
Okay.
I mean, I've seen people lose a pint of blood a minute, okay? That's heavy bleeding.
Yes, sir.
This wasn't, and if you read my assessment, I also wrote the amount of bleeding there was moderate. It wasn't that much of bleeding at the time.
Okay.
So I don't know how did the other people assess. I have to assess what is on the record.
Right.
And on the record, at one time it was called heavy bleeding, that she needed to travel by ambulance.
Right.
And probably, if they don't put heavy bleeding, the ambulance don't get paid either.
All right.
And this is true.
Yes, sir.
So I just followed the.
This is your discharge summary, true?
That was my discharge summary.
And you wrote profuse vaginal bleeding here.
Yeah, I
sir?
did write that. I'm not denying it.
Okay, and that's because that's what you observed, true?
I do that because I think that 900 mLs is heavy bleeding.
Okay, and heavy or profuse, it's the
It's
same.
the same.
All right. And then immediately beneath that, or below that, so will you read this portion again?
Polyhydramnios.
Right. Polyhydramnios, again, a risk factor for placental abruption, true?
We discussed that several times, yes, sir.
Right, and immediately beneath that,
Remember, the patient was not polyhydramnios at the time that this happened.
right, and immediately beneath polyhydramnios,
Yeah, I put that
Next two lines.
polyhydramnios. And my operative report addresses that.
He's
That's
asking
right.
you what's underneath, to read what's underneath.
just these two lines?
Emergency primary low cervical transverse cesarean section.
Yes, sir. So what you performed was an emergency cesarean section, true?
I hope it was.
Yes, sir. And that's what you let the nurse know to get the OR, the operating room, ready because you knew you needed to perform an emergency cesarean section,
That
true?
is correct.
And you also wanted the mother ready to go, in addition to having the OR ready to go, true?
That is correct, sir.
And you wanted the anesthesiologist to get the patient ready to go as quickly as possible, true?
Yes.
And if general anesthetic would have the patient ready to go quicker than a spinal, that's something you would have preferred the anesthesiologist do, true?
Object to the form.
You may answer.
Not necessarily.
Okay.
Not necessarily.
That'd be up to the anesthesiologist.
That's his business. He chooses the anesthetic that he sees most indicated for the case.
Okay. And beneath that, you wrote at least 50%
Placenta
abruption.
abruptio, I'm sorry.
Right. And at least 50%, that means half the placenta had peeled away from the uterus, true? Uterine wall.
Again, this is an appreciation
Yes, sir.
of what you see. If you look at these notes on the size of the clot, was the clot too widely spread on the placental maternal phase, or was the inclination at which I was looking at the placenta, or what? Now, in the pathology report, there's not even one word mentioned about abruptio, which I'm sure you noticed.
Yes,
But
sir.
I don't know if it was because somebody came in and picked up the placenta and cleaned it up and then sent it to pathology, or the placenta lost the blood clot attachment, or what?
Right.
Object to the speculation, move to strike.
So,
John,
you may answer.
Testify to what you know, not what you don't know.
No,
Okay.
you can explain your answer.
Well, this is knowledge. This is all over the charts.
Right.
I'm just saying, testify to what you know, but you don't have to guess.
Oh, no, I'm not guessing. Two things I don't do, guess or
Right,
lie.
and I'm not asking you to guess, and you're doing fine, doctor. You were talking about how, we were talking a little bit about the pathology report, and what we were talking about is your note in the discharge summary from Ms. Bohannon, where you wrote at least 50% abruptio.
That is correct.
And by at least 50% abruptio, what you meant when you wrote that is at least 50% of the placenta had peeled away from the uterine wall, true?
No, 50% of the clot was occupied by the clot,
Okay.
right? Whether it's positional or not, I don't know.
Got it, okay. But it meant that in either case,
Half of the placenta supposedly detached.
right, half the placenta was detached, and that half the placenta that was detached was not getting oxygenated blood to the baby. True?
Supposedly, theoretically, yes.
Right.
Well, half of them wasn't perfused. Now, what we don't know is if that amount of abruptio was present at the time
Right.
of labor. We don't know that.
Right.
Some of that could have happened at the time of delivery itself.
Right.
It's impossible to determine that.
Right. But more likely
But
than not.
There wasn't a
Wait,
sizable.
let him finish his
That's okay.
question.
That's fine.
I'm sorry.
No, you're fine. More likely than not, there was at least a 50% abruptio at the time the baby was delivered.
That's what I said.
Right. And you said that's, an abruption can be, I think you said 5%, 10%, of course, 50%. In your experience, how often have you seen a placental abruption that's 50% or more?
Oh, I've seen babies floating inside of a uterus, and the placenta is not even attached. It's not even part of the whole system.
Right.
It's just swimming in there.
Right.
Those are acute, massive abruptios.
Right.
So it goes from 5% to 100%,
Okay.
and it can happen very fast.
Right. All right. It's you would agree, doctor, that a baby's not going to survive in a uterus for a whole long time if there's at least a 50% abruption of the
Object to the-
placenta. True?
Object to the form.
Join.
You may answer.
What do you mean by survive?
How long can a baby live, a fetus live in a uterus with at least a 50% placental abruption?
Object to the form.
It's hard to tell, It depends so much on the reserve of the baby, on the maturity of the baby. You take a premature, more premature than this, it's a borderline premature by size, 2,500 grams. You take a string premature, 29 weeker.
Right.
That baby has half a chance that has a 34 weeker or a 36 weeker. So that one, in the base of, in the context that we are talking here, a person that has so many other factors shooting at her, blood pressure, disorderly diabetes, quote unquote, increased amniotic fluid. She's got to have a metabolic syndrome because she's got every component in it, even though we can't treat metabolic syndrome during pregnancy. So there is more against this baby that there is in the baby's favor. How long is that going to last to keep her baby's vital signs present? That doesn't mean a person is alive, but there are vital signs. I don't know. I cannot answer that question the way you would like to have it, which is a time duration.
That's fine. So with the constellation of signs and symptoms that Ms. Bohannon was exhibiting, which you just shared again with us, it was imperative that that baby come out as quickly as possible. True.
As soon as we could get it.
Yes, sir. Looking at Plaintiff's Exhibit 6, which are the fetal strips beginning page 1 to page 12, which are SFMC numbers 150 to 161. You agree that the strips reveal an initial fetal heart baseline within the normal range?
These are variables.
Yes, sir.
There's good variability, not same here.
Okay. And that's, for the record, you're looking at pages 1 and 2, for SFMC, pages 150 and 151. True?
Yeah, can we just, because this and that and here and there, just, I'm sorry, isn't computing for all of us down here at the end of the table. Can you just tell us what page?
That's fine. So, and now, as the fetal heart strips, from page 3 back, you see deterioration. You see fetal tachycardia and also repetitive late decels and loss of variability. True?
Check to the
I
form.
see that happening from page 4 on.
Okay.
Read what the base label is on that for them.
0153,
Okay.
0154, and on
Yes, sir.
and on. There is loss of variability, reduction of variability, which gets more and more. And then there is something that I don't understand, and I need
Yes,
to
sir.
ask this question.
Well,
All
I'm
right.
going to object to the
Yep.
responsiveness of that since there's not a question.
That's
on it.
right. There's no question on the table, Dr. Nasser, so
I cannot ask questions. I'm
No.
sorry.
Sure.
You don't-
Yeah, doctor, I'd like to know what your question is regarding this strip.
To me,
Well,
the
this is
question
not-
Nasser, this is,
is
You
not
can answer.
allowed for me to answer.
You may answer.
you have answered you answered the question, which was about what you saw on the fetal uterine
Okay,
strips.
fine.
Okay,
So,
you don't ask.
I answered already the question.
Yes.
Good.
No, he said he had another observation. I'd like to know what that observation is.
I don't think that's what he said.
No, he
You
didn't.
may answer.
He did.
Go ahead, doctor.
This race is ending at 4:28 in the morning. At 4:28, the patient was already in PACU, okay? So how could this trace be here? You following me?
Okay, so that's your. So he's answered your question. Do you have another question?
Yeah, and I think I know what the baby was delivered at 3 o'clock. True?
Check to
And
the
we have
form.
recordings at 4:28.
Right. So how is that possible? That's my question.
That's the question that I wanted to ask all the science sitting here.
Nobody wants you to answer it, though, do they?
I know. It's like in,
But you can answer it,
like the
fortunately.
European soccer. Nobody wants to win the Liga.
But I want an answer. What are your
I
thoughts?
don't know the answer to that. I wish I knew the answer. I wouldn't be sitting here, believe me. That means that clock is also out of whack.
Yes, sir.
So if that's true, everything that we had been talking about on times is not accurate.
Okay. All right. Let's see. Yeah, my next question, I believe this ends at 4:27 on 27 June 2011, which is 43 minutes after Xavier Xander Bohannon was pronounced dead. True?
Yes, sir, I agree. It's true.
And that doesn't make any sense to you either, right?
No, I'm losing here almost 2 hours.
you would, let's have a look at page 120. So, or other comments about the scripts?
Let me flip to you to 120.
It get worse.
Sir?
Then it becomes a 3.
Yeah. At what point
Turn
does it come to a
That's the
come to
point
three
that,
interview?
that's the one that I haven't seen until after I finish my C-section.
Okay.
This tracing here. This maybe 4.
You're gonna have to
5
say the
pages.
page number, and I,
Page 7 on,
okay,
That's 156 SFMC.
page
On-
6 on.
Okay.
Is there a
That's
question on the table?
155 SFMC to the end, or 160 SFMC. That's a grade 3 in your view, right? Category 3?
Category 3 tracing.
All right.
okay.
And by category 3, that means,
What I call there on my notes all over, fetal,
distress?
there's so many ways to describe that, you know?
Yes, sir.
You can describe it as fetal distress, which we don't use that anymore.
Okay,
We call them ominous tracings.
all right.
We call them type 3 tracing. We call them non-reassuring, which
Okay.
I think is the most social of all the terms.
All right. So from South Fulton Medical Center, page 155 to the end of that strip, which is Exhibit 6 to your deposition, those strips you would consider ominous, non-reassuring, category 3, true?
That's correct.
And those weren't shared with you until after you'd already,
When I was
Object to the
actually
form of that.
finished with the case,
Right.
there is a point here that is very important to bring up.
Yes, sir.
And that is that those things occur after we already decided what we're going to do.
right,
So whatever was happening there was the time that patient was being get ready and the operating room being prepared and everything was geared towards getting that baby out.
Right.
It didn't make a difference what was happening on the tracing because nothing could be done any faster than what we were trying to do.
yes, sir.
So, and everybody was doing something else.
Yes, sir.
So probably that's the reason why I didn't see those, even though it wouldn't have changed anything,
Yep.
unfortunately.
So those strips beginning at South Fulton Medical Center, page 155, the ominous tracings, the non-reassuring tracings, the category 3 tracings, you weren't alerted to those, true?
Object to the
Object to the
form.
form.
Join.
Misstates
I
testimony.
didn't say that.
Okay.
I didn't say that I was not aware. I said I saw him after the effect.
Right. Well, that's what you were not made aware of those before you started the surgery, true? The C-section.
That is correct. If you notice my notes, they all talk about a type 2 tracing.
Yes, sir.
Variable deceleration, stack, things like that. At no time I enter this, and I have already even signed the tracings
Right.
when I saw that.
Wow. All right.
We discussed that.
We
remember?
don't talk about what we discussed.
Yeah, I know, but I'm sorry. I suppose you, not to involve you.
Oh, that's fine.
But, yeah.
Yeah, I don't
that
want to know what
happens
you
after
talked
the-
Right,
about.
I know.
I didn't add anything on the thing because anytime you lose a baby, you have to wait some sort of legal thing. And then they call you doctor the records, and I don't do that. So that's why I didn't add any further on the diagnosis.
All right.
Check to the response, move
Yeah.
strike, non-responsive.
Agreed.
So you agreed that those were category 3 tracings beginning at page 155, but you didn't go in and change the record because the baby had died and you didn't want to be accused of somehow manipulating the record. Is that true?
Yeah, well, I already have signed and written what I thought I have said.
Yes, sir. Well, then that was what you'd seen because you didn't see these tracings until after you'd already performed the surgery.
Is it, whose fault is it? I don't know, but
But
that's
not-
how it was. We were taught never to add anything on a
Right.
record.
And now you expect the nurses to alert you about ominous and non-reassuring tracings, true?
Object to the form.
Join.
You may answer.
Okay, I have to say something here because
You need
this
to
is
answer the
important, and this is to
question.
answer
This is the
his
answer.
question. The nurses mention on the notes
Right?
at grade 3 tracing.
Right, that's right.
This is nothing new there. But
Right.
look at the time that they make the note.
Right.
Okay, so the nurse was with the patient. She make her notes correctly. I don't know exactly the time that occurred, but that is, I didn't. And on the other hand, the philosophy is, what else can he do? Probably, I don't know. This is now me adding on things that I shouldn't guess. But probably
don't
that's
guess.
what they don't,
Don't guess.
yeah. That's probably why they didn't transmit the new tracing.
You're sitting
Because we were waiting to do the case.
waiting on what, anesthesiology?
No, I was waiting for my patient to be ready so I can cut it.
Right, well, and for
In
your
the
patient to be
process,
ready.
there's-
Wait, let him finish the question, okay? You guys can't talk at the same time or it won't get on the record.
Okay,
For your patient to be ready, the anesthesia has to be working, right?
that's correct.
Okay. Now, you were talking about the notes where it reads Category 3. If you would turn to page, let's see, 130, Southport Medical Center, labor and delivery flow sheet.
I had this just a second ago, hold on.
Ay, ay, ay. 130?
Yeah,
sir.
that's-
Blondiness. 130. Okay, sir?
Yes, sir. If you look at the bottom, actually the very bottom of that labor and delivery flow sheet, beginning at 1:37 that morning, the category, and this is a category for the tracing. What's the category at 1:37 according to the labor and delivery flow sheet?
This is disturbing.
Yes, sir.
According to this, the
Yes, sir.
category at 150 is category 3.
Yes, sir. And also at 1:37 and 1:40.
That's correct. And at
144.
216. You see? So,
Hold on. We're looking at two different. Yeah. Okay.
now,
Wait for the
Let's-
question.
this time here, at 2 o'clock, I'm supposed to have been sitting next to the patient's bed, right?
Right.
And this, I was not
Category
aware
3.
of.
Okay.
What time are you referring to, Dr. Nasser?
Here it starts at 1:50, even before I arrived to the hospital, according to this timing.
Yes, sir, I appreciate that, but what you were pointing to a note, and I don't know what time it is.
She just wants to know what time you're reading.
My time was,
The time on here,
On the
or
note.
the time here is 1:50,
that's all.
okay, and 2 o'clock,
Okay.
and 2:15, and 2:16. And there's 3 category 3s call-ins. So if she was aware of that, she didn't mention it.
Okay, and that's something you would want to be made aware of as a physician, true?
That is
In
correct.
fact, it's imperative that you be made aware of ominous tracings like those, true?
True.
And the tracings, just for the record and for opposing counsel here, if you look at Southfield Medical Center record 0129, one page previous,
0129.
it looks like the first category 3 or ominous tracing is at 1:45 that morning, is that right?
That is correct. That's how it is entered.
Yes, sir.
And then if you turn over to the next page, South Fulton Medical Center 0130, according to the flow sheet, it's also category 3 or ominous tracing at 150, true?
That's exactly what it says there, sir.
And at 2 o'clock, true?
Yes, sir.
And at 2:15, true?
We don't have any entry for that.
Well, at 2:16, true?
216 is true.
Okay, and also at 2:22 on the following page, 0131, true?
Uh-huh.
Yes?
Yes, sir.
And then on the following page at 2:33, also a category 3, true?
That is correct.
And we have some of those, it looks like, are left blank, is that right?
Yeah, there's no notes.
Those should be completed, true?
Object to the form.
Whatever the category.
Join.
I guess the computer has the space to have that completed.
Yes, sir.
Maybe it didn't print right.
Okay. But if, unless it's a computer error, that's something that ought to have been entered by the nurse, true?
Object to the form.
Object to the form.
You may answer.
Yes, sir, that is correct. I don't know the reasons for not printing.
All right. If you would, turning back to 126. This labor and delivery flow sheet.
Might not be in the right order. Wait, that's not the right page.
Oh, that's not the
I
right.
can use,
That's 139. Thank you. Okay, sir.
yes, sir. If that's the maternal review of systems for June 27, 2011 for Miss Bohannon, true?
Yes, that is true.
Yes,
That's
sir.
what it is.
And it's documented here at 115, the vaginal discharge color is bloody, true?
Yes, sir.
And if you flip back to South Fulton Medical Center, 7, let's see, number 20. Let's see, I'll show you. Oh, this is your operative report.
Oh, okay.
Let's have a look at that.
I got my operative report here.
I think I can find it in here too.
It looks like this.
Here.
Yes, sir. Okay, here it is.
Can't quite get it flipped there for you, but
And for this, sir, you knew when you got the call at 1:15 that morning that it was a placental abruption, or you suspected it. You knew you had to get the baby out as soon as possible, true?
That is correct, sir.
And it took you about an hour to get to the hospital? Is that right?
Yeah, from call to arrival.
All right. And that's about, when you have an emergency C-section, about an hour's all right, in your view?
Well, it's an acceptable time
Yes, sir.
because it's over midnight. You're in bed. You have to get up. You have to clean,
Right.
dress, and drive.
Right. Are you aware of any South Fulton Medical Center policies or procedures that would require you to be there any sooner than an hour in a situation like
No.
Ms. Bohannon's? All right. If you would, looking at the page 20, your operative report, if you would just read at well, let's start preoperative diagnosis. Would you read your preoperative diagnosis?
Preterm delivery or pregnancy at 36.7 weeks of gestation,
Yes, sir.
advanced maternal age,
Yes, sir.
polyhydramnios,
Yes, sir.
chronic hypertension,
Yes, sir.
diabetes insulin dependent,
Yes, sir.
abruptio placenta,
Yes, sir.
non-reassuring fetal tracing.
Yes, sir. And non-reassuring fetal tracing, those are the same as the ominous tracings or true?
Postoperative diagnosis,
Yes. I'm
Yeah.
sorry, we didn't.
I'm sorry, I didn't answer. Yes.
That's all right.
Yeah, he hasn't asked you to do anything else yet.
Oh,
That's all right. And then, that's right, your postoperative diagnoses were what?
the same, except for leiomyoma, uteri large, multiple, and voluntary sterilization.
Yes, sir. And your preoperative diagnoses, since you wrote that on June 27, 2011 for Ms. Bohannon, haven't changed, true?
Yeah,
I mean, this is what you knew when you got the call at 1:15, and you supplemented that information with what you found on arrival, true?
that's correct. That's the
Yeah.
difference.
Sure. Yes, sir. And the postoperative diagnosis, this is after you went in and delivered the
Find
baby?
the rest of the stuff.
Yes, sir. And the name of the operation was what?
Primary emergency low cervical transverse cesarean section, bilateral tubal ligation.
Yes, sir. So this was an emergency C-section for sure, right?
Yes, sir.
You had to get the baby out as quickly as you could, true?
That's correct.
And the anesthesiologist you were relying on to take care of the anesthesia was Dr. Ketchy, true?
Dr. Ketchy, yes, sir.
And then immediately beneath that, it reads pathology, and this is your note. Would you read that note, please?
This is a
Just the
41
first paragraph. Yes, sir.
Okay. This is a 41-year-old female admitted by ambulance to South Fulton Medical Center because of profuse vaginal bleeding that started approximately 1 hour prior to admission. Patient has been seen in our practice for a few times with complications based on late prenatal care, advanced maternal age, polyhydramnios, chronic hypertension, diabetes, insulin dependent. She has been followed by Dr. Sadin for her diabetes and a prenatology group, Atlanta Prenatology Associates. The patient is very well aware of the possible complications. She was assessed on admission and showed profuse vaginal bleeding, as well as the infant a few minutes after admission became tachycardic with variable decelerations present. That's not good English, but that's what it says.
Yes, sir.
Patients did not have uterine tetany at a time during the pre-op admission time. The pre or admission time. Contractions, that doesn't make it. Patient did not have uterine tetany at any time during the pre or admission time. Okay. Contractions were present about every 3 minutes, but there was good relaxation between contractions. In view of this situation, the patient was taken immediately to the OR, where an emergency low cervical transverse cesarean section was performed. At the time of the cesarean section, large leiomyoma were present on the uterus, especially on the frontal side and right horn of the uterus, corners of horn.
Yes, sir.
This leo measured at least 12 centimeters in diameter. Large varicosities were on the area of these large fibroids. Other smaller fibroids were present posteriorly. The tubes were essentially normal, as well as the ovaries. There were a couple of small pedunculated fibroids, approximately 4 centimeters in diameter,
That's
and
good.
a pathology.
That's good. And at the bottom, your estimated blood loss, about 900 milliliters.
Estimated blood loss and blood clots together 900 ml.
And on the following page, one last note, looks like.
The infant was declared dead about 20 minutes after birth.
James, if you're leaving the operative note, we can take a really quick break. I
Oh,
Paper
of
cut
course,
my
of
finger
course.
when I flip that page and I need a Band-Aid.
Wow.
All right, we're on the record at 3:09
I'm on
PM.
the-
We're back on the record at 3:21 PM.
Labor and delivery flow sheet, it's SFMC 0128.
It's the flow sheet. I know. but-
128.
Yes, sir. This is the labor and delivery flow sheet for Ms. Bohannon on June 27, 2011. And at 115, under vital signs, it's got an HR, right?
Uh-huh.
Yeah. That stands for heart rate, true?
That's the patient's heart rate. Yeah.
Yes, sir. So at 115, Ms. Bohannon's heart rate was documented at 146, true?
That's what is written there. Yes, sir.
And it was also documented to be 146 at 117 or 2 minutes later.
Right.
And that's what you were talking about earlier when you were talking about the patient's or Ms. Bohannon's tachycardia, right?
That is correct.
And that's something you would have wanted to be alerted about, true?
True.
And the nurses did not share that with you, that information with you, true?
That is true, sir.
Okay. That is true that they did not share that with you, true?
That is correct.
And immediately beneath that, or down below, it reads pain and the pain scale. And it's got pain scale of 10, right?
That's correct.
And pain scale of 10 out of 10 is the worst imaginable pain, true?
You can't stay in bed.
Right. And next to pain location, it's got abdomen, true?
True.
Which would refers to the where the baby is, or the abdominal area, true?
True, sir.
Okay. And it also reveals fetal assessment at 115 of a category 2, true?
That's correct, sir.
And a category 2 is different from a category 3.
Yes, but it's at the same time, though.
Yeah.
All right.
It also reveals here on the vaginal exam dilation of 7.0, true? Let's see.
Yes, that's, we went through this already, didn't we?
Well, it was a different portion of the
Oh, a
record.
different
but-
portion. Okay, yes, that's exactly correct. That's what it says.
And when you did your own vaginal examination, it was a course of 5.0.
That's correct.
Let's see. Pain. If you would turn to SFMC 0035. We're not going to go through this whole, it would be over here. Be your orders in the progress record.
Oh, progress.
Yes, sir.
Progress notes.
We've covered a portion of this. I'm just,
There.
James, what you're
0035.
referring to now are not pieces of exhibits you've marked today. You're just looking at the actual medical record that he is looking at as opposed to making them exhibits. Is that right?
well, we'll go ahead and make the
Now,
Southfield
I'm
Medical
not
Center.
trying to make you do that. I just want to understand what it is he's looking at.
Yeah, and for the record, I don't know if I did a clear enough job earlier when we asked Dr. Nasser what he'd reviewed only a portion of the Southfield Medical Center records. And what what he's been doing as we've been talking about the South Fulton Medical Center records for this visit. We've been referring to the ones that were produced by Counsel for South Fulton Medical Center by SFMC and the page number, the Bates stamp page number.
That's fine, thank you.
Is there anyone prefer me making those an exhibit to?
As long as we have a good identification of what the doctor's looking at when he's looking at it, I don't care.
Right
Well, why
now,
don't
he's
we-
just looking at a set of the South Fulton records. You're correct. It's not a portion that was marked as an exhibit.
Okay, thank you.
Well, let's go ahead. I'll supply a copy to Steve. We'll mark it as Exhibit 7, the
Okay.
medical record. Then there won't be any question about it. Right.
That's fine.
If it's all right, I'll just email that to Steve. Everybody all right with that?
That's fine with me.
Jeffrey?
Sure.
Okay. Where were we? At the very top of SFMC 0035, which we sent marked as Plaintiff's Exhibit 7, the entire South Fulton Medical Center record for Ms. Bohannon. It reads admission. Could you just read the first 4 lines here?
It says admission brief note.
Yes, sir. Brief note.
Call about Mrs. Bohannon, admission by ambulance because of severe vaginal bleeding. No pain.
Yes, sir. As you shared with us earlier. Right. We discussed briefly AROM, or artificial rupture of membranes. You felt like that was not the standard of care in this case. For what reason?
Object to the form. That misstates his testimony. He didn't talk at all about the standard of care.
Okay. You may answer.
Go ahead.
Go ahead.
Yeah.
All right. Yeah, we talk about, and I was explaining that the presenting part was not at 0 as he was
Right.
stated on the
Right.
chart. That I couldn't even feel the
Right.
presenting part.
Right.
And by rupturing the membranes, which was a bulging bag of water under pressure, all I could cause is more problem by having a prolapse cord.
Right. If what the nurses had written in the record were accurate as far as the effacement, would that have been something you might have considered?
Definitely.
Okay. If you would turn to, again, the labor and delivery flow sheet. This is page 131 of the South Fulton Medical Center record. Yes, sir. And in the right-hand column on SFMC 0131, the labor and delivery flow sheet for Ms. Bohannon, at 216, the annotation comment reads, Dr. Nasser at bedside performs vaginal exam, gives decision patient to go for C-section. True?
That is exactly correct.
And that's the note that indicates that you were there at 216. True?
Yeah.
But the portion about decision patient to go for C-section, that decision had actually been made an hour earlier when you told the nurse on the telephone at 1:15 that you were en route to get the OR ready for C-section for Ms. Bohannon. True?
Object to the form misstates his prior testimony.
John?
May answer.
Yes, I did say that.
And that's accurate.
As far as I'm concerned, yes.
Yes, sir.
There's no notations.
Right. And you've heard the phrase for 40 years or so, not documented means not done. True?
that is something that we say continuously, to especially to young people. If it is not written, it didn't happen.
Right. And that's why it's very important for medical records to be accurate, true,
Correct.
and for nurses to record things like,
Accurate.
yes, sir, and to record things accurately, true,
True.
and to record, for instance, what you said at 1:15, get the OR ready for C-section for Miss Bohannon, true?
That is correct, sir.
And that's important so that, if other people are looking at the medical record or come in later, they know what's going on, true?
That's correct.
It's also important so that if you look at the same records later, it'll help you remember, what was going on, true?
That is true.
It's impossible to remember everything going on with every patient unless you accurately record what's going on, true?
True.
And then the C-section began at 44 minutes later at 3 o'clock, true?
I don't know if it's true or not.
Okay,
That's what the papers say again.
right,
I know that I was there. I was cooperating with everybody. I even prepped the patient. And when the patient was ready, I did my thing. The problem is, I don't know anything about times. Is being brought up here several times.
yes, sir. You were there at the hospital from 2:16, ready to perform the emergency C-section as soon as the patient was ready, true?
That's correct, sir.
And if the patient had been ready before 3 o'clock, you would have performed it before 3 o'clock, true?
I could have done it 2 minutes after. After I got out of the patient room, I was ready. I didn't have anything, not to go
Right.
to a party or anything.
Right.
I came down to that party.
Right, you could have done it at 2:18, true?
I could
Yes.
have done it 2:18.
2:19, yes? Yeah, yes?
Yes, correct.
And any time after that, and before 3 o'clock, had the patient been prepped, sedated, and ready to go, true?
True.
Now, if you would, turn to tab, let's see, page 91. This is a portion of the record that deals with anesthesia.
Oh. How do you know all these things so well?
What number? What page number?
91. SFMC 91.
You supposed to say?
Sorry.
I said,
Intraoperative record. Page 1. Yes, sir. And I'm now referring you to SFMC, page 91, which is an intraoperative record. And it reads here anesthesia, and it's got times, true?
Yes.
And the times, according to this record, and Southfield Medical Center did not have a central timekeeping, so these may or may not be accurate, but the times recorded here under start arrive times for patient in OR was 6:27:11 at 2:40 a.m., true?
That's what it says here. Yes, sir.
And anesthesia, it looks like that wasn't started till 2:35 that morning, true?
In another clock, yes.
Yes, sir. Okay. Whatever clock.
I mean, this is what I'm talking about, and
Right.
you're talking about probably the same.
Right.
That 5 minutes to do all that,
Right.
I don't know. I know my friend is good,
Right.
but it's 5 minutes. I mean, the man, 5 minutes ago, he was by the patient's bedside according to this record.
Right. Well,
And now we are in the operating room at 2:40.
well, actually, yeah, it's got the patient in the OR at 2:40, and anesthesia started at 2:35. Does that make sense?
Yes, I had by now 10 minutes. Yeah, he's good. I mean, he doesn't play around.
Right.
When he's going, he's going. This
Right.
is why I'm saying it wouldn't have made much of a difference scratching this patient or not.
Right.
crashing, you mean,
Put in a slip.
okay, versus emergency?
That has really nothing to do with.
Yeah.
I'm not an anesthesiologist, I'm supposed to discuss this. But his spinals are very good spinals, precise spinals, that don't produce the complications that everybody complains of his spine as
Right.
when he's a resident. We're
Right.
talking about a man with 30+
Right.
years of experience,
Right,
a very good anesthesiologist, if I may say that.
right,
So that's not what I'm criticizing here. What I'm saying is, again, we are dealing with the same clock.
right. Well, but as far as anesthesiology, the best anesthesiologist in the world can't get a patient ready as quickly with an epidural as they can with a general anesthetic. True?
Check the form, like
Join.
conditions.
You may answer.
That is true, but this is not an epidural.
No, I'm not. Well, I'm sorry. He used a spinal anesthetic, right?
This is spinal. Spinal is a single tap, bing, bing, out.
Got it. But the best anesthesiologist in the world cannot get a patient ready as quickly with a spinal as they can with a general anesthetic. True?
Object to the form.
Join.
Join.
I really don't, I'm not qualified for
That's
that
fine.
answer.
Page SFMC 20.
Wait for him to tell us what it is now.
Well, this is the,
The operative note.
yes, sir. If you would, the second page of the operative note, which is page 21, description of procedure. Just read that, that first sentence only.
With the patient prep and draped in usual manner for abdominal surgery under adequate spinal anesthesia, a transverse incision was made down to the peritoneum, which was open vertically.
Okay. And so it was a spinal anesthesia that was used to get the patient ready for you, true?
Yeah, this is standard.
Right. Well, spinal anesthesia is not standard for an emergency C-section, true?
Object to the form. He just said he wasn't qualified to answer this.
I'm
Same
not
objection.
qualified to
Okay.
answer that.
All right.
Thank you.
If you would, turn to page 89, SFMC 89. This is the anesthesia record.
The one we just looked at. Okay, sir?
Yes, sir. This is the anesthesia record for Miss Bohannon, true?
Apparently.
Do you recognize Dr. Ketchy's handwriting?
Yes.
Okay. Up at the very top, procedure, can you read those first two lines?
If you can't, that's fine.
C-section and abruptly on two, but I don't know those first two words.
Okay. It reads, parenthetically, there, suspected abruption, true?
Is that what it says there?
Well,
I don't know.
if you don't know, that's
No,
that's
I
what
can't
it looks
make
like
it
to me.
up. I thought on the top line
Yes, sir.
here, it might say emergency, but
Right.
because I think I would consider that word as being written there. But underneath is a duplication of the same word.
Okay.
So
Well,
I don't know if it is emergency or what, but
All right.
is C-section and abruptio I can bring up.
Okay. It looks to me like it reads emergency C-section, parenthetically suspected abruption.
Suspected.
Okay, well,
He
I
just
don't think
said-
that's a question, and it's calling for him to speculate.
he
and
just
already
said he
said
can't
read
interpret it, so
Suspected might be too. Now that you say that.
Join the objection.
That's fine.
Okay.
Got it.
So let's presume that this is.
No, you don't need to
No.
presume.
Not
Wait for a
presume.
question.
Okay, I'm sorry, sir.
You're fine.
I was talking about the same question before.
All right, it looks like page 89, interviewing anesthesiologist, which is Dr. Ketchy, at 6/27/2011. The time he was notified appears to be, is that 2:24? Is that right?
That's what it says there.
Okay. And if you look, reviewing anesthesiologist, below that, it reads Ketchy, date 6/27/2011, time 2:24. True?
That is the date, yeah.
And it's your understanding that's the time that he becomes involved in getting a patient ready for surgery. True?
That probably is true. I wasn't there.
Okay.
I was not present here.
Right, but did you call Dr. Ketchy or anesthesia and say we need to get a patient ready for an emergency C-section?
No, I did not.
Okay.
Actually, in your pre-op orders, routine pre-op orders on emergency, when you said, get me ready for a C-section, the first thing they do is call an anesthesiologist.
Okay.
Now, when I walk in there, Dr. Ketchy wasn't there. So
Was not
somebody
there.
must have called it, because he doesn't sleep in the operating room waiting for somebody to come in for a C-section.
Okay.
So somebody must have gotten him up there and talked to him about it.
Okay. So when you walked into the operating room, Dr. Ketchy was already in there.
Yeah.
True?
Object to the form. The operating room?
I'm talking about in labor and delivery.
I just want to make sure y'all are on the same
Okay.
page.
When did you first see Dr. Ketchy with Miss Bohannon?
I saw Dr. Ketchy as I was walking in Ms. Bohannon's room.
All right.
And we briefly talked, like, let me check it out and see what's going on for sure, but I am sure that we're gonna do this.
Okay.
Something like that.
You sure you
Wait,
are an
say
emergent,
it-
an
say that
emergency
again.
C-section?
Walking into it.
Okay.
And I did my stuff.
Well, hold on.
told,
I want to. You were sure we were going to do an emergency C-section, is what you told Dr. Ketchy. True?
That's
Yeah, I
not
said,
what
I'm pretty sure this is what we're
Yes.
going for.
Right.
Could
And
you,
I
Wait,
went on.
hold on.
Okay,
Stop.
please, I'm sorry. We're not gonna have a clean record, and we'll be back here doing this again if we don't do it one at a time.
Well, you're gonna have to
Look,
do it
look, if
without
you have an
me.
objection, make it. I mean, otherwise,
Well,
you're.
then I'm objecting to the constant talking over. Let Dr. Nasser finish his answer, and then you can ask a question. All right, because otherwise the court reporter's not gonna get it down.
Wait,
Okay, I'm sorry.
that's
about
okay.
You're fine, Dr. Ketchy. It's fine. You haven't done anything wrong, for sure. And if you feel like I'm interrupting you, please stop me. I certainly don't mean to, but I am.
I don't think it's appropriate for you to be coaching or counseling the witness about whether he's done anything wrong. You're not his attorney.
Are you
Why don't
ready
we
to
go
go?
back to the, can you read the
I'm ready.
question?
Can you
Okay,
read the
I'm
question
ready.
and the last response back, please?
So where we
Wait,
were.
that's what he's going
Was-
to do.
Yeah.
Doctor, he's going to read back the last question
So
and
I saw
answer.
Dr. Ketchy as I was walking
It's
in
okay.
Ms. Bohannon's room.
Yeah, and pick up from there, please.
We briefly talked like, let me check it out and see what's going on for sure, but I'm sure that we're going to do this, or something like that. And he said, or something like that.
Okay.
And that's when she asked that he repeat that answer.
Right. Yeah, she said, could you say that again?
That's when Ashley asked.
Ashley said
Okay.
you
Can you
said
read
that
it back then one more time, what you got down, please,
Sure.
Steve?
I saw Dr. Ketchy as I was walking in Miss Bohannon's room, and we briefly talked, like, let me check it out and see what's going on for sure, but I am sure that we're going to do this, or something like that.
Thank
Can you
you.
say that again? Walking into it,
Okay, thank you.
All right.
I did my stop, and then Jim said, hold on, you were sure we were going to do an emergency C-section, is what you told Dr. Ketchy. True?
Okay,
That's not what he said. I'm pretty sure.
okay.
Okay.
And then you all started.
Yeah. All right. So when you told Dr. Ketchy, I'm pretty sure we're going to do this. What you told him was, that you were going to do the emergency C-section. True?
Object to the
Check to
form.
the form.
Ms.
Okay.
Davis' testimony.
You may answer.
You want an answer. This happened more than 3 years ago.
Yes, sir.
I can't recall the exact words that I told Dr. Ketchy when I walked in, but when I saw him, besides saying, "Good morning, Dr. Ketchy," I said, "Let me check it out, and most likely this is what we're going to do." See, at that point, I entered the room, and I examined the patient, and I called a C-section.
Right.
And from then on, there was no more communication with anyone that I needed to.
Okay. And did you tell Dr. Ketchy then that you were doing the emergency C-section?
Oh, he knew it.
He already knew it. How did Dr. Ketchy already know that you were doing an emergency C-section on Miss Bohannon?
Because he knew that I had called a C-section. Probably the nurse was the first one, because he was a few minutes, I don't know how many minutes to be
Right.
exact, but a few minutes later he was standing by the patient. That means he's going for it.
Right. And you told the nurse, of course, it would be an emergency C-section, and you would expect, if she's the one that called Dr. Ketchy, to make sure he knew it was an emergency C-section too. True?
Object to the form.
You may
This is
answer.
presumption. I don't know because I wasn't there.
Then
And
don't speculate. Just testify
Right.
about what you know.
I don't know anything about that. What went on, I don't know.
Yeah, I'm not, and let me do a better job of my question. I'm not asking you to presume anything. What I'm asking is, when you tell a nurse that we're going to do an emergency C-section, if the nurse is the one communicating to the anesthesiologist, she in turn needs to let that anesthesiologist know it's an emergency C-section. True?
Object to the
That
form.
is 100% correct.
Got it.
Once you
That's
give
it.
the order, she is the one to tell everybody that is adequate informed of that.
Yes, sir. So if that didn't happen, well, that was the nurse's responsibility. True?
Object to the form.
Join.
Sounds like. Dang, I don't know.
If you look at the next page, page 90, up at the top left corner, looks like anesthesia began at 2:35. Is that right? Up here.
Yeah.
And to OR at 2:40. Is that right?
That's what he says.
And about how long would it be from the time anesthesia began at 2:35 until that patient was ready for surgery?
Object to the form.
Object to the form.
Join.
I don't know, because you can write here,
Yes, sir.
whatever, the paper takes anything you want to put on it.
Right.
Remember one thing.
Yes, sir.
The patient might be ready for anesthesia
Right.
or already under anesthesia, but not ready for surgery.
Right.
Okay? So, and they don't have too many other questions, but it seems like this is what all they needed to know.
Right. The patient was not ready for surgery until 3 o'clock when you did the surgery. True?
Object
That
to the
is
form.
correct. That's the time that, according to this clock, I started a surgery.
Right. And you started as soon as the patient was ready for you to do surgery.
Yes, but, there are so many steps between you call and between you cut.
Right.
Even though we have guidelines for that, which around the country are not kept, because they're kind of unrealistic.
Right. And that's the guideline from decision to incision is 30 minutes. Is that right?
That is correct. That is but is a guideline.
Yes, sir.
Not a rule.
Right.
Not an ironclad thing.
Right.
Because in most hospitals it cannot be accomplished.
All right. And in Southfield Medical Center at the time, that could not be accomplished. True?
Object to the form.
Join.
Join.
Let me answer. And from the time you first
cut, or from the incision to delivery took about 19 minutes. Is that right?
That's what this thing say. The first surprise was me,
Yes, sir.
to be honest.
How long do you think it took?
I was so into it. And I was up to my neck working on this case because that is something you don't forget so fast.
Right.
I didn't have an assistant. It was a huge uterus, bleeding everywhere.
Right.
And I was trying to maneuver my knife around so I find a little hole where I could pull the baby through.
Right.
On top of that, we were aware of the fetal distress.
Right.
So I don't know how long it took. But if you see cut too close, it was exactly the same time, 1 hour. So am I defending myself? No, I'm not defending myself. I'm trying to see where usually my C-section rate, my C-section time ranges from 45 to an hour.
Yes, sir.
All right. This took an hour. Alone, no assistant, no resident.
Right.
That's not a bad time, believe me.
Well, it didn't take it took less than that. I mean, it took you less than an hour. The baby was out at 3, right?
Yeah, but
Object to the form,
Join.
misstates the testimony.
the question was,
No.
where was I doing in the first 19 minutes?
No, his question was, does the time of delivery,
Knife to baby birth
Right.
was 19 minutes,
Right.
according to that.
Right.
okay,
And what can I say? How can I change that?
That you were doing.
I was
that
working,
is-
that's all I know. Oh, another thing is that I was surprised
there's no question.
that it was taking 90 minutes, which I didn't know
Dr.
until
Nasser,
later on.
there's no
Right.
question on the table right now.
Oh, there's no question on that? Yes, you are. What's the question? No?
I
Okay,
think it
I'm
was-
sorry.
you-
Okay,
So that-
I'm volunteering too much stuff.
No. So from incision to baby was 19 minutes. True.
That's the time.
And that was, you were working as fast as safely possible over those 19 minutes, true?
That is correct, sir. I didn't want to make any. No, that is correct. The answer is correct.
All right. And what you didn't know over the course of those 19 minutes is the fetal distress depicted in the Bohannon baby's fetal strips beginning at South Fulton Medical Center, page 155. True?
According
Object to the
whose
form,
time?
object to
Sir.
the form, misstates the prior testimony.
According to whose time?
Well, according to any time, whenever.
No, we just saw, you just showed me that at 1:15 when the patient was admitted was already a type 3.
Right.
And now you're asking me the question of type 3 that I wasn't aware while I was operating. And that is correct. I was not aware while I was operating that this baby was on a type 3.
Right.
But there
Because
was people that was aware of that when the patient got out of the ambulance.
right. But they didn't make you aware of it, true?
Yeah, but that doesn't change it for me.
Well, but it's imperative for you to be made aware of category 3 or ominous tracings when you're going into an emergency C-section, true?
Object to the form.
Yes, that's true. All that is true.
Okay. And the APGAR scores, you know what APGAR scores are? Yes.
I happen to know Dr. Abgar
Yes, sir.
myself.
Yeah. You knew Dr. APGAR.
I met Dr. Abgar when I was in Boston, yeah.
Yes, sir. And Dr. APGAR, what those scores do is,
It's the worst score.
Wait,
to-
wait for a question.
I know what he's going to say.
No, you don't.
Okay, proceed, sir.
that's what those scores do is what, doctor?
That score is to evaluate a newborn.
Right.
I'm going to put an example here that has nothing to do with discrimination.
Yes, sir.
But you take a baby born out of an Indian family
Yes, sir.
or a black couple, a real
Yes, sir.
black couple,
Yes, sir. A black, a what?
a black
Couple.
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 born.
Couple. Got it. Yes, sir.
Now, how are you going to see a pink baby on those two
Right.
races?
Right.
That blows up 2 points immediately.
Right.
Right. And there are other things. This is all a suggestive
Yes, sir.
way of grading a baby.
Yes, sir.
He has a defense, and is that most of the babies that were Apgar in the beginning were all white. So
Right.
that wasn't very difficult.
Right.
And people were trained with white babies.
Right.
But that's not the same when you Apgar in babies at Grady
Right.
or in any other community hospital where it's mixed races of all kinds.
Yes, sir.
And the Apgar was always done by doctors. That was abolished in this country now for probably 20 plus years,
Yes, sir.
where they have evolved with NICU nurses and all that are the ones that call the shots.
Right.
So the defense of this is Apgars below certain level are not really predictive, but certain other Apgars are extremely predictive. All right. In this case, we have a 1, 2, 3 or something, or 2, 2, 3, or
In this case, we have 2 at 1 minute, 3 at 5 minutes, and 0 at 10 minutes.
that's non-predictive, as you can see with the 0 at 10,
Right.
because of the low scores that we had at 1 and 5.
Right.
But if you get an Apgar of 5, I've seen Apgars at 1 minute that they give them a 5, and at 2 minutes it's 10. And then you ask the person that is giving these numbers, how did you die? What was the miracle
Right.
here? That in 1 minute you turn a 5 to a 10.
Right.
And they say, well, he turned pink. That's it. So it's a subjective score.
Right.
A lot of people don't believe in it, but that's the only rule we have to grade babies.
Right. So most of this we've already covered.
Is it too tight?
I know I'm safe here.
Tuck under there.
Yeah, I know. I did it that way, so I won't feel any tension on it. Then I'll have to pay for that. No, I don't want to.
You weren't involved in neonatal intensive care unit or NICU care for this baby at all, true?
The only involvement that we have there is when we're going to circumcise a baby,
Okay.
and that's it.
Right. And you didn't circumcise
And
this
only
baby?
when they say the baby can't be circumcised,
Got it.
then you go in and do that.
All right.
Otherwise, we don't even say hi to the nursery people.
And you didn't do that here either, true?
No.
Did you
No
witness?
experience.
Did you witness any of the resuscitative efforts by the NICU team?
Well, we don't do that for a long time, but we were trained to do the resuscitation.
Yes, sir.
And during those years, there was no teams. It was just the whoever was present, and if the baby needed resuscitation, we'll go on and do it.
Right.
And then by the time the pediatrician or the pediatric resident came in place to cover, But yes, we used to do that.
I don't-
Legally, it's not a smart thing to get involved today.
I don't know if you heard the question correctly. He said, did you witness the
No, you-
resuscitation in this case?
Oh, I didn't hear that.
That's
I'm
what
sorry.
I thought.
I think we had a couple, I mean, yeah, I think you answered the question. You didn't have any involvement in the
No,
resuscitative
not
efforts of this
whatsoever.
baby,
You
true?
can witness something if you're operating,
Right,
because
right,
they are in a different corner.
Right.
You either witness that or you witness your patient.
right. So when they were making the resuscitative efforts, you were closing up with Miss Bohannon, true?
Whatever.
Okay, and you didn't witness any of the resuscitative efforts, true?
Yeah, I didn't know. I don't. I actually, to be honest with you, I didn't even hear when they said that the baby has been declared.
Had died.
Yeah, and it was later on when I asked, you know, when I was through, I said, well, how's the baby? He said, they call the baby 20 or 30 minutes after. I haven't heard.
They told you the baby didn't make it.
That's when I learned, yeah.
Do you have an opinion about what caused the baby's death?
Anoxia?
Okay. Lack of oxygen? And do you have an opinion as to what caused the anoxia?
All right, this is usually a trend that follows. In this case, anoxia is explainable because of detachment, shortage of oxygen. The oxygen that you apply to the patient is never going to make up for the one that is missed.
And that's the 50%.
Circulation is not, the oxygen is there, but the circulation is not working properly to transfer. So anoxia leads to, well, hypoxia leads to anoxia and leads to acidosis,
And that caused the baby's death. True?
unfortunately,
Yes,
yes.
sir. And the hypoxia, or the lack of oxygen, was caused by the placental abruption, which appeared to you to be in excess of 50%. True?
Not only that, no, but this patient, oh boy, here we go again. Well, she's got intrauterine growth retardation syndrome, okay?
right.
Small for gestational age, is very evident just on the weight,
Right.
and on the conditions that were along with her,
Right.
okay? The age, and plus the chronic conditions, chronic hypertension, diabetes, all of those are predisposing to SGA. So there was already a well-fertilized land to put seed there. But the seed didn't grow well because not enough fertilizer, I guess.
Okay.
The situation is that this baby is what we can qualify and call that this has been a prolonged thing. This is not a one-day type of thing. And the survey that we were able to do, unfortunately this baby was born when the survey was supposed to start more intensively, calls for good BPPs, biophysical profiles. So that was good to know that the baby was doing well,
Right.
but the placenta was affected. There was no question about it. So that placenta was not perfusing as much as it should have. We don't know why exactly.
Right.
Perinatologist or not, nobody knows.
Right. But you do know that if it's 50% abrupted, it's perfusing less than if it had not been abrupted. True.
That's true.
You agree placental abruption is a medical emergency requiring prompt delivery, true?
We discussed that this morning,
Yes, sir.
and we agreed that it was true partially.
Okay.
It depends on the degree of abruption.
You agree that as a physician, you have a responsibility to recognize an acute emergency, true?
True.
You agree that placental abruption is used to describe the group of clinical signs and symptoms associated with profuse vaginal bleeding, severe abdominal pain, 10 out of 10, and the diagnosis of placental abruption is primarily a clinical one based on the signs and symptoms observed by you, the physician, true?
Object compound, yep.
Same objection.
The answer.
Yes, I thought we went through that this morning.
I think mostly we did. I think we've already marked this. Show you what was previously marked as Plaintiff's Exhibit number 4. You reviewed that before your deposition here today?
Yes, sir.
That's the board order, is that right?
Yes, which I was told by the board, as a matter of fact, that that was not really any reason for an order.
Okay.
But apparently they didn't nullify this document because you have copies.
All right.
And according to Mr. Lane, which is the legal counsel for the board, he told me, Gabe, that's not a reason for this. I said,
Okay.
well, you take care of them. See, I'll take care of them.
Okay.
Well, they never did. This is about
Dr.
a
Nasser?
fine.
Wait for a question.
I
So
answer.
there are 2 orders. The first one, public consent order dated March 06, is that right?
That's the one I was referring
This
to.
had something to do with a payment issue, is that right, of about $4,000?
Yes, sir.
And what is that? Tell you what. What does that have to do with?
That was a case that I had, and they settled it.
Yes, sir. A case.
The insurance company settled it.
Okay.
I didn't have nothing to do with settling. And
Do you remember the
they
name?
wanted to ask me, why did I settle? I said, I didn't settle, but the company says that I didn't have the right to refuse settlement.
Okay.
And that was it. So we got into words, okay,
Right.
with a guy that was heading the committee. And it got nasty, and the guy got disgusted, and he issued a fine. And then I said, I'll pay, I'll send him $1,000, and then I didn't even send anymore.
All right.
Because I think it was unfair, but that doesn't have anything to do, and then they wrote me that.
Did you remember the name of the case, that case? Did it involve life cycle?
Now,
Did it involve Southfield Medical Center?
probably because that's the place where I had practice.
Okay.
you remember what
but
year?
I don't remember exactly the case.
Okay.
I don't even remember what year was that. What year was this?
Looks like it's 2006, but it's got a finding of
This is
facts.
4 years later.
It says on or about May 6, 2004, respondent, I think that's talking about you.
Probably around
Have a
2002.
consent order. Okay. Would
So
that,
I end up paying him.
okay. Yeah, what are you gonna do?
I'm not saying I
And-
didn't want to lose my license.
And that was in Fulton State Court, was that case, you know? Was that in Fulton County?
Yeah.
Okay. Do you remember the name of your lawyer in that case?
This case?
Yes, sir.
No,
Or did
this
you-
never went to court.
Okay, the underlying case that was settled without your consent.
No, there was no, I don't know any of that.
Okay.
All I know is that the insurance people wrote me a letter saying that they were going to settle this case, that they have made a good arrangement with the patient, and that I have no right of refusal, I think is the term. So I called my lawyer and asked him, and says, you have no right of refusal. I said, okay, that's it. What can you do?
Yes, sir. And there's a second board order, Plaintiff's Exhibit 4. This is,
You're back in the record at 4:27 p.m.
Dr. Nasser, my name's Kim Woodland. I introduced myself a little bit earlier. I'm going to give you a copy of the paper that was the notice for your deposition here today. And the reason for that is I'm just going to go through and tell you who I represent, okay? So let me show you. This is the notice of deposition that Mr. Potts sent out. And if you'll see up there at the top, under the V, it lists all of the defendants. And I'm going to just tell you who I represent. I represent Alandria Willis, who is an OB tech. Do you remember Miss Willis?
You said you represent who?
Yes, if you'll start, it's about halfway down. The name Alandria Willis, OBT.
Yeah, I remember it.
Do you remember Miss Willis? Is that a yes?
Yes,
Okay.
yes, that is correct.
Okay.
Yes.
I represent Zador, it's spelled Zadori, but it's Zadorsi Blassingame, who's a respiratory therapist. Do you remember Mr. Blassingame? Is that a yes?
Dr. Nasser?
Dr. Nasser.
You have to answer verbally, or it's not on the record?
No, I was reading, I'm sorry.
That's okay. Well, here,
just didn't hear you,
okay.
which
Yes, ma'am,
You do remember Mr. Blassingame?
yes.
Okay, all right. The next person I represent is Sarah Posley, who was a neonatal nurse practitioner. Do you remember Miss Posley?
Vaguely.
Okay. I also represent Charlotte Rodriguez, who was a
Yes,
registered.
very well known, I remember.
Okay. And well known for what? What was Miss Rodriguez well known for?
She was one of the head nurses in labor and delivery.
Okay. Do you remember Joy Alexander?
Yes,
Okay. Then the next person I represent is Nancy Young, also a nurse. Do you remember Miss Young?
yes.
Okay. And then I represent Tenant South Fulton, doing business as South Fulton Medical Center. In other words, the hospital that was known as South Fulton Medical Center. Okay?
Do I remember that
And I
one?
imagine you remember them. Okay. I'm going to be going back through some of the material that Mr. Potts asked you about, either to clarify some of what you said or to follow up on it. I'm going to be jumping around a little bit in terms of the topic area, so just bear with me. I'm going to try to move through it as quickly as I can. And it's very hard. Earlier I made an objection. It is very hard for Steve, our court reporter, to get us both down when we're both talking. I know that's the way we talk in normal conversation. So if I interrupt you, you need to let me know that. And likewise, if you'll just let me finish my question before you start to answer, because otherwise the transcript is just he, the, and it's just very difficult to read. Okay? Okay. A couple of things. Prior to today, have you ever met with or talked to Mr. Potts about Miss Bohannon or your care and treatment of Miss Bohannon?
No, only with my lawyer.
Okay, all right. Mr. Potts asked you some questions about your opinion about the cause of the baby's death. And as I understand what you said, Ms. Bohannon had chronic issues going on with her placenta, correct?
Yes, ma'am.
Okay, and that was because she had chronic hypertension, correct?
Correct.
And she had insulin-dependent diabetes mellitus, right?
Correct.
And she also had advanced maternal age.
That's correct.
And all of those conditions meant that the placenta was not perfusing as well as it should throughout the course of the pregnancy, right?
True.
And that was manifested by the fact that the baby had intrauterine growth retardation and was small for gestational age, correct?
True.
And all of that had been going on in the pregnancy prior to June 27th of 2011, correct?
Yes, that is correct.
All right, in other words, sort of in lay people's terms, it wasn't really a very well-functioning placenta throughout the pregnancy. True?
That's well put.
Okay. I understood from some of the questions that Mr. Potts asked you that when you finished your training, both your residency training and your fellowship training at Emory in 1970, you went into private practice, right?
That is correct.
Okay, and when you went into private practice, Dr. Nasser, at what hospitals did you get privileges?
I got privileges at South Fulton Medical, Georgia Baptist Medical Center,
Okay.
Crawford Dublin Long Hospital,
Okay.
Doctors Hospital. or
Doctor's
something.
Hospital out near North Lake, the old Doctor's Hospital out there?
No, Ray was across from Crawford Long.
Okay, all right.
I don't remember of any. Oh, Southern Regional,
Okay.
until I realized that I was just one human being and I cannot take care of patients in 5 different places.
Okay.
So I stayed in one hospital.
And that was primarily South Fulton?
That's
Okay. In, Mr. Potts asked you some questions about the board orders that were marked as Plaintiff's Exhibit 4. And let me ask you, at the time of the board order in 1983, do you remember where you had privileges?
South Fulton Medical Center. And yeah, I have, before then, I have quit going to the other places.
So in 1983, do you think you just had privileges at South Fulton, or did you have privileges at Grady at that time as well?
I don't know if I know that I was an attending at Grady, but I am not 100% sure if at this date I still was there or not.
I'm just going to show you your,
Sure. Do you have it on the CV?
yeah, on the
Okay.
CV.
Okay,
Which
perfect.
is probably in that stack. but-
Okay, let me ask you, if you will, it's a good thing we left the exhibits there, Dr. Nasser, if you'll look at the exhibit that was marked as your CV. I think it was
Yes, it
numbered-
is. I was looking at it. This is not a complete CV, as a matter of fact. Yeah, I emailed it to you.
okay.
And I don't know why,
Well,
but
that's
this
okay.
is not up to date.
you know
Anyway,
what,
it doesn't,
Will? That's
you're not
okay.
missing anything.
Okay,
Well-
well, let's look at the CV. And if you'll turn over to, it looks like it's the 3rd page. It says hospital appointments. Down towards the bottom. See where I am? And take a moment and just look through all of that and tell me if there's anything that you think you need to update or correct about your hospital appointments. In other words, are there any you need to add to?
No.
Okay, so looking through this then, at the time of the 1983 board order, you were an attending on the active staff at South Fulton Medical Center, right? Need to say yes.
Yes, ma'am.
Okay, sir. And if I have to remind you to say yes, I'm not harassing you. It's
Thank you,
just-
ma'am.
It's just I know you
Appreciate
need to
that
say
very
it.
much.
Okay. All right, if you'll turn over to the next page. Then it has Grady Memorial Hospital, Obstetrics and Gynecology Faculty, 1972, and a dash, and then there's no closing date. So is it true that you've been on the staff at Grady since 1972 to present?
I am on the staff
Gotcha.
now.
Okay. Next one that's entered here is Crawford W. Long Memorial Hospital, and it shows that you were on the active staff from January 1971 to September 1987, right?
Mm-hmm.
Need to say yes.
Yes, ma'am.
Okay. Then,
Only the answer is yes.
then Georgia Baptist Hospital, you were on the active staff from July 1972 to August 1987, right?
I think so.
Okay. So at the time this board order was issued in 1983, Dr. Nasser, you were on the active medical staff of South Fulton Medical Center, Grady, Crawford Long, and Georgia Baptist, correct, sir?
That's what I said, I think so.
Okay.
Because I don't know these dates now in comparison.
I appreciate that.
Because I did quit the other hospitals before this order, way before this order,
Okay.
which I had privilege on these other people from 69 or 70 through whenever I quit.
I appreciate you quit some of them, but we can assume that the information you've put in your CV about the dates is true and correct to the best of your knowledge, true?
To the best of my knowledge,
Okay.
yes.
All right. So when the board order was issued in 1983, you were on, to the best of your recollection and knowledge, you were on the staffs, the active medical staffs of South Fulton, Grady, Crawford Long, and Georgia Baptist.
No, I don't think so.
Okay.
I was, at the time, with South Fulton Medical Center and Grady as an attending.
So do you think you had,
AMC's downtown?
AMC is the campus?
Yeah, it's the main, Georgia Baptist.
Yes, sir.
No, I was not with Georgia Baptist then.
Okay, so on this CV, do you think the date that is shown as the last date you were at Georgia Baptist, August of 1987, isn't correct?
Yes, let's see. Where is Georgia Baptist here? It's not Georgia Baptist.
Right here.
Oh, this says 72 to 87. No, I don't think this is right.
Okay. Do you have any papers in your possession that show when you left the staffs? What dates you left the staffs at various hospitals?
It still was Georgia Baptist.
Yes.
So that must have been late 70s.
I will represent to you that I think it was Georgia Baptist later than the 70s. It was
Yeah.
Georgia Baptist, yes, sir, until
Well,
probably the 90s.
He was Georgia Baptist when I resigned.
Okay.
Actually, the Baptist privilege that I had was just to train residents.
Okay. Well,
And so I didn't really, I never admitted a patient there or
okay.
anything.
Well, let me ask you the question. What? Okay.
Objection.
Are you his
Doctor,
lawyer?
you have an opportunity to finish
James,
answering.
James.
Hold on, now listen.
No.
Okay,
Well,
okay.
This is.
Okay,
I
James,
object.
you're
lying.
No, she's interrupting. She can't interrupt a witness. I mean, it doesn't matter, period. I object, you're interrupting the witness, and I want a complete answer.
Okay, let's
You,
put,
you keep cutting him off.
well,
and-
I
and
would
object on
disagree.
that
Okay,
basis.
I would disagree. Dr. Nasser is well-educated enough and forceful enough to tell me, and if I cut you off, as I told you earlier, you tell me, okay? Mr. Potts, I'm gonna put on the record, is not your lawyer
Can
here.
ask anything you want, lady.
All right, thank you, sir. Let me ask this question then. When you resigned from Georgia Baptist, did it have anything to do with the 1983 board order?
No.
Did Georgia Baptist make you resign because of the 1983 board
No,
order?
I never been asked to resign from anything.
Okay, then let me just clarify then, with Crawford Long, whatever date you resigned from Crawford Long, did it have anything to do with the board order?
Nothing. Not,
Okay. And Crawford Long never told you you had to leave because of the board order, true?
No. I'm telling you, the only hospital that I was at the time of this was South Fulton.
Yes, sir.
And they hire their own legal people to look into that.
Okay,
And they were the ones that cleared me.
okay. And
And I didn't ask for any of them.
no, I appreciate that. And for example, like at Grady, where you were on staff, Grady's never made you leave the staff because of the board order, has it?
No, I'll be tomorrow afternoon at Grady.
Okay. When you were taking care of Miss Bohannon in 2011, you were on the staff at Grady then as well?
Who's this?
In 2011,
Yes.
when you took care of Miss Bohannon.
Oh,
the
Miss Bohannon,
Yeah, the
yes.
plaintiff in this case, you were also on the staff at Grady.
Yes, ma'am.
And were you delivering babies there?
Yes.
Okay, and were you also doing surgeries like OB and GYN surgeries at Grady in 2011?
That is correct,
Okay.
yes.
And I believe you had told Mr. Potts that you largely spent your career at South Fulton from 1970, when you went into private practice, until the labor and delivery unit closed in 2012, right?
I'm still on the staff there doing surgery.
Yes, sir. In fact, you've continued to do your GYN surgeries down there.
Yes, ma'am.
Okay. And I think you had told Mr. Potts that if a family member had to go to the hospital, you would send them to South Fulton.
My last child was born there.
Okay.
My wife had a hysterectomy there. I had my last hospitalization there recently, 4 or 5 years ago,
Okay.
because I had an allergic reaction. It stuck me in the intensive care unit.
Sorry to hear that. Well, certainly with regard to your OB patients like Miss Bohannon, you would not have planned to deliver her there if you thought the care was unsafe.
No, Ms. Bohannon was planned to be delivered at wherever she wanted to show, okay? This was not a very reliable human being to choose plan surgery or anything besides. I wasn't planning to do surgery on her. But no, we never had the chance to even discuss site of delivery.
Okay.
Because she came in 4 weeks ahead.
Okay. But certainly if you had felt that it wasn't safe for her to deliver at South Fulton, you would have told
She
her
would
that.
not end up at Grady, you bet on that.
Okay. I don't know that Mr. Potts asked you this. Dr. Nasser, what is your address in Sandy Springs, your physical house address?
Hearst Ferry Road, 1115.
1115 Herds Ferry. Okay. And do you have any sense of how long it takes you to commute from your, well, strike that. Was that where you were living in 2011, June 2011?
Since 1972.
Gotcha. And do you have any sense of how long it takes you to travel?
There's 25 miles from the door of my garage to the parking lot of South Fulton Doctor's parking lot.
Okay. And appreciating that these events were taking place in the middle of the night, do you have any sense or recollection of how long it took you physically to drive once you got in your car from your house down to South Fulton?
Well, there is about 7 or 8 miles that are surface road, and the rest are expressway.
Okay.
A dead doctor on a expressway is of no help for any patient. So I don't drive 100 miles an hour.
Sure.
I drive 70 the most. It takes me 30 minutes,
Okay.
32 minutes,
right.
35 minutes at most.
Okay.
It all depends how much police is on the road too, because
Okay.
doctors cannot speed up anymore, you know that.
Sure. For example, just you said about 7 to 8 miles is surface road. When you turn off of Herds Ferry, what's like the main road you get on? When you come like out of the subdivision where you live and you turn off of Herds Ferry, what main surface road do you take to get to the expressway?
If it is at night, I take 285.
Gotcha.
If it's during the day, since most of my early hours are at Grady, I have to take 75.
Gotcha. So in this case, you would have gone around 285?
285.
And then come back up to Cleveland?
166
Okay.
to Delo Drive, to Norman Berry,
Gotcha.
to South Fulton.
Okay. Mr. Potts asked you some questions about your understanding about why the labor and delivery unit at South Fulton was closed in 2012. And you had referenced that the area around the hospital had undergone changes in terms of businesses that had privately insured patients and the neighborhoods themselves. Did you understand that the majority of the patients who were coming to South Fulton for care in the 2010, 2011 timeframe were largely either Medicaid or Medicare patients?
That's what I said.
Okay. And your understanding is that the federal government was, or the state, in the case of Medicaid, was cutting the reimbursements it would give hospitals for patients who were either Medicaid or Medicare, correct?
Correct.
So in that situation, it would be difficult if the reimbursement rates were coming down for a hospital to cover the cost of actually providing the care, true?
That's exactly what I said this morning.
Okay, and so the reason that you understood that was given for closing the unit was that the hospital was losing money on the labor and
That's what
delivery
they told
person.
us.
Okay. Dr. Nasser, at any point since this 1983 board order was entered and you served your probation, did the medical board ever take away your medical license?
Not before nor after.
Okay, and as of today, you have a valid medical license to practice in the state of Georgia?
Yes, ma'am.
And in 2011, you had a valid medical license to practice in the state of Georgia, correct?
Of course.
Okay. I wanted to clarify something, Dr. Nasser, that was a little unclear to me. Did you review all of Ms. Bohannon's medical records from South Fulton?
Unfortunately, yes.
Okay, because I understand that Plaintiff's Exhibit 2 is just a couple pages from
Missing.
one of those visits. But you actually were provided the records from all of her visits to South Fulton?
Yes.
Okay, all right. So, let me ask you, I'm going to ask you some questions about this June 22nd through 23rd visit. That's the one where she went in for observation for a period of time?
Yes, ma'am.
Okay. And from your review of the records, did you understand that Charlotte Rodriguez was the nurse who was evaluating
I
Ms.
do.
Bohannon? And what was your overall impression of Ms. Rodriguez's nursing abilities?
Ms. Rodriguez didn't work for me.
Okay.
Worked for the hospital.
Okay.
And she carried orders
Okay.
away.
All right. And did you have any concerns about when you saw that she was the nurse who cared for her on June, cared for Miss Bohannon? Did you have any concerns about her how about Miss?
She answered my questions and gave me the results of the test that I ordered, and I made my decision and said, since she's doing so well, she can go home.
Okay. You had told Mr. Potts that insofar as a tracing on an electronic fetal monitor, the patient's body habitus can affect whether you can get a good tracing, correct?
I did that.
Okay. Do you have any recollection, having described Miss Bohannon as obese, where most of her body habitus was? Was it like in the front, on the sides? Some people carry it all in the front, some people carry it on the sides. You can answer.
I don't want to get in trouble with
No,
patients
I
telling
know.
them.
Okay,
She was obese.
okay,
She was not massively obese, but she was 220 some pounds.
I think you had told Mr. Potts that her body mass index was
39.
39 or something. Okay, all right. And can the size of the baby, like if the baby is small, can that also affect your ability to get a good tracing?
A good tracing is known to be difficult to obtain on below 32 weeks of gestation,
Okay.
especially for variability. But we can get tracings. I mean, you take a person of your habitus, you'll be an excellent subject for it because the transmission is direct.
Okay. If the baby is has intrauterine growth retardation or is small for gestational age, even if over 32 weeks, can that make it more complicated to get a tracing?
Here, I think the difficulty here was a combination between the habitus and the tumors on the uterus.
Okay. And those are the leiomyomas that you've encountered?
That is correct,
Okay, okay. All right. And appreciating you did not come in to evaluate Ms. Bohannon at the time based on the information you've had, you've since had a chance to look at the tracing that was obtained during that hospitalization.
Yes, I did.
Okay, all right. And go back to that. I wanted to clarify a couple of things that you had told Mr. Potts in response. Excuse me for reaching. One second.
No problem.
And it has to do with the last page, page 216, the interpretation.
Right.
And do I understand from what you were telling Mr. Potts that that is a computer-generated interpretation?
You don't have the tracing available to sign this, because at South Fulton, they had a special thing where they have the tracings stored different than the medical records, and that was never part of the medical records. They kept it separate. I do not know if that was changed or not, but it makes sense, because when you have, let's say, an 8-hour labor recording, you're talking about several miles of paper, okay? So that's why they kept it separate from the records, and that's why it wasn't available also to.
Okay, well, that's what I wanted to clarify. When you made that, what we're calling the interpretation, which is page 216, what did you have available to you to enter that?
What she has told me in mine. She told me that night the tracing. She told me it was a reassuring tracing, that there was a now and then blip, and then that's where I came out with the variable.
Okay.
She said the variability was very good.
Okay. Let me ask you, if you will, for me then, Dr. Nasser, to look at the tracing that starts on page 1, because I was sitting far down the table and I couldn't see exactly what it was that you were pointing to when you were talking to Mr. Potts about it. But beginning on page 1 and then going over to page 2, I believe this is where you pointed out that there were some spikes that suggested a heart rate up above 180, but there was nothing to indicate that this was a sustained tachycardia. True?
That is correct.
All right, sir. So can we even call this tachycardia, given that it's not even connected, or is this artifact?
You can lose this page because you haven't lost anything.
Gotcha. Okay. So going over then to page 3, where you actually begin to have a connected tracing.
That's a good tracing. Yeah.
Okay. Would you call this a category 1?
Yeah.
Okay. Going over to page 4, then continuing on to page 5 and page 6, would you agree we can't really call anything on these pages because the monitor's not picking up, true?
Correct.
Okay.
You've done your homework.
Okay. Going over to page 7 then, I believe this is the page where you said there was the only variable decel. And just so I'm clear for the record, up at the top, there are these panel numbers.
I know, I remember that.
So it's between panel 12216 and 12217, correct?
Mm-hmm.
Okay, just need to say yes for me.
Yes, ma'am.
Okay, and based on your review of this strip since, you don't see any other variable decelerations on this strip, do you, sir?
That's it.
Okay. Do you see any evidence of a sustained contraction pattern on the TOCO printout?
No, ma'am.
Okay, so is there anything to suggest that during this hospitalization that Ms. Bohannon was in preterm labor?
No, ma'am. There's no evidence that this lady, she wasn't even complaining of that either.
Okay, and so based on reviewing the strip at this point in time, Dr. Nasser, it was appropriate that Ms. Bohannon was sent home. True?
Supposedly, with instructions.
Okay. And there was nothing based on this tracing to indicate that the baby was in any kind of distress?
No, not that I can tell.
Okay. And nothing, again, based on your having the chance to look at it after the fact to suggest that you needed to come in and assess the patient personally, true?
No, that is correct.
Okay. All right. I wanted to ask you, you had answered some questions from Mr. Potts about sort of centralized timekeeping, and I wanted to make sure I understood what that was about. Are you talking
I
about?
became an engineer. Okay,
Are you-
centralized.
Are you talking about the concept that all the clocks in the hospital are synchronized?
Exactly.
Gotcha. Okay. So at South Fulton, for example, like the night of the delivery, when you went into Miss Bohannon's room or you went into the OR, do you remember there being clocks in those rooms?
Some working, some not.
Okay. In the OR, all right.
Never works.
Okay. Then who is keeping time? The
That's
circulator?
exactly what I was trying to say today without having to put the blame on anybody because I don't know.
Okay.
Okay? I'm just making an observation. I'm not accusing anybody nor ducking my responsibility of anything.
Okay.
But you can't have things happening without using time. You know, you need like if you, let me explain this, okay? And not meaning any criticism, but at 1:15, there's a lot of stuff that happened in that record. Now, I want to know, how could that lady take care of all that stuff and not move the minutes? They all happen at 1:15.
Okay, well, we'll walk through the records themselves, but do you have, for example, do you wear a wristwatch?
Yes, ma'am.
Okay, when you went to do the C-section that night on June 27, 2011, were you wearing a watch?
Was waiting to watch, and I used the time for my note
Yes,
out
sir.
of my watch.
Okay, so the time that you noted on your progress note of 0219 was from your watch, correct?
That is correct.
Okay, thereafter, with regard to.
My operative note
let
was
her-
out.
Let her finish her question, just
Oh,
so it,
okay, I'm sorry.
just so that it's clear
I
on the
just
record.
Right.
meant to complete the
No,
answer.
well, and I want you to complete it, and like I said, if I cut you off, I want you to tell me that. So, anything else that you remember timing from your watch?
My post-operative note
Okay,
and my orders, they are timed with my wristwatch.
okay. So, let's make sure we've got that in the record then. Is that the set of records that he was using that has the numbers on it, Melissa?
Yes.
So we can clarify that, okay. Okay, why don't we go to, start with page 35,
Which is.
because that's his progress, admission, brief note. Okay. You've got in front of you, Dr. Nasser, the document that's marked SFMC0035, that is your admission brief note, that is dated June 27, 2011, timed at 0219, correct?
Correct.
And that's one that you timed from your personal wristwatch?
That is correct.
Okay. Then I believe you also said your post-op order, so if you'll turn over to page 27, it's going to be an MD orders. There's an MD order that says add 20 units Pitocin to
The 505 is mine.
Okay, so that one as well, and anything else that you remember timing from your personal wristwatch?
Yes, ma'am.
Yes, sir, tell me what that is.
Go to page 032.
Okay. Okay, your C-section delivery physician orders?
That's post-op orders.
Okay,
Also my wristwatch.
okay,
My PCA, which is 029.
your pain
I
control
think.
orders?
Yeah,
Let's find
PCA
those.
orders,
Let's find those.
029.
Okay. And those are also timed at 0400, right? Okay,
And the admit orders at 219.
okay, and so
That
that's
is my
the,
wristwatch.
okay, and that's page,
This is just a formality.
yes, sir, and that's
This
page,
is a repetition of the original orders
Okay.
here, but in
Gotcha.
the format,
And that's on what, page 28?
page 28.
okay. So, just to clarify then, your progress note and admission orders, which are on pages 35 and 28 respectively, you timed yourself from your wristwatch at 0219.
I didn't say admission orders.
I'm looking at these routine admission orders on
Oh,
page 28.
this,
Yes,
that
sir.
one, yeah.
Gotcha.
But the other one has a different time.
Yes,
It
sir.
happens at 1:52,
Yes, sir.
which I wasn't there.
Now, I appreciate that. The orders at page 27, up at the top, that are timed at 01:15, was a telephone order from you that was written by
That
nurse-
is copied here,
Yes, sir.
and this time is mine.
Gotcha. And so the time on page 28 of 0400 was from your wristwatch.
That's correct.
Gotcha. Okay. So, all right. Mr. Potts asked you some questions. Well, strike that. Before we get off the question of clocks, does Grady have central synchronization does Grady Hospital have central synchronization of the clocks?
I think so, but I don't think so.
Okay.
Okay, I don't think so because now that you bring that up, I have fixed the clocks in the operating room
Okay.
and in the clinic because I'm really paranoid about seeing clocks that are not straight or they're not working, and most of the time it's a lack of battery or something.
Okay.
And so, no, they don't have. Now, there are some clocks synchronized, like in the main operating room, they have all synchronized, cardiac surgery and all that stuff.
Okay. In the ORs at South Fulton, the labor and delivery ORs, were there any other pieces of equipment that had clocks on them, like the anesthesia machine?
I don't know if an anesthesia machine has part of the equipment a clock.
Okay. All right.
Since they run all kinds of money towards in the anesthesia, it's possible that they have a time-in.
Okay. Mr. Potts had asked you some questions about the guideline of the 30-minute decision to incision. Do you remember him asking you some questions
That's
about that?
American College of Obstetrician-Gynecologist.
Right, and as you indicated, it's a guideline, correct?
That is correct.
Not an ironclad rule.
No.
Okay. Now, I believe, and correct me if I'm wrong.
Objection, I don't believe anyone cited to any of the ironclad rules. Do you have a citation for any of the
I don't need one.
ironclad? I'm sorry,
I don't need one.
I'm not.
I'm asking the
I'm
doctor
just
what his
asking
opinions
you
are.
Whether you have a citation for any of the ironclad rules portion of ACOG or ironclad rules portion of
What's your
the
objection?
statute or any
Okay.
other citation.
Let's
for the
move on.
ironclad rules. Is that a no?
I don't have to
Well,
answer your
I-
questions. I'm not under
I
oath here
object.
today. If you have an objection, note it and we'll move on.
I object any reference to the quote ironclad rules, close quote.
Okay.
And inasmuch as there are no such rules either in the American College of Gynecology or anywhere else in medicine.
Okay. You had indicated, I thought, in response to one of Mr. Potts' questions, Dr. Nasser, that sometimes you couldn't meet that 30-minute decision to incision guideline at South Fulton. Was that simply because of what was going on with the patient, or was it that there was something else at South Fulton?
Object to form the question, it's an improper compound question.
Yeah, can you make it a
Sure.
couple of 2-3 questions?
Sure, be happy to. Was there, for example, like in this case, more than 30 minutes passed between the decision to do the C-section and the incision, and we'll come back to that. But were there any structural issues at the hospital, like the OR was too far down the hallway, or that you were referring to when you answered Mr. Potts' questions?
Object to the form of that question, that's also an improper compound question.
You can answer.
Drop it.
All right.
No.
Not drop it?
You can't get into peer review, I'll tell you that. But I mean, is it something that,
There is not a single, to answer your question, there is not a single thing that can be pointed at. We have done studies in many hospitals, including South Fulton, looking for the cause of delay of incision after call. And sometimes we're the same patients, you know. But see, if you have a scheduled C-section, it doesn't matter.
right,
But this rule of the 30 minutes is only to apply to emergencies.
right. Okay.
And as a guideline, 30 minutes is good if you have a good team.
Okay.
But if you have a team that is not very experienced, you're never gonna get on 30 minutes.
Okay. You would agree that Dr. Ketchy was an experienced anesthesiologist?
Yes, I think so.
Okay. Who else do you remember being present in the OR during Miss Bohannon's C-section?
There was from people from NICU.
Okay.
There was the nurse that was supposed to assess on what's the name of that? They got a special title. Anyway, the one that takes care of everything that is needed at the time of surgery.
The circulator?
She's supposed to place the patient on the table. She's supposed to perhaps is supposed to locate the patient correctly, tie it up with a belt,
Okay.
put the compression devices, etc., etc., etc.
Okay. And we can look at your OR note or any of that, or the op note, but do you have an independent memory of who that person was in this case? Who was doing those jobs?
All I have the independent memory telling me is that I have to prep the patient if I wanted to move faster.
Okay. All right. What did you personally do to prep the patient? What did you personally do to prep the patient?
I went and grabbed my prep solution and prepped the belly with DuraPrep.
Okay. Okay. Let's look at the OR records. It's at page 91.
Is it anesthesia?
No, yeah, I've got it under OR records, page 91. I don't know if you put it under like his op report or.
Yeah, that's what I was thinking, probably.
91.
Check here. Sorry, I'm gonna give you a paper.
That was 71.
Looks like
Yeah.
this.
I think I
Got it?
Yeah.
It's the intraoperative record. Got it in front of you, Dr. Nasser?
Yes, I have it in front of me, ma'am.
Yes, okay. About halfway down under personnel, it lists who was present, and it says anesthesiologist Dr. Ketchy, surgeon Dr. Nasser, neonatologist Sarah Posey. It should be Posley. Do you remember Miss Posley being in the room?
Yes.
Can you describe her physically?
She's, Miss Posey is a medium build, black lady.
Had you had deliveries where she was present before?
She doesn't work for me
No.
or for labor and delivery. She works for NICU.
No, I appreciate that. My question was, had you had deliveries before where she was present during the delivery or afterwards to take care of the baby?
Probably,
Okay. Others in the OR were listed as Francis Aguirre, RN, and Zadorsi Blassingame, RT. Do you see that?
yeah.
And had you worked with Miss Aguirre before?
Aguirre.
And when I say
No,
worked, I don't mean you
I
employed
don't
her.
recognize that.
Okay, can you bring up a mental picture of what Miss Aguirre looks like?
No, that's what I'm saying.
Okay. All right. Mr. Blassingame, do you have a mental image of what he looks like?
No. Miss
Okay.
Newton, yes, and Miss Willis, too.
Okay. Miss Newton, what is your mental image of what she looks like?
She's a slim young lady. She was the one that was taking care of the patient to begin with. That's the one that passes on as a circulator in OR,
Okay, do you remember if she was Caucasian or African American or Asian?
Afro-American.
Okay. Do you have any information as you sit here today about where Miss Newton went to nursing school? Need to say no, if that's a no.
No, I'm sorry.
That's okay. Do you have any information as you sit here today about where Miss Newton had worked insofar as hospitals, offices, before she was at South Fulton?
Don't have any knowledge of her background.
Okay, so you don't know how long she'd been a labor and delivery nurse as of the time of these events?
Nope.
Okay. Do you have any recollection of having been, of her taking care of any of your patients prior to this evening?
Probably yes.
Okay.
Now, she worked nights,
Yes, sir.
okay? And I don't work nights.
Okay. Do you have any memory of how long Miss Newton had been at South Fulton in labor and delivery prior to June 27th, 2011?
Anything that I tell you on that respect is a lie. I don't have.
Don't know. Okay, fair enough. All right. The next person who was identified on this intraoperative record, Dr. Nasser, as a scrub tech is Alandria Willis. Do you have a mental picture of her?
Oh, Gary, you say that?
Willis, under scrub tech.
Oh, Willis, the
Yes,
scrub
sir.
tech.
Yes, do you
Yeah.
have any memory of her, mental image
Yeah.
of her?
She scrubbed several times with me.
Okay. And,
And she's, that matter of fact, she's good.
okay. And African American, Caucasian?
Afro-American.
Okay. Female?
Female.
Female, okay. Remember anything about her build? Short, tall?
Medium.
Medium, okay. And you had worked with her before and thought she was a good scrub tech? Need to say yes for him.
Yes, ma'am.
Okay.
I had worked with
Okay.
her before.
And thought she was a good scrub tech?
She's a scrub tech, yeah.
Okay, all right. Do you have any criticisms about her abilities based on anything you'd observed before?
Well, she knew what to do.
Okay. Okay. Let's turn to the events of the night of June 27th, when you talked to Miss Newton on the phone. And why don't you find the labor and delivery flow sheets for him, Melissa?
Which one are we
Starting with page 125.
Okay, that's okay. Let's try to finish this.
My outline's not as long as his was.
That's not all outlined there.
Okay. All right. And you have, the first document you have in front of you is Maternal Review of Systems. That's from page 125 to 127. And then you have the labor and delivery flow sheets that start at page 128. I'm going to be asking you some questions. When you get a call from a nurse, what I first want to find out about is sort of your general habits. You've been a doctor a long time, taking care of a lot of labor and delivery patients. When a nurse calls you to report on a patient, do you have sort of a set of information that you want to find out about that? Let's just say it's a labor patient who's come in. Is there sort of a set of information you want to know the answers to?
Are you relating to this information or information that the nurses place on computer? Or?
No, just generally, and we'll talk about Ms. Bohannon specifically, but a lot of times physicians have certain kinds of information they want to know about the patient. What's her gestational age? What's the status of her cervical exam? What are her vital signs? What are her chief complaint? How long has she been there? What have you done for her? Is there any kind of general set of information you want to get from the nurse when a nurse calls you about a patient?
She's supposed to give you that information without being asked for.
Okay. If the nurse, for example, doesn't give you a piece of that information, is it your routine to ask for it?
Yes, ma'am. That's
Okay.
exactly what happened here.
Okay. Moving then to the night of June 27th, 2011, it sounds like from what you've conveyed that you weren't expecting Miss Bohannon to show up at the hospital, true?
No, I had no idea.
Okay, all right.
She never called before. It's the only way that I would have known.
Okay, so she didn't, for example, call Life Cycle to report that she had problems with bleeding or anything and was on the way to the hospital, true?
That is correct.
Okay. So the first knowledge you had that she was at the hospital was when you got the call in the morning, early morning hours of the 27th from the nurse, correct?
At the magic hour.
I'm sorry?
At the magic hour of
1:15.
1:15.
Okay. And at the magic hour of 1:15, you were at home in bed?
Yes,
Okay. What do you keep your phone, like by your bedside or?
that's correct.
Okay. Were you the physician on call that evening, Dr. Nasser, for Life Cycle, or was?
I told her that if she ever needed anything to call me directly.
Okay, so assuming she conveyed that information to the nurse knew to call you as opposed to the Life Cycle on-call physician, correct?
That is correct.
Okay. When you got the call from the nurse based on the information that she conveyed to you, you told Mr. Potts that you knew there was a placental abruption. Is that correct?
At what time?
When the nurse called you at 1:15, based on the information she conveyed to you,
It sounds like a placental abruption.
you thought it sounded like a placental abruption. This is where I'm a little unclear. At that point in time, at 1:15, when you are sort of getting this information to yourself and you're thinking it sounds like a placental abruption, did you make the absolute decision at that point you were going to do a C-section, or did you just suspect you might have to do one?
I told this young lady that I wanted the OR ready.
Yes, sir.
That was clear what I was gonna do.
Okay, so at 1:15, you had decided for sure that you were going to do a C-section.
You cannot call the C-section order until you can write it, okay?
Okay.
But you can ask to have the operating room ready. So when you walk in, you said, C-section, now.
Okay.
And
Well,
they
that's
should supposed to move.
okay. Well, this is where maybe the language we're using is a little different, because I'm talking about making a decision, appreciating you can't get there and see the patient for a period of time. That's what I'm trying to find out. Is it that you suspected you were going to have to do a C-section when you got the call at 1:15, but you needed to see the patient and make the final call? Or had you made the final call at 1:15, I'm going to do a C-section?
Object to the form of the question, that's been asked and answered repeatedly.
You can answer it again.
Dr. Nasser's already answered that question several times.
You can answer.
You
It's
can
not
answer.
enough answer for you, huh?
Well, the problem, Dr. Nasser, is words like suspected, called, planned. So here's what I just, in your words, at 1:15, what had you decided about a C-section?
Object to the form of the question, that's been asked and answered
can answer it again.
repeatedly. Just because you don't like the answer you get doesn't mean you get to keep asking the
Well,
same
you've asked him
question
the same question
over
multiple
and
times,
over
James.
and over
And you know what?
again.
I get to ask
Also, I
questions too.
appreciate you interrupting me, but
Okay, go ahead.
that's that malignant.
Okay.
Look, I don't think it's fair. Now, you're talking about making a decision.
Yes, sir.
Do you think it's right to make a decision for patient without seeing the patient?
That's what I'm trying to elicit.
I'm asking a question now.
Well, unfortunately,
you can't.
I don't get to, I'm
So-
not under oath.
So the term is unfair.
Okay, well,
Okay.
then you tell me, because,
Objection, I don't think Dr. Nasser was finished answering the question.
Dr. Nasser, if I cut you off.
When I
you tell
spoke
me.
to her, I said I want an operating room
Yes, sir.
ready. That means that I have a pretty good idea of what was gonna happen. When I walk in there, and for example, I saw Dr. Ketchy, I told him, let me check it out, but I'm sure that this is gonna happen.
Okay,
And then I said, C-section. Then I wrote the order.
gotcha. Because I appreciate you need to come in and personally see the patient.
I hate to say that because I know that my questions are not answered.
Okay, okay, okay. So then at 1:15, when you talked to Miss Newton on the phone, you had a pretty good idea you were going to go ahead and do a C-section.
Objection asked and answered repeatedly.
Yes, I did.
Okay. Do you have any memory of how long the phone call with Miss Newton lasted at 1:15?
It was more than 1 minute,
Okay,
that's for sure, but
Okay.
there's no record of that.
okay,
And number one. And number two, you know, I have to wait on the telephone for her to give me answers. So I don't know how long it took.
right,
She says 1:15, 1:15.
okay. Well, obviously, you asked her to do a vaginal exam, and she had to do that, correct?
Mm-hmm.
You need to say
She
yes.
should have done that.
Okay. And her records indicate that she did, because she charted what she at least felt was the result of the vaginal exam,
That's
correct?
correct.
Okay, all right. When you come into the hospital and you have a patient where they've started a record on them, is there any part of the record that you routinely review for yourself? I mean, for example, do you look at the labor and delivery flow sheets?
This is not going to be ready, so you cannot look at that.
Okay,
The best communication you have is your nurse. And she will tell you contractions are this or that, fetal heart tones are this, that. And usually everything is passed on in a very brief manner.
okay,
And the better the nurse, the more accurate everything is.
okay.
So based on that, then you assess your patient, examining yourself and making up your mind as to what you're going to do next.
Okay. Do you routinely look at the electronic fetal monitor?
Yes.
To see, and appreciating there may not be a paper printout, but you have the ability on the monitor to go back in time and look at what's happened before you've arrived, right?
That's correct.
Okay. When you were talking to Ms. Newton on the phone at 1:15, did you ask her what the patient's vital signs were, if she didn't tell you?
Did I ask one?
Did you ask Miss Newton, because you told Mr. Potts the nurse didn't tell you what Miss Bohannon's heart rate was. Did you ask her what the heart rate was or any of the other vital signs?
Yes, I asked her all that information. She told me that she had some variables.
Okay,
And that no decelerations. That was very clear.
okay,
She told me about the bleeding. I don't recall she mentioning anything about pain, even though she's written differently.
okay.
And then I asked her the pelvic. Oh, I haven't done that. Well, go ahead and I hold.
Okay,
So she did. Once she gave me that, I said, okay, I'm on the way. Get me an operating room ready.
okay,
And that was it.
okay. Did you at any point during that conversation ask her about Miss Bohannon's vital signs? What her
Objection.
May I finish? What her temperature was, heart rate, anything of that nature?
Objection, that question has already been asked and answered repeatedly.
I don't believe it has, but if it has, it's been a long day, Dr. Nassar. Did you ask Miss Newton what Miss Bohannon's vital signs were in the 1:15 call?
Same objection, that question's been asked and answered repeatedly.
A minute ago, I answered the same question differently, right? Which I said that a good nurse will give you your information without asking.
I appreciate that. My question's the converse, which is,
And
did you
now
ask
I
her?
will answer that question with an addition to it. It says, if it's not mentioned, it's because it's normal. So you go to the positive findings.
Okay,
That puts you on a situation that you might be assuming that what she hasn't said, it was normal.
okay.
But
And a
It might
patient,
not.
Objection, I object again to Ms. Woodland cutting off the witness. Dr. Nasser was in the midst of speaking, I believe that was like mid-syllable. You interrupted him yet again. I would object and ask that the witness be allowed to finish answering the question.
I would note for the,
Object.
are you finished? Just tell me when you're
No,
finished.
I'll be finished when you stop and let Dr. Nasser finish his answer.
Have anything else you want to add? Now?
I don't think so.
Okay, I would note for the record, you are not Dr. Nassar's counsel. His counsel is sitting here to his
I
left.
think
May
all
may I
2,
finish
4,
now?
6, 8, 10 of us know that I don't represent Dr.
Okay,
Nasser.
good. Well,
I still have a right to hear the answer to the question, and I have a right to an uninterrupted answer. I mean, I'm entitled to an answer to the question just like everyone else in this room is.
Okay.
Just because I don't represent Dr. Nasser doesn't mean that
I don't have that.
doesn't mean that
I have the right to
you're
represent.
entitled to cut him off.
Dr. Nasser, let me just tell you, I don't mean to cut you off. Sometimes when you stop, I think you've finished. And if you're not finished, just please tell me, because I really want to get it here on the record, everything you have to say. Okay?
I'm really, I want to cooperate
I know you. And
every way
Steve,
possible.
Okay.
Would you read back where Dr. Nasser was when
Sure.
Ms. Woodland interrupted him? Thank you.
So how many months how many months do I have to block out my schedule for the trial? This was a 2-hour deposition.
Well, mine might be 2 hours. I don't know about his.
Yours, yeah. So far.
My stomach's gonna start growling.
Tried to find just exactly where that was.
I'm all right.
You won't know. You won't have to worry about traffic on the way home. You won't have to worry about traffic on the way home.
Look on the bright
You know,
side.
The silver lining.
Last time I was here, I don't know how, I made a wrong turn somewhere here, and I ended up on Piedmont.
Oh.
I got
Okay,
home
you said
about
it
7:30.
depends on the situation that you may be assuming.
Heavy.
You may be assuming,
I'm sorry.
and I thought he said that
It's
they're.
not mentioned because it's not normal, so you go. It's not mentioned, it's not normal, so you go to the positive timings. You said, okay. It says it depends on the situation that you might be assuming. That what she hasn't said. And you said inpatient, he said might not, and then Jim objected.
Okay. We'll read back the last question okay, and I'll rephrase it.
Okay.
Okay, I'll answer that
Well,
again.
let me get him to read the question back, and I'll
Back
restate
before
it.
his answer.
Before the answer, Mr. Potts is objecting, I cut him off. I'll read that question.
Okay.
That wasn't intentional.
You didn't kick me.
Did you at any point during that conversation ask her about Ms. Bohannon's vital signs?
I thought he'd answered that one.
Okay, what about that?
You know what, in the interest of time, why don't I just, I'll rephrase it.
Okay.
Okay, why don't we start from
No,
there?
I don't,
I'm sorry.
Okay.
he's entitled to finish answering his question.
Well-
I want a complete answer to his question.
Well, we can't ascertain what the question is the problem. My question was, did you ask Ms. Newton what Ms. Bohannon's vital signs were in the 1:15 phone call?
and I answered
Yes, sir, I believe you did.
that usually the report includes the positive findings under the assumption that that's the way that we are supposed to report, as well as reporting anything out of the usual that they have observed, like vaginal bleeding in this case, which she did. The problem is the presumption. Is she telling me the positives and what she's missing is because it's normal and she just do that, or simply because she didn't say anything about it and then you don't know if it's normal or abnormal. But you have to trust your nurse.
Okay. I don't want to cut you off. Anything else?
You
Okay,
have to trust somebody.
okay. In a patient who,
Don't trust you.
in a patient where you believe they have a placental abruption like Miss Bohannon that night, do you have any expectations about what their heart rate's going to be if they are bleeding?
Yes, I expect it to be a little bit above 90, okay? But I wasn't expecting a paroxysmal attack, okay?
I'm sorry, you weren't expecting what?
190, 195,
Okay.
200. Cardiac arrest.
Well, we can agree Miss Bohannon was not in cardiac arrest, true?
That is correct, not
Okay.
even near.
Okay, all right. Now, when you arrived at, we'll just say around 2:19, since that's when you timed your note. Do you have page 35 for him, his progress note? Oops. Got that in front of you, sir?
Yes, I
Okay,
guess so.
okay, all right. Then this is your admission brief note that you timed from your watch at 02:19, right?
That is correct.
Okay, and, well, to find the line it's on. About halfway down, it's the line that starts with VS. See where I am?
45.
And it says, if I'm reading this correctly, vital signs on admission showing maternal TAC 134, blood pressure 130/65, afebrile, denies severe pain, having contractions every 3 minutes, abdomen obese, uterus palpable with no tetany. Did I read down to that area correct?
That is 100% correct.
Okay, all right. And so when you came in and noted in your note at 02:19 that her vital signs on admission were showing maternal TAC of 134, blood pressure of 130/65, and that she was febrile, do you remember what it was you were looking at to come up with that information, Dr. Nasser? In other words, were you looking like at the Dynamap or the monitor strips where they may have recorded the vital signs?
Well, you know, when you look at the monitor will give you all those. And probably was a memory picture of it. Or that I was lucky enough that I have one of the little papers with the information that I gather for my notes.
And when you say...
I can't remember what I did there.
Okay. When you say the monitor, are you referring like to a Dynamap monitor or to the electronic fetal monitor?
Electronic fetal monitor.
Okay, because the electronic fetal monitor has a readout that will give
All
you
that.
all that as well. Okay. And because as I understand from what you told Mr. Potts, the first thing when you did when you arrived is you went straight into Miss Bohannon's room, correct?
Yeah, the first thing I did was look at that.
Okay. And so the first thing you did when you came into her room is you noted what the vital signs were that were showing on the monitor?
Well, you know, if you notice here, I actually pointed at 3 things,
Yes, sir.
which is the pulse or heart rate,
Yes, sir.
the blood pressure, and I did that because I know that she's a chronic hypertensive. All right? And so I wanted to know how the cardiovascular situation is, as any doctor will.
Right.
Now, the afebrile is the point that I accepted, and this is why you don't see a figure here, because it says afebrile, because I never heard the patient had temperature. We brought that up in the deposition way back, that the patient had 38.1 temperature, but nobody was made aware that she had that.
Think for a minute. So what was the basis of your statement then that she was afebrile? Did a nurse tell you that she was afebrile?
Well, see, okay, let me bring this up so it'll be more clear.
Yes, sir.
Temperature will increase the fetal heart rate. The higher the temperature, the higher the fetal heart rate, the less variability that you're going to be seeing on. And so it could be one of the confusing points as to why I'm not getting good variability or why isn't the baby having TAC. So this patient, I assumed that there was no reason for her to have fever, and 38 is not really anything septic enough to do that. But she was tachycardic, and that tachycardia can reflect onto the baby's fetal heart rate naturally. Now, the reason for her TAC could be, and I repeat again, A, the anxiety that she had, the hyperventilation she had, anguish or anxiety, whatever you want to. She is in a hostile environment, in a hospital, she's bleeding, etc., etc. But 140 some is a little bit. Now 134, I go along. That's what I have here because that's the figure I got. You can have different figures, but the one I got when I walked there was 134.
Okay, and the fact that she had a heart rate of 134, did that cause you to want to speed up matters at all?
Okay, there are things that you have control
Yes, sir.
to speed up, and there are things that you have no control whatsoever to speed it up. So I speed up everything that I can control.
And I appreciate that, and what I'm just asking is in her clinical picture, is the heart rate of 134 an indication that you need to do, do it faster?
All I need is to get that baby out.
Okay. With regard to the temperature of the 38.1 centigrade, I understand you gave her prophylactic antibiotics before you started the C-section, correct?
Correct.
Okay. Is the 38.1 degree centigrade temperature a clinical sign or symptom to you of anything that was going on with Miss Bohannon?
No.
Okay.
And the post-op temperature chart can show you that there's no febrile curves.
Okay.
Could be like I said before, a little dehydration too,
The temperature.
with the blood loss, yeah.
Okay. And so with regard to the temperature, it never indicated to you, for example, that she might have chorioamnionitis, for example?
I knew you were driving there. No.
Okay.
The first thing of chorioamnionitis that I was aware of was on the pathology report, and the patient was already home by the time I got that.
Okay. Let's go back then in time, Dr. Nasser, and we'll come back to this note, so just hold on to that then. Going back to the phone call with Miss Newton at 1:15, we've talked about what you discussed with her. or what she told you about the patient's condition, and you told her to get the OR ready and told her you were en route, correct? Need to say yes.
Yes, ma'am,
Okay.
I'm sorry.
Is there anything else that you recall discussing with her in that phone call that we haven't already talked, excuse me, that we haven't
No.
already talked about? Okay. And as I believe you had told Mr. Potts earlier, when you arrived at the hospital, you saw Dr. Catchy.
Yeah, I saw he was
Okay.
next to her.
Okay. Once you got the phone call from Miss Newton at 1:15, I'd like you to describe for me exactly what you did between then and the time you arrived at the hospital.
Okay, I took my pajamas off. Well, first I stood up, took my pajamas off, and went and brushed my teeth,
Okay.
and go to my closet, got clean clothes, which I put on, and being the time, I knew I wasn't coming home that night.
Right.
It won't be until 6 o'clock the other day. So I needed to get clean clothes. And I jumped on my car and took off.
Okay. Do you have any recollection of what time it was you left your house?
No,
Okay.
I didn't check on that.
Okay.
Maybe I did, but I don't recall.
Okay. Do you have any recollection of encountering any traffic on the way to the hospital?
No, I don't have that
Okay.
recollection. No, I mean, there was no reason for me to really have recollection of a specific ride to the hospital.
No, and I appreciate that, but for example, if there'd been a major wreck on 285.
No, I
that
didn't
might
have any problems or anything that would make remember the trip,
Okay.
except until I got to the hospital.
And when you get to the hospital, do you park in that parking deck that's adjacent to the hospital and go in on the floor where the glass blocks entrance is?
That's correct.
Okay. And once you got into the hospital, you went straight to Miss Bohannon's room, right?
Yeah, you get on the elevator, goes
Right,
up to labor
okay,
and delivery.
all right.
Those days, we used to have this security,
Yes, sir.
and that will take you straight into labor and delivery.
Okay. And based on page 35, which you timed using your watch at 02:19, you had already been in to assess Miss Bohannon at that point, right?
Yeah, this is written after everything has been decided, and I was waiting to operate on the patient.
Okay.
And so I sat and write this. I
Okay.
said, there's nothing else I can do.
Okay. Did you write the note at 2:19? Or are you indicating that these are events that occurred at 2:19?
This I am indicating why I am in the hospital and the reasons that I found.
Appreciating that, but my question's a little different. Sometimes people will time they may write the note later, but they're timing it at the time of the events. Or they may put the actual time they're writing the note. So does this 2:19?
Yes, you are 100% correct. There is a lot of people that do that.
Okay, so does your 2:19 reflect the time you're writing?
That's when I am
Writing the note?
signing here.
Gotcha,
You say, if you sign it, you time it,
gotcha.
right?
Okay,
So you put that note there at the time that you finish your note.
okay. So when you went into Miss Bohannon's room, what's the first thing that you remember you did?
I look at the patient naturally. I look at the monitor, which is here. You know, you got a wide vision of what's going on. The patient is very close to the monitor, and you see everything that is happening. And naturally, she was there. I asked her, how you feel? Are you hurting bad? No, I'm not. Then I said, I'm going to examine you, see how far you are. We might need to do a cesarean section depending on what I find. I did a pelvic right there and then, and by the time that I got in her vagina, I said, we need to section. Then I told her briefly. I didn't give her a consultation of what a cesarean section implied. I said, we need to get this baby out. The only way I can do it is by the C-section, so we're rolling you to the hospital, to the OR. And that was it.
When you looked at the fetal monitor, did you page back to see what had been going on since she arrived?
Yeah, I did. I did look to the monitor to the point that I was there. And today we were discussing, and I said that I didn't see the advanced pieces of the until after I finished my surgery, when I read the whole thing. And that's when I said, well, I already signed this thing saying that it's tachycardia variable, and there is an ominous pattern here at the end, which I haven't seen. Then I said, no, don't doctor the report, leave it like that.
And I wanted to ask you about that because I obviously couldn't see over your shoulder with that, so I wasn't sure what pages you were referring to. If you could for me, Melissa, if you can find the strip, you might want to take it out so he can lay it out.
Is it in here? No, she means the one that's a different exhibit.
Yeah, it's not part of the exhibit. It's the one on the 27th.
Oh, I thought, okay, I thought you had made it in.
Here it is.
No, she's looking for the other.
Yeah, that's the exhibit.
That's the only thing we have
Is
here.
it in your folder?
I thought James did mark that as an exhibit.
I thought he did too, but I don't.
There's one in there that
Okay.
I'm aware.
This is plaintiff's exhibit 2, but this is the one from the 23rd of June.
Yeah, there's also marked the one from the 27th.
That's what I thought.
Hold on, let me see if it's in that stack then, right there. Hold on. No, it might be in this stack under my paper right here. Here it is. Okay. Okay.
Thank you, ma'am.
You're welcome, sir. I'm handing you what we've marked as plaintiff's exhibit, or what Mr. Potts marked as plaintiff's exhibit 6. And that is the strip from June 27th, 2011, right? And why don't you pull up?
115.
Why don't you pull up his, the labor and delivery flow sheets as well? Why don't we get those out? We'll just have them in front of it. It starts on page 128.
Those aren't exactly the same. Well, wait, are you gonna talk
Yeah.
about 128 first?
Well, I'm gonna talk about them together.
Right, I meant of these pages.
Yes, of those pages, 128 forward, Melissa. Got it? Okay.
Okay.
And you should have in front of you, Dr. Nassar, just so it's clear for the record, Plaintiff's Exhibit 6, which is a copy of the electronic fetal monitor strips from June 27th, 2011, correct?
That is correct, ma'am.
And we had also turned in your notebook to the labor delivery flow sheet that starts with page SFMC 0128. The first time on those flow sheets is at 0115, right?
This is 128.
Page 128.
Oh.
Yes,
Yeah.
that one.
Time.
Oh, yeah.
Starts at I'm sorry,
115, the
115 time. Okay, all
magic
right.
time.
Gotcha. Okay, what I want to do is, just for the record, and this is going to be obvious to you, but on a fetal monitor strip, and it's a little unclear on our copies because they've been copied, but there are darker black lines that mark off 1 minute of time, correct?
That is correct.
And each small block within those larger blocks represents 10-second increments, right?
Mhm.
You need to say yes for the court report.
Yes, ma'am.
So basically, you have 60 seconds or 1 minute between the darker black lines, correct?
That is correct.
Okay.
Yes, ma'am.
And so based on this strip, and also for the record, up in the top of the strip, there are notations that are entered that reflect various notes that are numbered on the bottom of the strip, correct?
Mm-hmm.
Okay, so for example, on this first page of the strip, which is marked SFMC 0150, there's a note number 1 that says 6/27/11, 01/12 the time, and it indicates that the machine is getting started, correct?
That is correct.
Okay, and then down here underneath the fetal monitor strip,
says 1.
you'll see the note. Okay, all right. So this is the beginning of the strip that was run that was being run from the belts that were placed on Miss Bohannon that evening, correct?
I presume.
Okay, all right. And looking at this first part of the strip, say going over to about the end of page 2, how would you interpret those 2 pages of the strip?
You want me to interpret the 2 pages of it?
Starting with the fetal monitor.
Yeah, the
strip.
fetal
Yes, sir, on
monitor
the fetal
indicates baseline approximately 130 to 140. The variability is not bad. There is a deceleration here, which I will have to call it variable because I don't have any TOCO to work with.
Okay.
But if I was to accept this TOCO, I would call them still a variable.
And if you could,
But the same machine is telling me I am not working.
okay. Unfortunately, we had a little ring in the middle of that explanation, so I just want to go back. Where you say you had, where you would call the deceleration a variable, if you can just, I'm going to stand up and just show me which one it is. So you're at sort of at the end of the first page, roughly around 119 to 120 in the morning. Okay, all right,
Around 115.
okay.
He's kidding, he's kidding.
So if we start at 112, I just want to make sure, because as I understand it, and I don't mean to be pointing at you, Dr. Nasser, but the time that's recorded right here above the TOCO belt strip is the time on the monitor, right?
That is correct.
Okay, so the variable, as you're calling it, is roughly between, say, 119 and 120, correct?
That is correct.
Okay, and you were answering some questions for Mr. Potts about the TOCO belt. With a patient the size of Miss Bohannon, can it be difficult to monitor the contractions?
It could be,
Okay.
but this monitor wasn't touched whatsoever from the beginning
Okay.
on TOCO, okay? And it was ignored until, and naturally, we don't have time on this one.
Okay.
It was ignored until this KPA, which 129, 128, 127, about 125 or 6 when it was finally addressed.
Okay, and basically what you're talking about is they zero out the TOCO so that
Yeah.
it goes down to a 0 pressure, correct?
That is correct.
Okay, and once it was zeroed out, do you see any evidence of tetanic contractions?
Still won't work. And again, it was 0 out at 130, 1, 2, 3, 4, 5, 131 or
Okay.
so.
So, and it requires the nurse to actually physically zero it out, correct?
Mhm.
Need to say yes,
Yes.
sir.
Dr. Nasser?
Yes, ma'am, I'm
Okay,
sorry.
Okay, so the nurse zeroed it out at 125 to 126. She zeroed it out again at 131, approximately.
Approximately.
And do you have any opinion about why the TOCO monitor wasn't working?
No, it says here, the machine is telling us that it's inoperative.
Okay,
He begins to do that, and so the nurse play a game with it, and this time she set it up at a medium pace.
okay. And what time was,
that medium pace is not showing any activity on the TOCO. So was it recording? I don't think so.
and when is it that she set it at a medium pace?
Well, she set it, instead of bringing it down to 0 as it should be, this thing never came down from 30, 35. Okay?
Okay.
And this is from the beginning.
Okay, well then going back to your note at 0219.
We'll flip to it, okay?
Mm-hmm.
I need to move your arm just for a second.
Yeah, you can just keep that down. Why don't you put a pen or something in the notes uphill? There you go. Do you have your note in front of you?
Yes, ma'am.
Okay, in your note, you indicated that that the patient denied severe pain and was having contractions every 3 minutes. What was it that you were looking at on which to make that assessment?
This is what I found when I examined the patient. I brought that up before.
What I'm asking is, how did you determine that?
How?
Yes, sir.
When I placed my hand on the uterus and I felt the contractility and the duration of the contraction and what happened after the contraction ended. And I wrote it. He says, denies severe pain, having contractions Q3 minutes, abdomen is obese, but the uterus is palpable with no tetany. The fetal heart rate tracing showed tach and variable decels. The pelvic is so. Also, I wrote here that there was relaxation between contractions.
And so you were placing your hands on the patient's abdomen and timing the contractions and determining whether the uterus relaxed between those contractions. True?
Yes.
Okay. And based on that, you were able to determine that she was having contractions about every 3 minutes, correct? And also that she was relaxing, or that the uterine tone was relaxing between the contractions, correct?
That's exactly what I say here.
Right. And so that meant, in other words, there were no tetanic or long-lasting contractions, correct?
Not when I felt them.
Okay. If you'll flip back to the
Monitor?
both the monitor and also the nurse's notes. Looking over at like page 130, the nurse's notes. Okay. And do you see the entry at 0150?
150, yes, ma'am.
Okay. And going down under that, where the nurse was noting the uterine activity, where it says resting tone toco, she noted relaxed and entered an annotation that the uterus was palpating to soft after the contraction, correct?
That is correct.
So that would suggest to you that she likewise was putting her hands on Miss Bohannon's abdomen and assessing the contractions.
That's the only way to do it.
Yes, sir. And likewise again, at 0216, she made a similar notation that the uterus was palpating to soft after the contractions, correct?
I was reading something else. Yes, sir.
Okay, all right. Let me ask you then, we were going back to the fetal monitor strip beginning in that time frame of the first 2 pages. And so based on what you were assessing based on the fetal heart rate, what category of strip would you call this?
This is, I would say, a category 2.
In the first 2 pages?
And the 115, but this is not what the book says here.
Well, let me ask you to turn back to
Yeah.
the 115 note. And in the 115,
Oh, wait,
we're looking at page 128.
128 here.
Yeah. Okay, you look, I look at whatever you tell me.
Okay, okay.
Not
We're on
gonna
page
fight
1,
it.
South Fulton Medical Center 0128, and it's Miss Newton's note at 115. And under the description of the uterine activity, what category did she
2.
call it? Okay, so would you agree that in that time frame of 115, when it was first starting in these first
I
couple
don't
of
know,
pages?
I wasn't there, but what I saw, I thought it was a 2.
Okay,
But if you look at all the papers, tell you it's a 3.
well, we're gonna continue, but we can agree, can we not, Dr. Nasser, that when Miss Newton recorded at 0115, she called the strip a category 2?
2.
And you would agree that in these
That's what I
first-
would agree with that.
Okay, all right. Then, moving on to the next page of the strip, on page 3.
All right, here.
Okay. On the far left, Dr. Nasser, do you see this dark, really dark black line on the strip?
Yes, ma'am.
Okay, and what is your understanding of what that indicates?
I had no idea, I thought it was a printer thing.
Okay. Do you have any understanding that that sort of indicates that it's like a stop in the printing? Because if you look at the note up here, it says patient was transferred to the labor room.
Patients transferred to labor. Yes, I was very well aware of that transfer.
Okay. And so does that dark black line sort of suggest to you that the monitor stopped momentarily while they transfer and then it picks back up?
That's right.
Okay, all right. You weren't physically present at 01:30, correct?
Mhm.
That's correct?
That is correct,
Okay,
yes,
okay.
ma'am.
All right, so when the fetal monitor strip starts up again, and let's see if we can agree on the time. I'm sort of having to backtrack. If note number 1 is at 1:30, 31, at approximately 01:32, when the strip starts back up, throughout the rest of the page 3, what would you call the baseline?
A lousy recording.
Okay,
There's not really anything that you can come up with a conclusion there.
okay,
The TOCO is not operative, and this is very interrupted to make an idea of what's going on.
okay,
But that is because of the transfer.
okay. Hold on, bear with me for a second. Okay. Moving on then to the next page of the strip, page 4. Okay. On this page, it looks like we're running from roughly 01:38 to 01:46, correct?
Answer out loud. Dr. Nasser.
That is correct, ma'am.
I'm sorry. And on this page of the strip, and if you want to do it panel by panel, starting over on the left, which is the earlier time, are you able to interpret the strip?
That was a decent tracing for, I would say, 6-7 minutes. And then we lost the real transmission good. But I see that there is stack all of a sudden at the end of 1, 2, 3 minutes.
Okay. And
when you go to the next page, you will see that the TAC is at 160, 170, and topping to 180.
okay.
And it's continuing for 1, 2, 3, 4, 10, and then drops from 170 down to 140.
Okay. Well, let's take it page by page then, Dr. Nasser. Going back to page 4. In the first 6 to 7 minutes of that page, can you establish a baseline?
Okay. We start then with good variability at a rate of 150 baseline. And it continued it's hard to make here the divisions. 6 minutes.
Okay.
Then that's when the TAC begins.
Okay. And in that 6-minute segment before the TAC begins, what would you call that by category? Category 1, 2, or 3?
I would tend to call that a 1.
Okay. And then when the TAC begins, and let's try to establish a time if we can on page 4, and I'm going to back up from this last time right up here, Dr. Nasser, up here at the time where it says 1:46. So 1:45, 1:44, 1:43. Does it look like it's approximately 1:43 a.m. when the TAC starts?
That is correct.
Okay. And when the tachycardia begins, what category would you call it?
This is a 2. Immediately becomes a 2. And they begin to combine with variables. Assuming they are variables because we don't have contraction to prove that they are in relation to the contraction or post-contraction.
Okay, and if you would for me, first on page 4, can you identify any variables on that page?
Yes.
Why don't we do this? Is that marked as an exhibit?
Yes.
Okay, let's do this, since that was marked as James. Why don't we make another one, and I'll mark a defendant one. Do you have any colored pens?
I
Like
can get one. I don't have it in here.
I need like a red or something,
What do you need?
like a red pen.
Here's a red pen.
There we go, thank you. Okay, we got
One right there.
You know what
Okay.
we're gonna do, Dr. Nasser, let's just take a short break. I'm gonna get her to make me another copy of this, because
Okay.
I can't have you mark on Mr. Potts' exhibit. So I'll make a copy of this and have you just mark the variables so everybody can see what we're talking about.
Everybody want to take a break for a minute?
6:05 p.m. We are back on the record at 6:14 p.m.
Okay. Dr. Nasser, what we did in the break is we marked a set of the strip from June 27th as Defendants 1. And what I'm gonna ask you to do, why don't you take this red pen and go back to the first page, because you had told me that there was a variable on there, and just circle that with the red pen.
Just for the record, this is the same as Plaintiff's Exhibit 6, correct?
Yes. Okay. And then going on, we were on page 4, sir, and then, okay. And just moving forward. Okay. I don't need to stand up over you, I'm sorry.
I'm not worried.
Okay, we're on page 4. Okay. Can I, up to that point in time, can I see what you've marked so far? Can just see what you've
Yes,
done?
ma'am.
Okay, so,
For the record, he's not finished marking.
no, but I'm gonna have him
So
finish
he's-
marking it, but we've
yeah,
gotten to
finish
page
answering
4.
his question.
Up on page 1, you circled in red what you believe to be a variable, correct?
That's what you are.
Yes, sir. Okay. Just want to clarify, because on the record,
Page 2 the same?
and then you put.
Oh, I'm sorry,
That's okay.
I see.
Page 2, you circled what you believe to be a variable, then in the middle of the page, you have a question mark, and what does that question mark indicate? Is that a?
That question mark indicates that there's nothing you can do even though you have a top and a bottom of a wave, but no continuity, so you don't know if it was just an interruption of the, and then a drop, and it does that.
Okay. And so that-
Same there,
Gotcha. And so that's the same then over here on page 3, correct?
that's correct.
Okay, all right. Then over on page 4, you had drawn a red line, and then you wrote under it, what does that say?
So type 1 or 2.
Type, and meaning it's a category 1 or 2?
Yeah.
Gotcha. And then on the far right, you
The
then.
stack.
Gotcha. Okay, then why don't you continue
They
on?
remain stacked.
Okay.
We'll turn them around as we need to.
Here, ma'am.
Yes, sir. Okay. All right. Okay, we were on page 4 of this exhibit, and in the far left, just to clarify your comment, under that stretch where you drew the red line, you indicated that's a Category 1 strip, correct?
Category 1, reduce, really non-diagnostic it is.
Okay.
But if I have to take one route, I'll use the little piece that is available.
Okay. Then on the far right where you wrote the word
This is
TAC.
TAC.
Okay. Did it become a Category?
Tachycardia.
Did it,
The fetal heart rate has gone up to 180.
okay, does it become a Category 3 at that point?
Nope.
Okay.
At this point, all you know is that there is a transient tag, but we don't know what's going to happen after. See, the problem is we playing Monday morning quarterback here
Yes, sir.
because we have everything already in the hand. But when you were watching this happening, you didn't know what was going to happen the next minute.
Okay.
So we have to find that here it continued in a better way, though. See, the variability is not changed. The D cells are not anymore there as here, except for one time. And we'll see what happened on the next.
Okay, then we're now on page 5, would you still call this what category would you call that strip?
That I will start thinking in a 2 to 3 because of the cells. Now,
Okay.
here we have now typical 3.
Okay,
Okay? Because we have here, even though we don't have a trace that will spell it out, you can see here what's going to happen here.
okay,
The future will be
okay.
there.
So let me ask you then, using this, however we need to put it together, let's go back to the labor and delivery flow sheet, which you have in front of you. At 1:45 a.m., which is time-wise on page 4 of this.
Up here.
Well, I'm just to ask the question. On page 4 of the strip is where the time 01:45 is, and you had indicated tachycardia, correct?
Yeah.
Okay. If you'll look at the nurse's note for that.
Let's call it 3.
Okay. If she called it a 3, would you disagree with her, or is she overcalling it?
Well, she can call her anything. She's been calling here everything that she wants to call.
Okay.
Whether it was or not, we don't know.
Okay. Well, based on your interpretation of the strip, do you think it's a Category 3 at 01:45?
145, I don't have enough information in this piece to be called a class, a 3.
Okay. So, well, of the categories, the worst it can be is a Category 3, correct?
Let's don't talk about that.
Okay.
This is already going into a 3, yeah.
Okay. Well, I appreciate on page 6 of the exhibit, down here at roughly 2 o'clock on, you've called it a Category 3, correct?
And for the record, he pointed at page 5 when he just testified about Category 3, not page 6.
Well, let me just clarify for the record then. On the exhibit where you wrote in Category 3, you wrote it on page 6 around approximately 2 a.m.
Here, from here on.
Okay, so why don't you
And
indicate?
for the record, he pointed at the far left of page 5 of Defendant's Exhibit 1.
And James, if you will, I'll try, I'm gonna have him write it on here so it'll be clear to all of us. Okay, why don't you write on the strip where you think it became a Category 3 if before this time on page 6? So when do you think on this it became a Category 3?
This is interpretable. You cannot interpret this thing here. Right here.
Okay, so based on your interpretation of the strip, you believe it became a Category
Around this area, yeah.
3 on page 5 at approximately, make sure I've got it right, Dr. Nasser, 154, maybe around approximately 151.
Let me see the tack here, please,
Yes, sir.
excuse me. I'm sorry. Take that back. Here.
Okay. Okay, so let me look at the time then. 50. If I'm counting back correctly, using the time down here at the bottom of 150, so approximately between 148 and 149, it became category 3, based on your
I've got
interpretation.
here 180.
Yes, sir. I don't want to confuse, because when you refer to 180, you're referring to the heart rate. Let's make sure we've clarified the time. Based on your interpretation of the
okay.
strip, you believe it became a category 3 at approximately 1:48 to 1:49 a.m. in the morning, correct?
Whatever.
Okay, well, I want
That's
you,
what it says there.
okay, well, time-wise, do you agree with me that you've marked it around 1:48 to 1:49 a.m.? Gotcha. Okay. Looking at page 5, and we'll take page 4 away from you. Looking at page 5, how would you describe the variability? Minimal, moderate, or marked?
Minimal.
Minimal. Okay, can you establish what the baseline is? Okay, so going back then, looking at the nurse's
Just so,
notes.
I'm just gonna read that so it's clear to them,
For the
Oh,
record,
okay.
for the record, that he has written.
180,
Okay, that's fine.
minimal variability.
Okay, so on page 5, when I asked you about baseline and variability, you believe the baseline was 180 beats per minute and it had minimal variability, correct?
That is correct.
Okay, so let's go back and look at Nurse Newton's note around 145, which is on page 129. Come back one. And she started down at the bottom here, Dr. Nasser. And she noted at 145 that the baseline rate was 170 with tachycardia, minimal variability, and called it a category 3, correct?
That's what he called.
Okay, and do you have any criticism of her for calling it a category 3 at 145?
Criticism. What is 145 here? You guys had played with my brain so much today. This is not fair, you know? I mean,
Okay.
this game is worse than cards.
Okay, 145 is
Wait.
on page 4. Got it?
145 is, she's not a 3 here because this is not a trace that can be interpreted,
Okay,
all right? That's the only reason why I say no.
okay.
Right.
But you agree, based on your
That
own...
from here on, I agree.
Okay, all right. So if you'll continue on with her notes at 150, and that's on page 130, you would see that she noted that she called the baseline rate of 175 with tachycardia, minimal variability, and called it a category 3, correct?
And what page is that?
I'm sorry, sir, it's page 130, South Fulton Medical Center 0130.
130, yeah.
At 0150 in her labor and delivery flow sheet, she noted under the fetal assessment that it was a fetal heart rate baseline of 175 with tachycardia, minimal variability, variable deceleration in category 3, correct?
Yes, that's
And-
correct. I
and-
agree with that.
Okay. And then let's continue on.
From then on, all of them are gonna be category 3, okay?
Okay.
But I didn't agree with this thing was that at 115 was category 3.
Well, she didn't call it a category 3 at
She
115.
did in other parts.
Okay, can you show me what parts those are?
No, you find it out and I'll tell you.
Well, I will tell you in her note at page 150, page
This is
128.
2.
She calls it a category 2, right?
Right.
Can you,
But there's other places where she had called that 3.
at 115? Okay, well, I would like you to
It's
find
not-
that for me, if you will, please,
Really
sir.
not on my business, but I guess it might become my business someday. I'm not judging anybody here, okay? I'm based on paper.
Yeah, and
But look at this, 145 is on 3, all of this. Where is the other one, 115? He was on 3. We discussed it today already.
Sorry.
There's so many events at 115 that this is what it makes me uneasy. Maybe I was wrong. Maybe I didn't read right.
Well, the earlier testimony is on the record.
Yeah.
Well,
I
I
mean-
appreciate it, but I would like him, if he believes it's recorded in the chart, I'd like him to show me where it is.
I
As to-
can't find that category 3 at 115 anymore. I read it again and I see category 2.
Okay.
So I might have misread.
Okay.
That's what happened. I was misreading this thing because there's 2 columns of times here. I'm
Okay.
sorry.
That's okay. Well, let's go back then to the strip, and now we are on page 7, and you had written in red decels. Can you, just using the red pen, circle for me what you believe to be the decels?
Decel.
Yes, sir, just on that page. And on this page, is it still a category 3 tracing? Is that a yes?
That is a yes, yes,
Okay.
ma'am.
All right, sir. And on page 7, how would you describe the variability, Dr. Nasser? Okay, and
What-
you've written MV for minimal variability, right?
That's correct.
And can you describe the baseline on page 7?
No, nobody asked me to.
Well,
Yes,
she
good
just
now.
did.
Where would you kid? Okay. And what I'd like to do, Dr. Nasser, is go up to about the time when the nurse indicated that you were present at bedside, and that was at 02:16, and it's note number 2. You see that right here?
Here.
Yes, sir. And the nurse noted in her note that she noted you were present at bedside at 02:16 in her notes, correct?
Uh-huh.
And then also on the strip, on page SFMC 0157, there's a note, Dr. Nasser at bedside. It's note number 2, correct?
That is correct.
Okay, so that note is right here, just to point it out to you, on page 8 of the strip, which is SFMC 0157. Okay. When you came in that, early that morning, according to the nurse's time of 02:16, would you have looked back through all the pages of Defendant's Exhibit 1 on the monitor from the time it had started?
There were 2 pages that I've only seen today, so I know that I didn't see those. But I saw what I call at the time Category 2, that much of it. But I didn't see, as I explained earlier, from page 4 or 5 until after the C-section.
Well, let me ask you this. Do the monitors at South Fulton have the ability where you could page back through on the machine, not the paper, but where you could page back digitally through the machine and see the strips?
I don't know how much software they had installed in those computers, you know. We were handicapped on some of the software. I don't know how back can you go to look at tracings. That is something I don't know.
Well, when you arrived, what did you look at? A paper strip?
Yes.
Or on the machine?
Paper strip, that was the only thing that was available at that time.
So you're saying the paper strip that had printed out up to the time you arrived was not available for you to look at?
Yeah, but too late, you know. When I look at 4 or something, the whole event was over, and now I had the paper to look at that reads that this thing ended at 4:37, which is a big lie.
Well, here's my question for you, Dr. Nasser, and we'll get to the time it ended. Okay, when you arrived at the hospital at approximately 2:16, what I want to find out is what you looked at. Did you look at the digital readout on the monitor, or did you look at a paper strip?
I look at the strip, the real strip on the monitor, the pink strip on a white base paper
Okay.
with the red lines in.
Okay,
Right.
so you looked at the paper strip. what
I
call-
looked at the real strip.
Okay, and the strip prints out as it's coming, for
Yes.
example, like when it started at 1:15, it would be printing at 1:15, 1:20, 1:25,
That is
correct?
correct.
Okay, so when you arrived at 2:16, had the strip printed out up to the time of approximately 2:16?
Yes, ma'am.
Okay, so if we had the paper strip printing out up to the time of approximately 2:16 when you arrived, were you able to look at that paper strip up to the time you arrived?
That is correct.
Okay, all right. Okay. And so if you looked at the paper strip that had printed out, hold on, let's find the pages. Let's see this, please, I'm sorry. So if we can agree time-wise, the times that would have passed before you arrived at 2:16 would have been recorded on page 1 of Defendant's 1, page 2, page 3, page 4, page 5, page 6, page 7, and up to approximately half of page 8, correct?
That's what I marked.
Okay, all right. So that, at least that part of the paper strip up to the time you arrived would have been available to you, correct?
Yes.
Okay, all right. Let's do this. Let's finish. Okay. I'm sorry, sir. I think we had finished, and just make sure, we had finished page 8, correct?
Seems like,
Okay.
unless you need something else.
Do you have any comments on the variability on page 8? Still minimal?
Yes, ma'am.
Okay, and what would you call the baseline? And again, for the record, you've written BL 180 for baseline 180 and MV for minimal variability, correct?
That is correct.
Okay, going on to page 9, you had made a couple of notes at approximately between notes 1 and 2, and is your upper note TAC for tachycardia?
Mhm.
Yes.
But as I said also, this is not interpretable.
That's what I was gonna ask you. What is this arrow down? What's that word to the right of that?
That is to say that the variability is down.
Okay, there's a little,
Excuse me, how much longer do you think you'll be?
probably at least an hour.
Okay, well, I'm gonna object to, first of all, there's a time limit per day for the witness, and, I don't,
That's your part of the depo, I get the same amount of time.
yeah, but not in the same day. You don't get to do,
Well.
30 hours just because there are 5 parties.
Well, appreciating that, James, I mean, I'm entitled to my cross-examination. I'm not limited. If you took the full 7, I still get to cross-examine him. So,
That's correct, but you don't get to do it until the wee hours of the night.
Well, I don't plan
would
to be
object
here
to it.
until
The
the wee
witness has
hours.
already said that, he's getting tired and
Oh,
confused. And
He has not said that he's getting tired and confused.
and
he
that's,
said it was more like a challenging card game or something akin to that.
Well.
So.
This is getting tricky, yeah. It's not any more straightforward. And I have to be honest and tell you, it's like if you were my enemy. That's how I'm taking you now.
no,
So-
sir,
so-
and
I mean, the hospital is gonna screw me, or they
Okay,
want me to
okay.
screw them.
There is no question on the table right now.
Well,
And
No, that's fine.
no, you know what, let's take a break, and no, we're gonna take a
I
break.
object to going forward. It's a 6:45, and Ms. Woodland has already said she's going to be another hour, notwithstanding the witness has already shared with her some issues he's having. We've been going since 10 o'clock. That's 10 to 7 will be 10 hours with less than an hour for lunch.
Okay, we're gonna,
Which is,
well, you can make all the objections you want, James. What I'm gonna note for the record, and Dr. Nassar, if I can explain to you, Mr. Potts represents
it's
the
not an
plaintiff.
explanation. If you have questions, you can ask questions.
You've been given an explanation,
No,
James.
no,
I'm entitled
I
to
ask
it.
questions.
Okay.
Ma'am, when you tell
Wait, no,
the truth,
stop.
it doesn't matter
Okay.
who asks a question.
No, I understand, and what I want to find out is, Mr. Potts, for example, didn't ask you about the strip. I just have some questions for you about your interpretation of the strip. I'm not here to be your enemy or anything like that, but under the rules of the court, I'm entitled to ask you
I
some
don't
follow-up
have
questions.
anything to hide.
And I appreciate that,
Don't
Dr.
wait
Nasser.
over
Okay,
and over
okay.
and over and
I
over.
appreciate that. Why don't y'all take a break?
gonna take a
Okay,
break.
It's up to y'all whether to continue.
Yep,
I'm trying to
we're
move through
gonna
it as fast as I can.
I understand.
And
We're
just so
gonna
everybody
discuss
knows, I'm gonna have some questions as well.
it. How long?
I hope 30 to 40 minutes, no more than that.
Okay,
All right, so, well, I object to going,
You can
till,
object. You
what,
can-
the 9, 10 o'clock at night.
Well,
I
you
think
can
it's
leave.
absurd and.
Yeah. James, you went from 10 till after 4 o'clock, okay? So is that absurd?
What, the third grade looks don't really.
I mean, I'm sorry.
What is this, Valley Girl time?
You know,
or
is it-
amateur hour? Yeah,
No.
I know what we're entitled to.
Right.
We're each entitled to time.
Correct.
That doesn't mean you can keep a witness here for 18 hours or
And I'm
even
not
12.
planning to, and
That's
it's not your
So-
deposition to call.
Yeah, but
It's just your job to be here.
Okay.
so
Go take
We're
a
gonna
break.
Actually,
take a break
It's
now.
not just my
Okay.
job to be here.
Let's go.
I have a job
Okay.
to do.
Your job to represent your client.
Correct.
Off the record at 6:43 PM.
I mean, if the witness may not,
back
witness
on
might
the
not
record.
want to come back for a deposition. He might prefer to finish it tonight rather than travel back here. So I assume that'll be discussed with his counsel. And
That's
certainly
right.
we'll be cooperative with what the witness and his attorney wants to do.
Well, I don't remember Miss Woodland suggesting, she would be cooperative or if the witness was tired,
Ms.
as he
Woodland's
suggested,
always
or
cooperative in my
confused, as he suggested that he was, that, we wouldn't keep going for another 2 hours, which is, what, 9 o'clock at night?
I don't think anybody wants to be here at 9 o'clock at night, but
Well, whether
You
you
have
want to
to.
be here, it's not fair to the witness. Yeah, that's fine, thanks.
Off the record, 6:44 PM. All right, we're back on the record.
Okay. This is Kim Woodland at approximately 6:53 PM on, what is today? May 12th? May
Yes.
12th, 2014. We are in the deposition of Dr. Gabriel Nasser, which was noticed by the plaintiff. The record will reflect the times that Mr. Potts took to question. I'm in the middle of my cross-examination of Dr. Nasser. Dr. Nasser is apparently not willing to go forward with the rest of the deposition. Do you want to put on the record, Melissa?
I'd be happy to. The deposition started at 10 o'clock this morning. well after 6 o'clock now, and Dr. Nasser is tired and feels like he's unable to give his best testimony at this point, and will reconvene at an additional time.
Yeah, and
Okay.
I want to add for the record, I didn't hear the witness say he was unwilling to go forward. In fact, I heard the witness maybe an hour ago. I have 5 till 7. Maybe an hour or so ago, he said something akin to he was getting tired and or confused, and he likened it to some, challenging card game.
The record's going to.
and- Go ahead, I'm sorry.
The record
So-
will reflect what he said, and I don't think those words are exactly what he said, but
Be that as it may, I'm just going to note for the record, it's being suspended over objection, and we'll convene at another time. I do want Dr. Nasser to understand that under the rules, I've got a longer period of time to continue,
understands.
and we'll pick up. I do not want him to review the transcript. I would ask the transcript not be transcribed, and then Dr. Nasser not be provided with a copy of it until we finish it.
okay.
Okay? All right, with that said, we'll suspend and continue at another time.
We're off the record.